here in the UK and around the world. Together, we're shaping the future of medicine. Today, the RCP represents and supports physicians in over 141 countries, championing excellence in internal medicine, medical education, and global health leadership. Over the next 3 days, 12 to 14 June 2026, this conference will deliver over 70 expert speakers from world-leading institutions, 10 comprehensive scientific sessions spanning the most critical areas of internal medicine, high-impact lectures, interactive panel discussions, and industrial symposiums, future-focused sessions on AI in medicine, medical education, and the future of healthcare, exclusive virtual networking, breakout rooms, and live Q&A sessions. This conference is CPD accredited and approved by the Federation of the Royal Colleges of Physicians of the United Kingdom for 16 Category 1 credits, organized by iSummit. Our 3-day scientific program is structured as follows. Day 1, June 12, 2026. Session 1, Gastroenterology and Hepatology, Gastroesophageal Reflux Disease, Metabolic Dysfunction-Associated Steatotic Liver Disease, and Abnormal Liver Function Tests. Session 2, Cancer Screening and Prevention, Oncology, Bowel Cancer Screening, Anemia, and HPV. Session 3, Respiratory Medicine, Chronic Obstructive Pulmonary Disease, 2026 Updates, Smoking Prevention, and Obstructive Sleep Apnea Management. Day 2, June 13th, 2026. Session 4, Neurology, Transient Ischemic Attack and Stroke, Stroke Mimics, and Peripheral Neuropathy. Session 5, Cardiovascular, Acute Coronary Syndrome, Dyslipidemia, and Hypertension Management. Session 6, AI and Medical Education, Future of Training, AI and Diagnostics, and Ethical Dimensions of AI in Medicine. Session 7, Rheumatology, Osteoporosis, Rheumatology Advances, and Autoimmune Disorders. Day 3, June 14th, 2026. Session 8, Diabetes Mellitus, Continuous Glucose Monitoring, Diabetic Kidney Disease, and New Treatment Algorithms. Session 9, Obesity, Guidelines in Obesity Management, Surgical and Medical Outcomes, and Lifestyle Medicine. Session 10, Social Media in Medicine, Role of Social Media in Healthcare, Professional Digital Presence, and Combating Medical Misinformation. Throughout all 3 days, we are also delighted to host exclusive Meet the RCP sessions, a unique opportunity for delegates to connect directly with RCP representatives, learn more about membership and fellowship pathways, and discover how the Royal College of Physicians can support your career development and professional growth on a global level. These sessions reflect the RCP's ongoing commitment to building lasting partnerships with physicians across the Middle East and beyond. The first RCP Global Update in Medicine was held in Dubai in 2025 and brought together an outstanding community of clinicians from across the region. The feedback was exceptional. Delegates praised the quality of speakers, the relevance of the content, and the collaborative spirit of the event, building platform for medical education and clinical excellence. We would like to take a moment to thank our sponsors and industry partners for their support of this program. Their commitment to advancing medical education and improving patient outcomes worldwide is deeply appreciated. Behind every great conference is an extraordinary team. We owe the scientific excellence of this program to our Conference Scientific Committee, whose vision, dedication, and tireless efforts have shaped every session, every speaker invitation, and every clinical topic you will explore over these 3 days. We extend our deepest gratitude and recognition to Dr. Emma Vaux, Consultant Nephrologist and General Physician, Global Vice President, Royal College of Physicians, RCP. Amy Prothero, Head of Global, Royal College of Physicians. Dr. Mohammed Bakit, Associate Global Director for Middle East and North Africa, RCP, Consultant in Diabetes, Endocrinology, and General Medicine, University Hospital Lewisham, London. Professor Laith Al-Rubai, Consultant Gastroenterologist and Hepatologist, Health Point Hospital, Abu Dhabi. Dr. Yanal Salam, Head and Consultant Internal Medicine, Emirates Hospital, Jumeirah, Dubai. Dr. Adil Sajwani, Deputy Medical Director and Consultant in Family Medicine at Mediclinic Parkview Hospital, Dubai. Your leadership, expertise, and passion for clinical excellence are the heart of this conference. On behalf of all participants, thank you. We also wish to warmly thank our entire faculty, over 70 distinguished speakers from the United Kingdom, the UAE, and international institutions, who have generously devoted their time and knowledge to prepare and present at this event. Your expertise is what makes this conference truly world-class. We are honored by your participation and grateful for your commitment to elevating medical education globally. This conference is proudly organized by iConference, a leading medical events organization dedicated to delivering high-quality, impactful continuing medical education across the region and beyond. We thank the iConference team for their exceptional professionalism and commitment in bringing this global virtual event to life. Ladies and gentlemen, the next 3 days promise to be a rich, inspiring, and clinically valuable experience. We encourage you to engage fully, ask questions, join the panel discussions, participate in the breakout sessions, and connect with your fellow colleagues from around the world. Let us begin. Welcome once again to the second RCP Global Update in Medicine 2026. To officially open our conference, we are honored to welcome a special opening address from the President of the Royal College of Physicians. Let us watch.
So hello and a very warm welcome to the second RCP update in Medicine Dubai. It's truly inspiring to bring together colleagues from across the UK and the UAE and around the world, a powerful reflection of the Royal College of Physicians' commitment to our global community and to advancing patient care through our shared knowledge. My sincere thanks to all of our organisers at iConference and to our local and our RCP clinical leads and our wonderful global team who have worked in collaboration to deliver such a high quality and forward-looking programme. My thanks also to our speakers whose contributions span key areas including AI in medicine, the future of medical education, and important advances in cardiometabolic disease, cancer prevention, and multidisciplinary care. I warmly encourage you to join me and my RCP colleagues at the Meet the RCP sessions and continue engaging with our global community. I wish you an inspiring and rewarding conference. I hope you have a fantastic time and look forward to seeing you all there. Thank you.
Thank you, everybody, for being with us for this amazing morning on the second day of the RCP. And I would likely and gladly open this session by introducing our moderators for today, Dr. Anas Massad. Dr. Anas Massad is a dual board certified consultant in critical care and internal medicine with more than 25 years experience in Jordan, the UAE, and Canada. A University of Toronto Critical Care Fellow. He now serves as an ICU consultant and acting HOD at Al Zahra Hospital, Dubai. We have also with us Dr. Devdat Nayak. Dr. Devdat, a senior consultant neurologist and head of neurology at Al Kuwaiti Hospital, EHS Sharjah. He is also an adjunct professor at the University of Sharjah. So please welcome with me Dr. Devdat and Dr. Anas. Welcome.
Thank you, Fahad, and thanks for the whole team for arranging this wonderful conference. And it's a great opportunity for us to be here. Our first speaker is Dr. Saad Kannan. He is a board-certified neurologist and also a fellow of headache medicine. He works as a consultant in Emirates Hospital, in Jumeirah. He has a lot of interest in stroke and migraine medicine. He has vast experience in dealing with all sorts of neurology cases. And I welcome him to give the first lecture on transient ischemic attack and stroke and early recognition and referral, because the last 5 years has changed in our management of these cases, including the definition of TIA. Dr. Saad, the floor is yours.
Thank you very much for the introduction, and thank you for the organizing committee for giving me this great opportunity to reach so many people, really, with this virtual event with audience from all across the world. So, as mentioned, I'll be talking about TIA and stroke, early recognition and referral. And the talk is mainly for non-neurologists, as specifically primary care as a survival guide to help you feel more comfortable dealing with these cases and know exactly what to do. Because when it happens, it feels very stressful, and everyone knows that every minute counts with stroke. 1.9 million neurons are lost per minute of untreated ischemia. So why this talk matters, and we have good data even from the UAE. So we know that stroke in the UAE strikes a decade earlier than it does in the West. And a lot of times, most of the time, primary care is at the front door for prevention and even for acute recognition. So the mean stroke age in the UAE is 55.7, whereas in the West, the stroke age is typically 65 to 75. And about a quarter of patients who present with stroke are less than 45 years old. And that sounds scary to anyone who's in their early 40s and feel like stroke is a disease of the elderly. It's no longer the case. And 90% of strokes are linked to modifiable risk factors. And here's a huge opportunity for primary care to make a big impact on these numbers. Of those modifiable risk factors, hypertension accounts for about half of those cases. So it's hard to talk about stroke without going back to our medical school days and looking at the circle of Willis. We have the anterior circulation, which starts with the carotid, and we have the posterior circulation that starts with the vertebrals. The anterior circulation with the carotid starts with the common carotid up to the internal carotid artery, terminating into a middle cerebral artery and an anterior cerebral artery. You have this posterior communicating artery, which after birth tends to shrink and does not really function. So it doesn't really give you a lot of supply to the posterior circulation. So the posterior circulation, where does it come from? It comes from the vertebral arteries, which merge to form the basilar artery. And the basilar artery terminates in a bifurcation into both posterior cerebral arteries. Now, most strokes happen in the anterior circulation. So about 80% of the strokes happen in the anterior circulation, and about 20% of strokes happen in the posterior circulation. Posterior circulation strokes, although they're 20% of the cases, they tend to be, can be the more devastating ones, but also can be the more tricky ones and harder to diagnose. So we looked at the blood vessels, now we look at the territory that they supply. If you look at this graph, mostly this is gonna be the anterior, middle, and posterior cerebral arteries. The middle cerebral artery covers the vast majority of the brain, which is in red. And then you have the anterior cerebral artery, which covers the medial portion and the frontal lobe. And then you have the posterior cerebral artery, which covers the occipital lobe and parts of the temporal lobe. The vertebro-basilar system supplies the brainstem and cerebellum, without going into too much detail of which part is which artery, because they're more smaller arteries. So some localization, we're not going to go into too much detail to know exactly where the stroke is coming from, but this helps with recognition and diagnosis. So if you see these symptoms, you're more confident that you're dealing with a stroke or a TIA. So with the MCA syndromes, you'll get a contralateral face and arm more than leg weakness. Mainly that's because the cortex is arranged in a way that the leg motor fibers are supplied mostly from the anterior cerebral artery, and the face and arm are from the middle cerebral artery. So if you have a face and arm that are very weak and a leg that's maybe a little weak, you're knowing you're dealing with a middle cerebral artery stroke. More importantly, with the middle cerebral artery, you get some cortical symptoms, which aphasia seems to be the biggest one. And that happens when you have a stroke in the dominant hemisphere, which is usually the left side. So often aphasia comes with right-sided weakness. If you have a stroke on the left side, it'll give you right-sided weakness and aphasia. The other one is neglect, and that's if it happens in the non-dominant hemisphere. So you'll get neglect to the opposite side. So you'll have, most of the time, it's going to be the left side that you're going to neglect, and weakness on the left side. And that neglect can sometimes look like also that you have a preference for gaze, where the patient is only looking or paying attention to the right side. MCA strokes are the most common. Now, the second one is the anterior cerebral artery strokes, which affect the leg more than the arm. They don't really typically affect the face. Then you have the posterior cerebral artery, which cause a homonymous hemianopia, which is a visual field cut. So you'll lose the half of the vision on one side of your visual field. And it's important to note for non-neurologists that the patient is not going to come and say, yeah, I see this picture, half of it is black and half of it is normal. That's not going to be the case. So the brain will fill the picture with what's available from their visual input. So they're going to see a whole picture, but it's only going to reflect what's happening in the right side of their visual field. So they're not going to wake up and immediately recognize it. They typically recognize it, or their family recognizes it, because they start bumping into things, they start missing signs, they start walking past that door that's on their left side, and they have to turn around and then they see it. So those, just be aware that the patient's not necessarily going to come and say, half of my vision is gone. That's typically not how it works. Now, the vertebrobasilar system, or the brainstem, this is the more tricky one because it can involve a lot of stroke mimics. I'm glad there's a second talk after this talking about stroke mimics, but who here hasn't seen any dizziness come to the clinic? Do we treat all of those as strokes? Not really. Most of the time, these people are going to ENT looking for crystals in their inner ear. So dizziness can be a sign of an ischemic stroke in the brainstem or in the cerebellum. Diplopia, double vision, so we call them the Ds, the dizziness, diplopia, dysarthria, dysphagia, and direction-changing nystagmus. So these are all signs, and again, these are the most commonly missed strokes. Ataxia is another one with the cerebellum specifically, and then the unique thing about brainstem strokes is if they involve motor symptoms, they a lot of times have cross signs. So for example, if you have a stroke in the right side of your brainstem, you can get a facial weakness on the right and the body weakness on the left. So the cranial nerve and the rest of the body are crossed in terms of where their deficits are. You can also get cross-sensory symptoms as well, where the face on one side is numb and the body on the other side is numb. So if you see any cross signs, that's definitely going to be a brainstem stroke or a brainstem syndrome, I should say. Not always a stroke, but if it is a stroke, you can get those cross signs. Very commonly missed, if you have someone who comes in with new onset isolated dizziness with a new headache, you really have to think about posterior circulation stroke, especially if it's someone who has risk factors for ischemic disease. Stroke versus TIA, and I think this is kind of my biggest pet peeve in the whole talk. I think this is probably the most valuable slide or most valuable topic for non-neurologists, because this is what I see most commonly misdiagnosed when or undiagnosed in my clinic or in the ER. So definitions. So TIA is focal brain spinal cord or retinal ischemia, which is very similar to stroke. The only difference is that the TIA, the clot or the ischemia, resolved in time before there was any tissue damage. So from a patient standpoint, I always tell them that stroke versus a TIA is a matter of luck. Like the only difference between them is that you either were lucky and the clot passed and the ischemia resolved, or you were unlucky and permanent damage happened. But from a definition standpoint, you have to prove tissue damage to count as a stroke. So now we have MRIs. We've had MRIs for many years. So the definition over time evolved from time-based to imaging based. So now we have DWI, which is the section or the modality of MRI that detects cerebral edema, cytotoxic edema, which tells you that there's been actual tissue damage. Used to be the TIA and stroke were a time definition. So with TIA, the symptoms typically last less than 1 hour. And this is a very important distinction. And they have to have a normal MRI. So you have to meet both. If the symptoms last 10 minutes and on MRI there's a time of tissue damage, it's a stroke. So the time you throw away the time if your MRI tells you a different story. But what's more important than the less than 1 hour is that if it's more than 1 hour, you're expecting any ischemia in the brain more than 1 hour to actually cause stroke or tissue damage. So you should see it on an MRI. So when we shift to the MRI or ischemic stroke definition, you have to have evidence of infarction on imaging, which is DWI. This is diffusion weighted images, or persistent symptoms more than 24 hours. Now, the persistent symptoms more than 24 hours was mostly from the old definition, but nowadays we use it for people who can't get an MRI. So think of someone who has some metal or someone who has a pacemaker that's not compatible. You can't get an MRI, it looks like a stroke. You waited 24 hours, it's not resolved. You can call it a stroke. But here's where I find the misdiagnosis is when someone has symptoms more than an hour, let's say someone has symptoms for 6 hours, 7 hours, and then you do an MRI and it looks stone cold normal. This is where most non-neurologists get very confused and they don't know what to call it because in their mind, this has to be ischemia. And that's the big problem. If your symptoms last, or if your patient's symptoms last several hours or even days and the MRI is normal, in my mind, that's not an ischemic event. You have to think about other things. Again, stroke mimics is coming in the next presentation. You have to really think about those. I find TIA very commonly diagnosed in people who've had symptoms for 2 weeks, just because the MRI was normal. If the symptoms last long enough, MRI is normal, it's not a TIA and it's not a stroke. You have to think about other stroke mimics. If I made this clear, great. If I didn't, I'd love to get as many questions as possible about this topic because this is a very common misconception. So why is TIA a neurologic emergency? Symptoms resolved, patients looking great, just send them home, right? Not really. So the risk of stroke in this patient who's now back to normal is 10 to 15% in the next 90 days. And half of that risk is in the next 48 hours. So although everyone deals with a stroke as a top emergency, I really want to encourage people to think of TIA also as a top emergency. You have 48 hours to deal with a very high risk of stroke. The risk of stroke through those patients, if you treat them and evaluate them, is down to 3.7%. Not zero, of course, but that's a huge chunk of risk that you can cut down by appropriately assessing and treating these patients. So the gap between 10 to 15% and 3.7% is what your management and urgent referral can prevent. So we always think about TIA to stroke as what an unstable angina is to MI. This slide is not coming out well. Can you guys see the slide? On my screen, it's not coming out well. I'm going to talk about it. I don't know if you guys can see it clearly or not, but this is the slide about BFAST.
Yeah, I don't
see a green as well.
A green background.
On the slide panel on the side, it looks correct, but on the main presentation screen, it looks like a green slide. But I'll tell you what it says. So this is the acronym BFAST. BFAST is a way that we teach non-neurologists and even paramedics to detect stroke symptoms. So B stands for balance, if they have acute sudden balance issues. E stands for eye, blurry, double vision. FAST is face, facial weakness. A is arm weakness. S is speech, so any slurred speech, garbled speech, or no speech at all. And then T stands for time. It's really time to send this patient either urgently to the ER or just call the paramedics to take them to the nearest stroke center. BFAST is the acronym that we use. The old acronym was FAST, and we found that BFAST detects 14% more strokes than the old acronym. So BFAST should be your acronym that you use to detect acute stroke or TIA. So you're in clinic and the patient comes in and then they tell you that they had acute neurologic deficits. So what's your 5-minute workflow? Because you got to be really fast. So you're going to apply BFAST. You're going to look for any new focal neurologic signs or symptoms. And if they do have that, then that's a stroke until proven otherwise. Next step is establish the last known well. So a lot of people here want to tell you, or the family member will come and say, yeah, the stroke started at 10 a.m. That's not enough information. You need to know when the last time the patient was established to be well. So if you ask more questions, you'll find out the patient woke up at 10 a.m. and they already have the symptoms. So that's not really the onset, right? Or someone, like the wife saw him, then he went to work, and then he came back and she had right-sided weakness. They'll count the time that he came back from work, but that's not really the true last known well. Last known well is when was the last time the patient was documented to be normal or free of these deficits. So that's a very important one to establish. You have to call 998, or if you're in a hospital, you send them to the emergency room. If you have a neurologist available immediately, you would call them. So those are the typical things that you have to do, but it has to be very fast. You check a POC glucose because hypoglycemia is a very important stroke mimic. And then you gather all the critical information for the next person to deal with it, including medication list, anticoagulation status. If you've determined this last known well, that's amazing. If they've had recent surgeries or anything like that are going to be very important because you're thinking next step is the patient going to be a candidate for thrombolytic therapy. So a TIA in clinic, and this is easy to miss and easy to kind of overlook or underestimate, what not to do. Don't schedule an outpatient MRI in 2 weeks. Do not wait for symptoms to happen again before acting. Do not give aspirin and say, yeah, this is fine. Just go home, take this aspirin, you'll be okay. And don't rely just on a normal neuro exam. I can't tell you how many times I've been contacted about a patient in the ER. They want to send them home because their exam is normal and they're perfectly fine. Well, if you listen to the story, you know they're not perfectly fine. There's a high risk of stroke in the next 48 hours. These people really do need urgent evaluation and treatment. So the patients need referral same day if your neurologist is very accessible, or you send them to the emergency room. As primary care physicians, you want to modify their risk factors. You're optimizing blood pressure, statin, glycemic control, smoking. Of course, in the acute stroke setting, you're not going to touch that blood pressure. We don't want to lower blood pressure in the acute setting of ischemic stroke, but we're talking long-term risk factor modification. Antiplatelet therapy, you can defer this to neurology, but I'll just tell you what we typically do. We usually start dual antiplatelet therapy for people who have high-risk TIA or minor strokes. We do that for 21 days, and then we withdraw the clopidogrel and maintain the aspirin. And for people who are resistant to clopidogrel, we use ticagrelor. So what are our key takeaways? You can map the deficits. This helps you with more confidence make the diagnosis. If you can see someone and you're like, oh, I can see that this is probably coming from the right middle-cerebral artery, it confirms your diagnosis. TIA and stroke are both emergencies. The difference between stroke and TIA is luck. Be fast. Apply this acronym, especially the balance and eyes can help you detect some of the tricky posterior circulation strokes. It captures 14% more strokes than your typical FAST acronym. Establish the last known well, and this requires you asking multiple questions and not just relying on the first piece of information that comes to you. And when you're in doubt, just call the emergency medical services or send the patient to the ER. Time lost is brain lost, and thank you very much for listening.
Thank you very much for such a informative, and there is a lot of information there for our primary care physicians and GPs, and I think we will discuss some of these things in our question and answer session. I think we'll have the questions, Anas will have it at the end of our session. I think that would be better.
Yes.
Our next speaker is Dr. Angela, and she is going to talk on stroke mimics. Angela is a geriatric medicine consultant at University Hospital Lewisham. She's graduated from Barts, London and Queen Mary University. She has done a lot of work on stroke and stroke rehabilitation. She runs one of the busiest TIA and biggest OPD clinics in UK. So we will listen to her about stroke mimics. I was told if it's something you walk like a duck and it is a duck, it's stroke. If something walks like a duck but it's not a duck, then you have to think about stroke mimics. So it will be very interesting, Dr. Angela, to listen to you. The floor is yours. Thank you. Are you talking? I think it is a video.
Hello there. My name's Dr. Angela Calendron, and I work as a consultant in general geriatric and stroke medicine at University Hospital Lewisham, and that's a hospital in the southeast of London in the UK. So I'm going to be giving a talk on stroke mimics. So in terms of what I'll be discussing, I'll talk about the impact of stroke, both in the UK and worldwide. I'll also talk about some definitions, both of stroke and stroke mimics. I'll then discuss types of stroke mimics and distinguishing features. And I'll also go in a bit more detail about the common stroke mimics that we will see. I'll then touch briefly on investigations, and then we'll finish with a couple of cases. So in terms of the impact of stroke in the UK, unfortunately, every year 100,000 people will have a new stroke, and that equates to about one stroke every 5 minutes. Unfortunately, 1 in 5 strokes are fatal. 1 in 8 people die within the first 30 days of having a stroke. And it's the fourth leading cause of death in the UK, and that comes after dementia, heart disease and lung disease, and it's the leading cause of disability in the UK long term. So unfortunately, with patients who are admitted with a stroke, at least 2/3 will leave hospital with some sort of disability, and 1 in 10 people will end up in some sort of institution, whether that's a nursing home or a care home. And the cost of stroke is huge. So annually to our NHS, our National Health Service, the cost is just over £3 billion, and that equates to admission to hospital, costs of treatment, imaging, lengths of stay, and also stroke rehabilitation. The cost to social care is greater than £5 billion, and that is because, as we mentioned earlier, it's the leading cause of disability. So people who have a stroke may end up needing carer support for their day-to-day activities. And then the cost in terms of informal care is quite considerate at nearly £16 billion. And that is because there are loved ones who are willing to give up their work in order to look after those who have had a stroke. And in addition to that, it's a huge cost to the economy, as unfortunately on our stroke units, we have people in their 40s, 50s, 60s, sometimes even younger, who are working up until the point of their stroke and then aren't able to return. So there's a loss of productivity in relation to them and also their loved ones who may then provide that informal care. So these are the costs in 2017. Now, conversely, when looking at the impact of stroke worldwide, 12 million people will have a stroke every year, and it's the second leading cause of death worldwide. That comes after heart disease. And again, this is a figure in 2017 where the annual cost of stroke is $890 billion. And if we're looking at the exchange rate back in 2017, the cost to the UK and the cost worldwide is 20 times that in the UK, if not more. And these figures will certainly have increased by at least 20% if you're looking at this day and age. So historically, stroke used to be about prevention. So if a stroke had happened, the mainstay of treatment was antiplatelet therapy to try and prevent another stroke, and then it was stroke rehabilitation. Treatments only first came to light with aspirin being recognised as something that could prevent a stroke, but that is only when a stroke had happened. However, in the 1990s, the treatment of stroke became revolutionised by the introduction of thrombolysis. So that came to light in 1995, was introduced in the UK in 2003, and then mechanical thrombectomy, which was also identified in the 90s, but unfortunately took a bit longer to trial and test, and it was finally introduced in the UK in 2017. So with the advent of thrombolysis, it showed that strokes were not just preventable, but actually also treatable, and it really could improve patient outcomes. So mortality reduced by a third, lengths of hospital stay reduced by half, and fewer people were needing to go into a nursing home or a care home. So it really did revolutionise stroke treatment. As a caveat to treatments, all treatments sometimes can have their own side effects and complications. So we know that with ischemic strokes, the mainstay of treatment remains antiplatelet therapy. So that may be a high dose of aspirin. So in the UK, we use aspirin 300 milligrams once daily for 2 weeks, followed by clopidogrel. And when our guidelines were updated in 2023, we can now use dual antiplatelet therapy for 3 weeks for mild ischemic strokes within 24 hours. But we know that a recognised side effect of antiplatelet therapy is upper GI bleeds. Likewise with thrombolysis, it doesn't come without its risks. So the most common complication of thrombolysis is hemorrhage, and studies quote figures between 2 to 6%, and that is in people who've had a stroke and who have been thrombolysed. However, if you have a patient who actually ends up having a diagnosis of a stroke mimic, so i.e. not a stroke, the risk of complication from bleeding is lower, and rates can vary between 0.5 to 2%. There's also an associated allergic side effect with thrombolysis, so anaphylaxis is a potential complication, as is angioedema. And then one has to think about the costs of treatment. So we talked earlier about how the costs of stroke can be high, and so the patients who need those imaging, needs that treatment, then it needs to be given. However, when we think about patients who are suspected to have a stroke but actually end up having an alternative diagnosis, the financial implications can be high, and this relates to the medication itself, so things like thrombolysis, but also the imaging to try and identify the diagnosis, but also admission of these patients to a very specialised unit. So in the UK, patients admitted with a stroke are usually admitted to a stroke centre, a hyperacute stroke unit, and that care is delivered by highly trained doctors, nurses and other specialists, and also involves continuous monitoring. So the costs can be high in those who do not end up having a diagnosis of a stroke. So just as a reminder, a definition of a stroke is a sudden onset focal neurological deficit, and it's usually due to a vascular cause, and the symptoms last more than 24 hours. However, we know that there are other diagnoses that can affect the brain, which can also manifest in similar focal neurological deficits. So in terms of definition of stroke mimic, a stroke mimic is a non-vascular condition which presents with symptoms that are typical of a stroke. And when previous audits have been done of patients admitted with a suspected stroke who actually end up having an alternative diagnosis, stroke mimics can account for up to 25% of stroke admissions. Now, my colleagues and I at Lewisham carry out stroke reviews regularly, and I had a quick audit of 6 months worth of reviews of patients suspected to have had a stroke. And when I looked at the final diagnosis, actually 36 of these patients ended up as stroke mimics, i.e. having an alternative diagnosis. So this is just a reminder of the neuroanatomy. So depending on which part of the brain is affected, that will then determine the type of symptoms that a patient presents with. However, we know that focal deficits aren't always caused by a stroke. There are other conditions that can also give rise to focal neurological deficits. So these are common stroke mimics that can arise, and as you can see, it's a vast array, which can range from generalised conditions to focal ones, and sometimes these may be structural. They could also be vascular, so although stroke is a deficit caused by a vascular injury, that vascular injury could inadvertently be caused by, for example, a space-occupying lesion compressing a vessel and causing a stroke. It could also be due to other causes, varying from infective to inflammatory. And then in some cases, the diagnosis may end up being non-organic. So these are basically clinical features, and it's a table illustrating symptoms and characteristics that can make a stroke likely, but also what can make a stroke unlikely. And the thing to focus on is that with stroke, people tend to present with focal symptoms, and usually this can range from things like unilateral weakness and or sensory disturbance, dysphasia, and I've deliberately put in brackets conscious because we know that patients can have things like loss of consciousness, and following that may have slurred speech after, but that doesn't necessarily mean a diagnosis of a stroke, and that may point towards another diagnosis. Whereas generalized symptoms such as confusion, headache, something that's non-specific may point towards an alternative diagnosis. Likewise, other characteristics that can make stroke more likely are negative features. So stroke is always often about loss, so loss of power, loss of sensation, loss of speech, whereas positive features, so things like paresthesia, headaches, these kind of things may make strokes less likely. So again, people having vascular risk factors may point more towards a stroke, whereas an established diagnosis of something like migraines or epilepsy may suggest an alternative diagnosis. So when we're assessing patients with stroke, nothing hurts than going back to basics. So we all learned at medical school that history makes up 80% of the diagnosis, and that is very key when you're trying to establish whether someone has had a stroke or whether they may have a different diagnosis. Examination might also be helpful in terms of establishing what may be the cause. And although we're all taught that stroke is a clinical diagnosis, investigations are very useful adjuncts to try and help to establish whether someone has had a stroke or whether there may be something else that causes the symptoms. And with these investigations, it can help the patient to get the right diagnosis and therefore the right treatment. So this is a graph just illustrating common stroke mimics. And when I looked at this in comparison to the audit of patients that my colleagues and I have assessed on the ward, it's quite similar. So common stroke mimics that we tend to see tends to be things like syncope, other sort of traumatic injuries to the brain, so it could be a traumatic cerebral hemorrhage or subdural or extradural in nature, headache disorders, as well as peripheral vertigo. And another thing to highlight is often stroke mimic diagnoses also tend to be the same diagnoses that could also be similar to TIA mimics as well. So often you see very much an overlap of the conditions that can cause mimics of either a stroke or a TIA. So this is a table illustrating common stroke mimics, although these are for TIA, but as I said, there is a lot of overlap. But what's helpful here is the distinguishing features. So for example, for a patient with a brain tumour, the headache may be quite classical in terms of a pressure headache, which may be worse on bending or on coughing. If a patient is suspected to have meningitis, for example, they may present with fever, with headache, neck stiffness, photophobia. And with encephalitis, they may have fever, but also a change in personality. Likewise, with migraines, patients often have other symptoms in association with the headache. So this can be things like nausea and vomiting, photophobia and phonophobia, and sometimes they'll also have an aura as well. However, the aura can also be mistaken for stroke-like symptoms. And then multiple sclerosis, although patients may present with focal symptoms, they also may have other atypical symptoms such as pain in the eye, bowel or bladder symptoms. And with seizures, patients may have an aura, for example, preceding the seizure, and that could be sensory, such as an epigastric rising sensation, or olfactory, where they may smell sort of burning rubber, burning tyres. And then with peripheral vertigo, there could be characteristics such as hearing loss in association with vertigo, or they may have the vertigo may be worse with certain positions such as bending or turning over. So just to go a bit more in detail about some of the common mimics. So with seizures, we know the classical presentation of focal or generalized limb jerking, but what can also distinguish a seizure is the altered level of consciousness, which we don't tend to see with stroke. So this may occur during the seizure, where a person may lose complete consciousness and be totally unaware, or Patient could lose awareness. They could be staring blankly, eyes open, but there's that loss of awareness. Other characteristics include the traditional tongue biting and incontinence that we see with generalized seizures. However, what can often mistake a seizure with a stroke is Todd's paresis. So Todd's paresis is a transient weakness which can occur following a generalized seizure, usually generalized. And this, if you look through the literature, average timeframes tend to be from 30 minutes to 36 hours, although it can be as low as a few minutes up to 2 days. And often with generalized seizures, patients may have a period of confusion after, so we call it a post-ictal confusion, and that can sometimes last for hours. However, there can be an overlap with seizure and stroke. For example, in few patients with stroke, a seizure may be a manifestation of the onset, but usually this is not just with the seizure alone. There will also be other focal signs or symptoms. And sometimes in patients who've already had an established stroke, especially if there's gliosis or encephalomalacia affecting certain parts of the brain, such as the occipital lobe, the parietal lobe, the temporal lobe, such patients may develop secondary seizures. So another common mimic is migraines. So in terms of distinguishing features, this often occurs in people of a younger age, usually characterised by a unilateral headache, often throbbing in nature. And as mentioned earlier, the associated symptoms that we may see with migraines include nausea and vomiting, photophobia and phonophobia, and scintillating scotoma. So this is your visual aura, which can also be known as fortification spectra. So some patients may describe this as sort of shimmering lights. Some people see zigzag lines or flashing lights. But a migrainous aura can also be characterised by other focal symptoms. So patients may present with unilateral weakness, which can occur in hemiplegic migraine. Some people have sensory disturbance, which could either be a numbness or it could be paresthesia, sort of pins and needles tingling. But often in migraines, it tends to have a spreading sensation, which you don't tend to see with strokes. So it may start, for example, in the fingers and extend up to the rest of the body, in a single side of the body. And some patients, their aura might be characterised by dysphasia. So syncope is sort of defined by a loss of consciousness. Patients with syncope often may describe a prodrome. So when taking a history, it's quite important to ask about symptoms such as blurred vision, nausea, sort of generalized weakness, and often people feel lightheaded prior to syncope. And what often gets mistaken for a stroke is the post-episode period. So people may have slurred speech. With loss of consciousness, people are hyperperfusing their brain, and so the speech won't be normal, but it can also affect them physically, where they have more of a generalized weakness as opposed to the unilateral weakness that we typically see with stroke. Another characteristic of syncope is the quick recovery. So with seizures, we talked about how the post-ictal period can last up to hours, whereas with syncope, people usually recover quite quickly, so usually within minutes. And lastly, I'm going to talk about functional neurological disorder. So again, this tends to occur in people of a younger age. And sometimes when we're referred with someone who has a suspected stroke, it transpires that they may have an established diagnosis of FND, but nonetheless, it is still important to do a full assessment. And other characteristics that may suggest FND include sort of inconsistent symptoms. So you may have multiple symptoms that aren't particularly localized to a particular vascular territory. Often these may be associated with other atypical symptoms such as anxiety or pain. And the converse to that is you may actually have people presenting with multiple symptoms but are quite blasé about the symptoms, and often there's sort of a lack of concern which may sort of ring alarm bells. When you do a clinical examination of these patients, often there might be signs that we might observe or see when we're examining. So that could include, for example, a person who has a completely normal gait, but when we try and examine them, they struggle to lift their leg on assessing hip flexion. Likewise, where someone is complaining of arm weakness and can't move, but you've seen them that they're able to hold their phone, for example, or they're able to clasp their hands together without one side being limp. And then I've included Hoover's sign as well. So Hoover's sign is where someone may present with leg weakness and say they can't move the leg when you try and test hip flexion. However, when you then put your hand underneath that same leg under their heel and then assess flexion of the contralateral leg, often you find that they're actually pushing down with the affected leg with their heel, and actually they do have power as opposed to paralysis. And another tip when examining patients who you suspect may have FND is distraction. So initially they may be demonstrating weakness when you're testing power. However, if you're sort of distracting them, talking to them, and this may also involve sort of bilateral testing, you may notice that the power is actually intact. However, making a diagnosis of FND can be quite difficult in the acute setting. And as I put on the slide, it's a diagnosis of exclusion. So you want to make sure that even if you don't suspect it's a stroke, there may be an alternative neurological cause for their symptoms. And so often these patients may be referred to neurologists for further assessment. And if all of the investigations come back as normal, then the diagnosis of FND can be made and the patient can be offered the right treatment and support. So in terms of investigations, so the investigations help to point towards the diagnosis of a stroke or help you make the diagnosis of a mimic. So as with blood tests, if you're suspecting sepsis, which is a typical common mimic, you may check their inflammatory markers. So if there's suspected metabolic cause, you probably want to know if they're sort of check the electrolytes, make sure they're not severely hyponatremic or hypercalcemic. And a confusion screen is quite useful. So in the UK, when we test confusion, we will test things like B12 folate, thyroid function, because as we know, people with severe hypothyroidism may have confusion, and likewise with B12 deficiency, not only can it cause cognitive symptoms, it can also cause other neurological symptoms. So it's quite helpful to check those levels. An ECG will be useful, so especially if you suspect a patient has syncope, an ECG may help to diagnose an alternative arrhythmia or even a heart block. If you have a patient who has a known diagnosis of a malignancy and you suspect that their symptoms may actually be due to brain metastases, a CT head with contrast is useful. And the gold standard certainly for stroke is the MRI brain scan. So if you're doing an MRI brain scan, especially a diffusion weighted imaging, this usually becomes positive within 1 to 2 hours of onset of a stroke. And so extremely useful in helping the diagnosis. But as we know, an MRI can also help to make alternative diagnoses such as inflammation and may support also a diagnosis of a space-occupying lesion. And then lastly, again, if it's suspected, a lumbar puncture might be helpful for patients with suspected meningitis or encephalitis and also with multiple sclerosis. Okay, so we'll finish with a couple of cases. So these are real cases. So the first one is a lady who was admitted a year or two ago at Lewisham. It's a 96-year-old admitted with a controlled fall. And a controlled fall is essentially a lady who's about to fall. However, she's actually assisted to the ground rather than falling and then sustaining trauma. So it was an atraumatic injury. And unfortunately, she sustained a right fractured hip. When she was being assessed clinically, she was noted to have speech disturbance. So she was muddling her words, not able to speak in clear sentences, and also had trouble following instructions. So she did have stroke risk factors in terms of age and hypertension. And prior to the admission, she was able to manage her day-to-day activities and live with her son, who supported as needed. On examination, she was found to have dysphasia and dysarthria. So the impression was that she'd had a stroke, as well as a fragility fracture of the hip. However, when she had her CT head scan, which is on the left, there was a left temporal lobe hypodensity, which with the surrounding area of hyperdensity of a different degree, and as well as small vessel disease. And because although she had a control fall, the CT head scan had also showed a lytic lesion of her left mandible, which was suspicious. So as a result, she'd had a full CT scan of the neck, the chest, abdomen, and pelvis, and this had showed a spiculated mass in her right lung, as well as a mass in her left lung, her liver, and she also had lytic lesions in her ribs and her spine, as well as in the left ilium and acetabulum. So the opposite hip had also had lytic lesions. When she went on to have an MRI head scan with contrast, this showed two well circumscribed lesions, so in the left temporal lobe as well as in the right frontal lobe. So unfortunately, this lady had brain metastases likely due to a lung primary. And the second case is actually a case that was referred to our TIA clinic a couple of years ago. So this is a young gentleman with a known history of migraines, and he was referred with sudden onset partial right monoocular visual loss with right-sided numbness lasting a couple of minutes. This was then followed by a mild right-sided headache, which he said was typical of his usual migraine headache, and hours later had his usual visual aura. Now, the unusual thing in this situation was that he also had a migraine the following day, which was very atypical for him, but also that his migraines had increased in frequency over the last few months. So he was now getting migraines once a month. He had no risk factors for a stroke, so no family history, and there was nothing significant in his social history, and an examination was normal. So the clinical impression was that this gentleman had a migraine with aura. However, we did carry out brain imaging. And this had showed an infarct, so an acute infarct in the left gangliocapsular region, which is illustrated. There was also an incidental finding of a small infarct in the right cerebellum, which was also acute. So unfortunately, this gentleman has had infarcts, and so we carried out further investigations to look for the cause. A CT angiogram was fine, as were other typical stroke investigations, including an antiphospholipid syndrome screen. However, a bubble echocardiogram, which is an investigation we do carry out for young people with stroke, showed a large PFO, so patent foramen ovale with a shunt, and this can actually be associated with strokes and mini strokes in young people. And so this gentleman was referred to a cardiac centre for consideration of PFO closure. So I guess the thing to highlight in this case is that migraine is not a risk factor for stroke. However, people who have migraines with aura are at a higher risk of a stroke, although the overall risk is generally low. So just to summarise, when trying to distinguish a stroke from stroke mimics, a careful history is vital, and asking the right history and looking at different symptoms may help to distinguish from mimics. But as we said earlier, although stroke is a clinical diagnosis, investigations are extremely helpful with ensuring that the patient gets the right diagnosis and therefore the right treatment. And here are my references.
Hello, everyone, and we'd like to thank Dr. Angela for this beautiful and comprehensive review about stroke mimics. I think for the sake of the time, we will be moving to our last and third session presented by Dr. Agam Jung. It's going to be about peripheral neuropathy. Dr. Agam Jung is a consultant neurologist at Leeds Teaching Hospitals NHS, and she is a director of the Regional Motor Neuron Disease Care Center. So welcome, Dr. Agam, and we're happy to have you with us today. Please, I believe it's going to be a recorded session as well. So we are ready to move into the third session.
Hello, everybody. My name is Dr. Agam Jung, and I'm a consultant neurologist and the founder director of the Rob Center for Motor Neuron Disease. And I'm going to be speaking on peripheral neuropathy. So, I use a lot of art in medical education. And one thing that has always fascinated me is Frida Kahlo's artwork and her quote where she said, "I never paint dreams or nightmares. I paint my own reality." And if you look at her paintings, for example, the wounded deer, you can see various arrows stuck in a deer, obviously implying sharp shooting pain associated with some bleeding. And there's another one called The Dream in 1940, where she's sleeping in bed and even a light blanket feels as if it has got thorns on it, suggesting that there is a degree of allodynia. So what is this peripheral neuropathy that can actually result in such dreams and such severe pain? We know that diagnosing anybody with peripheral neuropathy is quite a diagnostic challenge, primarily because it is a spectrum. There are a spectrum of symptoms ranging from mild to very severe, and the clinical phenotypes can actually overlap. About 2 to 8% is the prevalence, and 1 in 15 people in the US will have peripheral neuropathy. It is quite expensive as well because patients can lose their employment, and it can lead to falls, fractures, and multidisciplinary teams need to manage these patients. And of course, up to 31% patients, we do not find a cause. And peripheral neuropathy itself actually can lead to a significant psychological effects. If it is genetic one, you will end up having a lot of guilt with pain. You don't sleep very well, disability, occupation loss, and in general, an inefficiency in the system gets generated. And as GPs, when you refer a patient to the neurologist, you get a long letter with lots of information. And for example, this letter ending with saying, this patient has acquired chronic, slowly progressive, length-dependent, sensory predominant, blah, blah, blah. Basically, what they want to say is that the patient has diabetic neuropathy. So there is a framework that we neurologists use when we are describing peripheral neuropathy. And that framework would talk about the onset, how fast it progresses, which modalities are affected, what is the anatomical distribution, and what is the electrophysiology, the nerve conduction study, what does that show, and of course, what is the background. So there is a method in the madness whenever there is a nomenclature of the neuropathies, You talk about the site, whether it is distal, whether it is ascending. Is it affecting only one body region, say the arms or the legs, or is it affecting all the body regions? And I think symmetrical and asymmetrical carries a lot of weightage. Is it a single nerve that is affected or multiple nerves? And if the multiple nerves are affected, are they symmetrically affected, or are they just patchy, one nerve here and one nerve there? Is it a motor, or is it sensory? Is it a combined one, or are there any associated autonomic features? And of course, the mild, moderate, and severity, the patients themselves tell us. Onset is very important because there are certain conditions where you can have an acute presentation of less than 4 weeks, or of course it could be chronic, in which it is more than 6 weeks, 3 months even. And these are usually metabolic, genetic, and toxic in nature, whereas the subacute ones are usually autoimmune or inflammatory. 90% of neuropathies are actually axonal and only 10% are demyelinating. And it's very important to make sure that we have identified the demyelinating ones. Whether there is what is the nature of the description? Is it burning? Is there pain? Or is it a proprioceptive loss? That is your joint position of vibration. Just one image on going back to the basics. You can see the red line is the upper motor neuron, which is going from the brain to the spinal cord. And this is not that this part is which we are not going to talk about. We are going to talk about the peripheral nerve, which starts from the anterior horn cell and goes down to the muscle. The second image shows you that if there is an abnormal sensation, for example, heat from a candle, that sensation is carried by the red nerve, which is your sensory nerve here. And there's an interneuron. And then, of course, the anterior horn cell from where the motor nerve starts reaches the muscle, and it tells the muscle to contract. Each of these nerves, actually, the blue bit here is the axon, and the myelin is on top of it. So whether an axonal neuropathy, the blue bits of the nerve are being affected, and in a demyelinating neuropathy, it is the myelin, this round bit here, that is the one that gets stripped off. Neurology can be actually quite simple if you answer just 2 questions. The first question is, where is the lesion? Is it an upper motor neuron lesion? Is it a lower motor neuron lesion? Or both upper motor neuron and lower motor neuron signs are affected? Because if there is a mixture of both upper and lower motor neuron, then the abnormality lies in the anterior horn cell. The next question that you ask is, what is the lesion? And there's a very simple sieve that you can use called vitamin C, D, E, F, where it is vascular, I is for infection, inflammation, or it could be iatrogenic, T is for trauma, A is for autoimmune pathologies, and M is for metabolic conditions, I, idiopathic, we don't know why, N is for neoplastic, and then of course congenital, degenerative, endocrine, and functional. So once you answer these two questions, it becomes quite easy to identify where and what the problem is. And as the patients give us history, the patients talk a lot, and then we need to figure out which part of the history is relevant, which part of the examination is relevant, and which tests we need to be doing, and which red flags we should not miss. In the history, both positive and negative symptoms are offered. The negative symptoms are when you don't feel anything, for example, numbness, while I'm walking on cotton wool. And if there are positive symptoms, then patients will describe dysesthesias or paresthesias, and of course, allodynia, as we showed in the first picture. They will talk about falls, poor balance, incoordination, and of course, advanced neuropathies can result in skin changes and ulcerations. Sometimes patients are unaware that they have a neuropathy, and a family history and history of playing sports is important. They might say, oh, I never played sport. And then you realize that actually they had a Charcot-Marie-Tooth neuropathy, which you can see in the images of the foot below. And of course, you want to know whether there is a history of a systemic illness that is associated, diabetes, cancer, any chemotherapeutic drugs that have been using. Chemotherapy can lead to a neuropathy, toxins such as alcohol intoxication, and of course, certain drugs again can give rise to neuropathies. Autonomic neuropathy is something that we should always ask for, and the symptoms really are about constipation or diarrhea, erectile dysfunction, if there is tachycardia after sitting or standing, and if there is a temperature intolerance, sweating issues, and gastroparesis, which means, there is an early satiety and bloating, and orthostatic intolerance. Usually we find autonomic neuropathies in diabetes, amyloidosis, Guillain-Barré syndrome. When patients are admitted in the hospital, they can have significant autonomic involvement, and vincristine-induced neuropathy also has a degree of autonomic involvement. If you have difficulties, always have a phone a friend situation. Call your friendly neurologist. And when should you be calling this friendly neurologist? You should be calling them if there are multiple nerves in a multifocal manner. That means that different nerves have been affected, not in a symmetrical manner. If the neuropathy is progressing rather rapidly, if it is a pure motor pathology and not sensory involvement, which will raise concern about motor neuron disease, or if there are problems with your speech and swallowing and there's a bulbar onset, and if patients are unsteady, and any acute or subacute non-length dependent neuropathy, these should be referred early on to the neurologist. When we examine patients, we start from the head down to the toes. So you look for cranial nerve involvement. And particularly in Guillain-Barré syndrome, you can have facial weakness and eye movements can be affected. And motor neuron disease, you can have tongue and oropharyngeal involvement. Dorsal columns can be affected, and that can be picked up in vibration and joint position. So we know that instances of people using nitrous oxide as a recreational drug, that can present with dorsal column involvement, as can vitamin B12 or syphilis affecting the dorsal columns. We usually use a 64 Hertz tuning fork, and a monofilament testing for every diabetic patient needs to be done. We must do a systemic examination, look at the joints, look at the skin, find out if there's any rheumatological issue, to identify early vasculitis. And please bear in mind that as we get older, we do lose our vibration sensation distally. Motor examination, again, motor neuron disease becomes quite significant, and one needs an early diagnosis here. And it's a pure motor problem. It's a low motor neuron problem. So the reflexes will be diminished or they will be absent. And there will be, if there is associated hyperreflexia along with atrophy, that tells us that the upper motor neuron is involved as well. And that is motor neuron disease. I'm showing you an image here. This is of the tongue, which is showing fasciculations. You can see the small fasciculations there. And of course, in the arm as well, you can see a few fasciculations there. And this is, again, the hallmark of motor neuron disease. In the community, I think the basic investigations, I put them in blue here. So a complete blood count, a metabolic panel, looking at making sure that the patient is not diabetic, B12, folic acid, serum protein electrophoresis, and underactive thyroid, HIV, syphilis. These are the ones that are the baseline investigations that need to be done. The second line investigations would include your rarer conditions, and particularly the vasculitic ones, ANA, ANCA, serum ACE. And of course, if all of this is negative and there is a relentless progression, then we do need to think in terms of a paraneoplastic presentation, and of course rare conditions such as an anti-BAG antibody, anti-ganglioside antibody. However, all of these, the last column really needs to be done by the neurologist, so I wouldn't worry too much about the doing genetic tests or looking for amyloidosis or Charcot-Marie-Tooth. There are specialist investigations. Patients with neuropathy, we will arrange for nerve conduction studies. And primarily this is to rule out the demyelinating, the 10% demyelinating ones, because those can be treated, whereas the axonal ones can't be treated. We do sometimes do nerve biopsies, particularly if there's a painful neuropathy, and that would be to rule out a vasculitis, sarcoidosis, amyloidosis, leprosy, lymphoma, and even small fiber neuropathies. Sometimes skin biopsies are done. We don't usually do them. And this is the area where the skin nerve biopsy is taken from. It's the sural nerve, and you can see the microscopic feature where the myelinated fibers are seen quite clearly. And again, if patients are relentlessly progressing, then a CSF analysis to make sure that this is not immune mediated, very important in Guillain-Barré syndrome. Or if there are any infections or a cancer or a lymphoma, then a lumbar puncture is also done. We've all had COVID in the past, and we do know that the olfactory nerve is affected in COVID. So you can lose your sense of smell, and of course, sense of smell and taste are both linked close together. Guillain-Barré syndrome has been reported, but there is an unclear cause. And critical illness neuropathy in patients who've been hospitalized, and even the ones who've been hospitalized, they can develop entrapment neuropathies, mononeuropathies, because of the positioning. Your knee can be against the support of the bed, or even in the proning position. Patients have presented with long COVID, and they do quite often report orthostatic intolerance and abnormal autoimmune function. It's quite controversial if there is a vaccine-related neuropathy, and I don't think that anything has been proven as yet. Guillain-Barré syndrome is an acute emergency, and this is the time to not waste and send the patient into the hospital. And when would you consider it? If there is a infection, a preceding infection, particularly in diarrhea or a respiratory involvement, and 20% of patients actually can have a poor prognosis. And EMG, the nerve conduction study and the EMG are done initially to diagnose and subsequently to prognosticate to see if there is any improvement or there is continued worsening, because this acute inflammatory demyelinating neuropathy can actually become chronic as well. We can do a lumbar puncture, and that is to identify that the proteins are raised. However, the cells are normal, that there is no infection as such. Management is with supportive care and immunoglobulin therapy. Some centers do use plasmapheresis, and if the IVIG fails, then again plasmapheresis can be attempted. Sometimes patients do end up in intensive care, and again, autoimmune involvement is quite significant. But bedside testing for respiration is good, because you can identify patients who are more likely to deteriorate, do a count up to 15, accessory muscle use, and the respiratory rate. Guillain-Barré syndrome, as I said, can actually worsen and become chronic, or of course it can plateau and have treatment-related fluctuations, and then it should really improve in time. Diabetic neuropathies can actually be generalized neuropathies, which is what usually patients present with. You have distal sensory problems, patients presenting with tingling, numbness, but there are certain rarer forms of diabetic neuropathy as well. They can be an autonomic involvement, and it could be cranial nerve involvement, so like a third nerve palsy can present, or just a focal limb involvement can also be present. So the most common of this, about a third of the patients of diabetes will present with the diabetic sensory motor polyneuropathy. It is classically glove and stocking length dependent. And as I said again, you could have autonomic neuropathy. The important thing is that when diabetes is diagnosed, we do a monofilament test. We regularly do a monofilament test. We should look at the feet, look for ulcers, any amputations, any loss of hair, and of course the gait. And we must ensure that our patients have a very good glycemic control. Mononeuropathies can present again, as I talked about the third nerve palsy. It is higher in diabetics rather than non-diabetics, and classically there will be ptosis of the eye, as you can see, with a pupil, with an eye that is down and out, and it should usually resolve because it is due to microvascular ischemia. You can have carpal tunnel syndrome, or you can have even lateral cutaneous nerve of the thigh involvement if people are losing weight suddenly or putting on weight suddenly, and if they've had any surgery done. So you can see from below the inguinal ligament, the nerve gets compressed, the lateral cutaneous nerve, and results in numbness in the thigh. Small fiber neuropathy, again, it's very difficult to diagnose because your nerve conduction studies are normal, but patients are presenting with tingling numbness, and really it is managed only by symptomatic relief. There is a corneal confocal microscopy which can actually also diagnose this small fiber neuropathy, and of course skin biopsy would be the gold standard, but not all centers do skin biopsies. It can be quite debilitating, and it is just that the terminal branches of the small fibers are degenerating. And again, quite a lot of diabetic patients will have small fiber neuropathy. I've already mentioned about the autonomic symptoms, and I'll just do a recap here because there's a resting tachycardia, or if you stand up, your blood pressure drops. You can have gastroparesis, bloating, esophageal dysmotility is also there, and erectile dysfunction, a neurogenic bladder, sweating issues, and a heat intolerance and a dry skin. These are all hallmarks of a diabetic autonomic neuropathy. Treatment-induced neuropathy can happen when you start insulin, when there is rapid normalization of the glucose levels. Then patients can develop an autonomic neuropathy, and that's called as insulin neuritis. And similar to the diabetic cachexia, where you lose significant amount of weight, which results in a nerve hypoxia, patients can present with painful paresthesias, and ultimately this does recover though. I'll skip this slide. And I just want to talk about this, the GLP-1 medications in neuropathy. So now there's a lot of medications being prescribed for weight loss and also in diabetics. And this is recent information that has come out, something called the slimmer's paralysis, which is your compressive neuropathies. So usually, if you are overweight, you have a fat padding around the nerves, such as the common peroneal nerve or the ulnar nerve. And when you lose that fat padding, then any pressure on those areas can result in your compressive neuropathy, like carpal tunnel, ulnar neuropathies, or a foot drop. There are other conditions such as lumbosacral radiculoplexus neuropathy, which is like a diabetic amyotrophy that can happen. And again, this is similar to the mechanism where we talked about the insulin neuritis. There is a rapid reduction, and the nerve itself can have microvasculitis resulting in your plexus involvement. And of course, you can have non-arthritic anterior ischemic neuropathy, but this is usually managed by the ophthalmologist. But if you have somebody who is losing vision, you do need to refer them to the ophthalmologist. It's important to counsel the patients on whom you are starting weight reduction medications. The doctor-patient relationship is really important because we need to be very honest with our patients and, of course, empathize with them, because this is not something that is very obviously seen. It's not a disability that is very obvious unless you have a diabetic ulcer or you're using crutches. And the questions that most often people will ask is, can you treat this? And of course, if there is an underlying diabetes or there's alcohol dependence or a B12 deficiency, then those things can be treated. But the vast majority of axonal neuropathies do not have a treatment. And again, when you talk about the symptoms, there are pharmacological measures and non-pharmacological measures. So non-pharmacological measures, you do need your multidisciplinary input with physiotherapists, occupational therapists, the right foot drop, a foot up splint may be helpful, gaining confidence with your gait, with your posture. And we must discourage people from going on the internet or TikTok to find various things that would help, because quite a lot of them are scams actually. Pharmacologically, in the GP world, amitriptyline, nortriptyline, antidepressants such as duloxetine, carbamazepine, anti-epilepsy medications, those can be used. However, for specialist settings, it is best that they are referred into if you come to a roadblock, it is best that you refer to either to a pain clinic or to the neurologist. And there is the WHO pain ladder that is usually used. I'd just like to show you this image. These are, I think I showed these last year when I had come to Dubai, and we were building the most beautiful center called the Rob Barrow Center for Motor Neuron Disease. Rob Barrow, as you know, is a very famous rugby legend in the UK, and unfortunately he passed away a couple of years ago, and we built a center in his name. And we opened the center in November 2025 with Prince William, His Royal Highness Prince William coming in December 2025 to formally inaugurate it. And we run the motor neuron disease service from the center. Thank you.
We'd like to thank Dr. Agam Jung for her presentation about peripheral neuropathy. It was a nice and comprehensive review. With this, we conclude this neurology session. And for the sake of the time, we are going to move for the next presentation, which is going to be it's going to be about advancing peripheral neuropathy diagnosis from complex diagnostic tool to practical patient-centered screening approach. And it's going to be a sponsored symposium. So we invite the audience to join Dr. Prof. Riaz Malik. Welcome everyone. Thank you.
And he has obtained his MRCP, PhD, and FRCP. He has served as a professor of medicine and consultant physician at the University of Manchester before joining Weill Cornell University in Qatar in 2014, where he currently serves as a professor of medicine. He has received international recognition for his research in diabetes complications, diabetic neuropathy, and peripheral neuropathy. Professor Malik has also had research published in around 574 peer-reviewed papers and focuses on the pathogenesis, assessment, and treatment of diabetic and peripheral neuropathies and neurodegenerative disorders. So we're blessed to have Dr. Riaz Malik, Professor Riaz Malik with us today. So over to you, Prof.
Okay, so let me just share my screen. And Assalamu alaikum, everybody. So, I know you just had a session on diagnosing peripheral neuropathy, but I want you to not forget all of that, but hopefully stay with me. And I would say challenge the dogma that you may or may not have heard. So I'll start with my disclosures, which are that I do receive advisory board, and I've done lectures, particularly thanking Procter & Gamble for giving me actually a platform to speak about my research. And that's what I'm going to talk to you about. But if you forget everything else, remember this, that the World Cup has started, and I am a Manchester United fan.
I just can't believe what I've seen. Only Wayne Rooney can produce a...
Okay, so that's the scene set. And my title, of course, is Challenging the Dogma. So if you know what dogma means, then you know what I'm going to talk about. And that essentially is that a dogma is a belief or set of beliefs held by a group or organization which others are expected to accept without argument. And unfortunately, in religion, in medicine, we kind of fall into that trap where we believe something that this is an absolute truth, and we then prevent ourselves from progressing actually by believing in the dogma. And that's what I'm going to challenge, hopefully. So how am I going to challenge the dogma? Well, it's really looking at how we might better diagnose both peripheral and central neurodegenerative diseases. So if we look at peripheral neuropathies, of course, diabetes is the number one, and that's where we've started. But there are other neuropathies that we've worked on, including idiopathic neuropathy, chemotherapy neuropathy, and HIV and AIDS, and I'll show you examples of that. But if we first of all look at diabetic neuropathy, often termed the Cinderella complication in relation to the other microvascular complications of diabetes. Why the Cinderella complication? Well, I believe fundamentally, the most major difference, I would say, between neuropathy and retinopathy and nephropathy is around how we diagnose this condition. So if we look at retinopathy, we have digital retinal fundus photography, we have OCT, allows you to identify disease at the very earliest stage. Diabetic nephropathy, we have microalbuminuria, we have EGFR. Again, you can detect the disease many years before it manifests in what you would call serious clinical problems, such as end-stage renal failure. Neuropathy, unfortunately, we still rely on a clinical examination, monofilament. Now, what is the issue here? Well, the issue is that the monofilament is great to pick up people who are at high risk of foot ulceration, but it's not good for identifying early neuropathy. And therefore, we have late diagnosis. We have patients who suffer for long periods of time, failed clinical trials, and no FDA-approved treatment. What is the major consequence of getting it wrong for diabetic neuropathy? Well, of course, it is this outcome. And unfortunately, if you diagnose people just before they're about to develop an ulcer, then honestly, there is very little you can do to prevent this major complication. And therefore, I put to you a quote from Machiavelli, who said, "As the doctors say of a wasting disease, to start with, it is easy to cure, but difficult to diagnose. After a time, unless it has been diagnosed and treated at the outset, it becomes easy to diagnose, but difficult to cure." Shall I just say that again? Well, basically, what it's saying is that it's no point diagnosing a disease when it's too late. So what you need to do is change our mindsets to say, well, you know what? We need to be diagnosing this disease earlier, and particularly diabetic neuropathy. So we actually thought about this maybe 2, 3, 4 years ago. We said, well, what are we doing wrong? Why aren't we diagnosing diabetic neuropathy actually in primary care? And it was a call to action. And actually, it's not just in, you might say, well, it's just in areas of the world where we haven't got facilities, we haven't got access. It's actually all over the world. If you look, USA, Qatar, Hong Kong, Taiwan, Germany, the lack, people not being diagnosed with diabetic neuropathy is anything from 80 to 90%. Is it because we have a lack of facilities or ability to be able to do this? Well, no, because I think, we've got plenty of questionnaires. They're all pretty sensitive, pretty specific, a whole range of questionnaires. But then why are we not diagnosing these patients? Well, I believe, again, sometimes, honestly, you have to kind of think outside the box. It doesn't have to be rocket science, but you have to get advice from outside. And I believe one of the issues is in the current way we do this. That is, physician sits in behind the desk, patient comes in. If the patient says, oh, I've got pins and needles, pains, they may ask about diabetic neuropathy, but more often than not, it's ignored. And we need to change that. So working actually with Procter & Gamble, we have developed a simple, very fast questionnaire, which is first of all given to the patient. And the patient then already scores it and says, look, I've got this score. It is abnormal. Now you need to do something about it. So this is now currently being validated: Qatar, India, Philippines, Thailand, Brazil, and Ecuador. What we've done is compared it against, say, the MNSI, which is a kind of the gold standard. We know this takes 8 minutes. And we also know 8 minutes is far too long in any primary care facility for somebody to be administered something like this. The ACT questionnaire, 2 minutes, 20 seconds. This is the first validation that we've done in Qatar, but we also have now completed the validation in India, in Thailand. Brazil is almost finished. Ecuador is done. This is 126 patients, typical patients that I would see in my clinic. We've given the MNSI and the ACT. And what do we find? Well, first of all, despite the fact that it's taking a quarter of the time, ACT is as good as the MNSI for reproducibility and repeatability. And if you use the MNSI as the kind of gold standard to diagnose, having taken 8 minutes, actually ACT performs very well. That is with sensitivity, 90%, specificity of 70%. So that is questionnaires. So what about objective diagnostic tests? Well, current diagnostic approach, I hope I've convinced you, has failed. Why? Because when we diagnose diabetic neuropathy, this is often too late. So what we need to be doing is diagnosing patients when they still do not have apparent clinical neuropathy or they have minimal early neuropathy. And so therefore, honestly, neurological exam, vibration perception, monofilament has got to disappear from our vocabulary as a way of diagnosing what we call diabetic neuropathy. This is all right for advanced people, advanced disease, but no way near good enough to identify early disease, which actually forms up to 20 years before we are currently diagnosing this. Why are we getting this wrong? Well, one of the key reasons, I believe, is because we have this unhealthy focus on large fiber function. And so, we use tests like neurological exam, monofilament, vibration perception, nerve conduction. What do they focus on? Well, the A beta fibers. They ignore the small C fibers. Is there a difference? Of course there is. Why? Because small fiber damage is actually occurring at the earliest stage. I.e., at that time, 15, 20 years before we get damage to these large fibers. And this, of course, is traditionally been believed to occur in the skin, C fibers in the skin, for which you need a skin biopsy. But we know small fiber damage underlies pain, but it also regulates blood flow and sweating. And these are all key to a major outcome, which is foot ulceration, which we're trying to prevent. So small fibers have pathophysiological relevance, but they also are damaged early. So now I put up a video of a famous scene actually from the film Gladiator. And I do it because you'll see in this video, there is Marcus Aurelius, who's a famous philosopher and Caesar actually, who said, we need to learn to measure what we value, not value what we can easily measure. And actually he appears here now. This is Marcus Aurelius. And so, you know, what are we measuring in diabetic neuropathy? We're measuring using the monofilament, but if it's not actually of value, then why do we do it? So in 2001, we had this crazy idea, and it really was crazy. We thought, you know, instead of looking at the feet, why don't we look at the eyes, and particularly the cornea? And why would we do that? Well, because actually we had a technique, or I'd been introduced to a technique called corneal confocal microscopy, which is a non-invasive, rapid, simple test which images the nerves in the cornea. The nerves in the cornea are actually small C fibers, so therefore they are damaged early. And we can image them without taking the tissue out, as you would with a skin biopsy, and we can literally interpret them now in seconds. And so what you start with is an image of the cornea, and we essentially we have a protocol, you collect these images, and the white lines that you see are actually nerve fibers. And what we developed then, 20 years ago, was actually a way of quantifying how much nerves there are here. So corneal nerve fiber density, which is in red, corneal nerve fiber length, which is the total length of nerve fibers, and corneal nerve branch density, which is the branches, gives us an overall quantitative assessment of how much degeneration is occurring in the nerves and how much regeneration is occurring in the nerves. So we began this in 2001, and it wasn't me, it was actually a colleague of mine who was in a department of optometry. They simply actually were able to just show that they could image these nerves. We then ran with that idea and said, okay, how about we look in diabetes? And when we did, we published our first paper, which basically showed that if we take diabetic patients who have no neuropathy, mild neuropathy, moderate neuropathy, and severe neuropathy, what you see is that already, even in people who have no apparent neuropathy based on nerve conductions, based on quantitative sensory testing, symptom signs, they already have a reduction in nerve fiber density and length. And that progresses with increasing severity of neuropathy. So we had proof of principle that here's a technique you can use quickly, you can image nerves, and you can actually detect early subclinical disease. So then begins, it's never easy to challenge the dogma. So I like to put this video up. It literally is, I would say, 20 years of trying to convince people. It's not quite like going to war, but sometimes it felt like that. Okay, so if you are going to challenge the dogma, you need to, first of all, I would say, go up against the gold standard. And the current gold standard, all neurologists will tell you, for small fiber damage is skin biopsy. So we've done the studies, compared CCM with skin biopsy, and what do we show? In the same patients with diabetic neuropathy, two different cohorts, CCM, skin biopsy. The data speaks for itself. I don't want to listen to interpretations of people who are experts in the field. Just look at the data. CNFD, sensitivity, 0.79, 0.77, specificity point. INFD is actually lower, right, compared to CNFD. So CNFD, corneal confocal microscopy, is at least as good as skin biopsy. Now, that was the first study I showed you in 2003. There are now being 38 studies, 4,000 patients, systematic review, meta-analysis in diabetic neuropathy, which basically tells you that we and others have recapitulated what we found, which is that in diabetic neuropathy, we can actually now, first of all, compared to healthy controls, people with diabetic neuropathy, you can use CCM to differentiate on all three parameters: corneal nerve fiber density, fiber length, and branch density. But also, even people with subclinical, you can now differentiate them from healthy controls. So that's picking up early disease. So that's 4,000 patients, but now there's been actually a study from Maastricht which involved 3,400 people who've undergone corneal confocal microscopy. And these are also not just type 2 diabetes, but pre-diabetes as well. What do they show? Well, essentially, that corneal confocal microscopy is now able to, it shows that there is a reduction in nerve fibers according to your, whether you have type 2 diabetes, but also even pre-diabetes, it's lower, and also in relation to different measures of metabolic control. So that includes the 2-hour post-glucose, HbA1c, and skin autofluorescence. So essentially, in a very large population-based cohort, you can see now that we are able to show that in pre-diabetes, there's already damage, which is very early, and even in diabetes, there is also damage. And then, as with, I mean, before AI became a buzzword, actually, way back in 2010, we thought, you know, at the moment, we're looking at these images and somebody's having to kind of trace these images. Can we make this process easier? We can, because machine learning came to our rescue. So the same images, an AI algorithm looks at them and is able to identify exactly where the nerve fibers are, but not in taking 30 minutes, but taking 25 seconds. And now it's down to about 3 seconds. And essentially, what we showed is that the automated machine learning AI-based algorithm was as good as the manual way to assess or quantify these nerve fibers. And we actually provided software which is free to the whole world, and we've had thousands of downloads now, basically to use to generate the body of evidence that we have. And we moved on from that, actually, where we used AI to identify abnormalities, but also to pick up the early disease. So rapid automated classification, using something called logic-based fuzzy inference, AI. We use deep learning on these images, and what do we show? Basically, comparing controls to people with diabetic neuropathy, 100% sensitivity and 95% specificity. And even differentiating people with and without diabetic neuropathy, that is people with diabetes, but some without, some with, there is a differentiation of 92% sensitivity and 80% specificity. Clinically, I told you that small fibers are important for pain. Well, is there more damage in the corneal nerve fibers in people with pain? Yes. And multiple reports now all show that in people with painful diabetic neuropathy, you can see here, compared to painless diabetic neuropathy, compared to healthy controls, there is a steady but progressive loss of nerve fibers, worse in those with painful neuropathy on all 4 parameters, actually: nerve fiber density, branch density, length, and inferior wall length. Furthermore, we've shown, I would say, excellent sensitivity and specificity for differentiating people with and without painful neuropathy. Now, that you might look at the AUC and think, oh, 0.74, 0.75 isn't great, but I can tell you skin biopsy is as low as 0.5, 0.6. Furthermore, the more severe the pain, the greater the loss of nerve fibers. And cardiac autonomic neuropathy, which, you know, is really, it's not a small fiber neuropathy, but it's small fibers. Have we shown whether there is a difference? Yes. Recently, we published a large study comparing people without cardiac autonomic neuropathy, early cardiac autonomic neuropathy, and definite cardiac autonomic neuropathy. What you show is progressive loss of corneal nerve fibers, and moreover, the gold standard, which is heart rate variability, Valsalva ratio, all of them were as comparable to corneal confocal microscopy, actually, in terms of their sensitivity and specificity. So deep breathing heart rate variability, EI ratio, 30-15 ratio was good, but CCM was as good. Then you would want to show, actually, I think, it's all very well showing that there's an abnormality in people 20 years before they developed diabetic neuropathy, but is that true? Well, yes. So this is a large NIH-funded multinational consortium study where we took 998 people with type 1, type 2 diabetes. 261 at that stage had no clinical, neurophysiological, or QST-based evidence of diabetic neuropathy. Followed over 5.8 years, 23% developed diabetic neuropathy. So now we have a study which is longitudinal and is maybe could be used to predict, you know, whether or not CCM can predict diabetic neuropathy. Well, what do we find? In short, we show that, yes, there are some tests like neurophysiology that might predict, but corneal confocal microscopy now actually predicts the people who develop diabetic neuropathy. So 5.8 years before they develop diabetic neuropathy, already the people who are going to develop diabetic neuropathy have lower nerve fiber density, branch density, and length. So whilst waiting for the FDA and the neurologist to be convinced, we started with diabetic neuropathy in 2003, multiple other peripheral neuropathies, including idiopathic small fiber neuropathy, CIDP, CIPN, Fabry disease, fibromyalgia. All of them have been shown to be potentially, you can diagnose them using CCM. And this is a systematic review meta-analysis we've just published, 51 studies, 2,996 participants in various neuropathies. All of them, apart from a few, show that CCM can be used to identify neurodegeneration in these conditions. Examples, HIV. And we did this study actually 10 years ago. What we showed is comparing healthy controls to people with HIV without sensory neuropathy, there is already actually a subclinical loss, but those in sensory neuropathy, for sure, they have corneal nerve loss. And so there's this progressive loss of nerve fibers. And we also showed, as you know, HIV is an immune process. We also showed something else, which was that there are some antigen-presenting cells called Langerhans cells, which are increased in HIV neuropathy, suggesting maybe some mechanistic basis for the nerve loss. In addition, a not common, but very debilitating hereditary neuropathy called Friedreich's ataxia. In New York, we actually undertook this study because we're doing a gene therapy program there. And what we showed is basically that corneal confocal microscopy actually can show again reduction in corneal nerve fiber density, fiber length, and branch density in participants with Friedreich's ataxia compared to controls. Moreover, patient function, the SARA and the FAS score are established neurological scores of the degree of disability that these patients develop. Guess what? Corneal nerve fiber length correlates beautifully with both the SARA and the FAS score. So there is a relationship between structural abnormalities and function. And moreover, a mechanistic link, well, we know that underlying this neurological problem is the number of GAA repeats. Guess what? There is a correlation between, so actually what is known is the more the GAA repeats, the greater the disability. Well, the more the GAA repeats, the lower the corneal nerve fiber length. Chronic inflammatory demyelinating polyneuropathy, by its very name, would say, oh, this is a demyelinating large fiber neuropathy. And in fact, that's what Mark Stettner, a good friend and colleague, said to me. He said, Riaz, it can't possibly, CCM can't be abnormal. But actually, they did the studies. And what did they show? Well, we all showed that if you take people with CIDP and you scan their corneal nerves, there is a reduction in CIDP, monoclonal gammopathy, and multifocal motor neuropathy compared to healthy controls. And there is an increase in dendritic cells, again, suggesting that we can pick up underlying inflammation using, not just looking at nerve fibers, looking at these cells. And moreover, the same group actually then went on, or a different group actually, in Germany, looked at the, I would say, looked at the cells to see whether they could predict those people who were not going to do as well. And what did they show? Well, total cell count, if you progressed, it was much higher than if you were stable. So I know what you're thinking. Oh my God, all of these conditions, Riaz Malik and his colleagues have shown that it's abnormal in HIV, CIPN, CIDP. How do you differentiate these conditions? Well, honestly, the human eye or me or our data found it very difficult. So we had people with CIDP, CIPN, diabetic neuropathy, HIBS. They were abnormal compared to healthy controls, but really, we couldn't really differentiate if these were different between each neuropathies. And that's where AI comes to the rescue. we've now used what's something called vision transformers. And vision transformers, what they do is they go beyond just looking at nerve fibers counts. So what they do is they look at visual patterns relevant to the underlying biological process. They look at the texture, the shape, spatial relationship between nerves. And when they do that, it's amazing. What you find is that based on that kind of almost fingerprint, now we can differentiate whether somebody has CIDP compared to not just controls, but with other neuropathies, with almost like above 90% sensitivity specificity. And this is actually another way of looking at it. And here you see it. This is stochastic neighbor embedding, TSNE. You can see very clearly all of these groups, whether they're CIDP in red, CIPN in green, DPN in blue, HIVSN in purple. And yes, there are one or two that the so-called healthy controls fall in, but overall, you can see really differentiates the two. So that's peripheral neuropathies over. What about central neuropathy? Well, when I arrived in Doha in 2014, I wasn't really bored, but I was asked by one of my colleagues whether or not maybe could CCM be used for central neurodegenerative diseases. Why? Well, I guess an easy way to look at it is that the cornea is not very far from the brain. But what we've done is looked at a number of conditions, including dementia, Parkinson's disease, multiple sclerosis. Multiple sclerosis, we were the first group to show in 2017 that there is an abnormality, and I'll show you the data, in multiple sclerosis in corneal nerves. But we and others have now shown it in dementia, in motor neuron disease, autism, schizophrenia, Parkinson's disease particularly, a migraine, epilepsy, and COVID-19. And now there is an increasing body of data to support this. For Parkinson's disease, actually, I started this study in Manchester with colleagues in Manchester. And what we showed is, in a first proof of principle study, that there is actually a significant reduction in corneal nerves in people with just common or garden Parkinson's disease. And it correlates with autonomic dysfunction. Furthermore, in a follow-up Michael J. Fox Foundation funded grant, we were able to show in a longitudinal study that corneal nerve loss, in the worst corneal nerve loss, in the lowest quartile, predicted motor progression. So this is 64 patients, baseline, followed up over 12 months. What we showed is, first of all, in Parkinson's disease, there is less nerves, but in those in the lowest quartile, actually, they were the ones who had the greatest progression in UPDRS. And together with colleagues in China, actually, we've now shown that corneal nerve loss differentiates different motor subtypes of patients with Parkinson's disease. So as you know, there are tremor dominant, there's a number of variants of Parkinson's disease. And what we showed is that compared to tremor dominant, PIGD, and mixed forms, there are differences, particularly in the I would say the PIGD form, that there's less nerve fibers. And actually, we can differentiate the tremor dominant from the PIGD forms with very good sensitivity and specificity, apart from branch density, which is a bit complicated, but I won't go into the details of that. What about multiple sclerosis? Well, we started in 2017, but this is a follow-up study, which was basically recapitulates what we've shown. In people with relapsing, remitting, and secondary progressive, particularly secondary progressive, there is corneal nerve loss, which is the greatest compared to healthy controls. But even over longitudinal changes, we see that there's progressive loss of nerve fibers, particularly in the secondary progressive ones, which is what you'd expect, that the underlying pathology is getting worse. And moreover, this is the rate of loss of corneal nerve fiber length is actually related to disease activity based on new gadolinium enhancing lesions. Dementia, well, Bill Gates was asked to invest about $100 million into this many years ago. And he actually came up with the same kind of thinking that we've had, that when we diagnose dementia, it's far too late. So symptoms are, showing 20 years probably before the disease process started. And he suggested reliable, affordable, and accessible biomarkers have the potential to revolutionize how we approach Alzheimer's disease. Well, what do we see in dementia? Actually, when we compare mild cognitive impairment and dementia with healthy controls, we see a progressive loss of nerve fibers. Here, you can see. But also, there is a correlation with cognitive decline. And when we compare with MRI, which of course in MRI, in dementia, you see this cortical atrophy, and particularly in certain hippocampal areas. Well, actually, in mild cognitive impairment, you see very little change in terms of MRI. So maybe whole brain just about is less, but hippocampal volume is normal, gray matter volume is normal. But already in these patients, corneal nerve fibers are reduced. And particularly in dementia, of course, they are further reduced. So again, coming events cast their shadows. So we've got 107 people with MCI. This is a study done in Qatar, followed over 2.6 years, much like the diabetic neuropathy longitudinal study. 30% developed dementia. What did we find? Well, actually, corneal confocal microscopy showed that those people who had mild cognitive impairment who developed dementia already had lower counts for nerve fibers, as good as hippocampal volume, whole brain volume. So CCM is able to predict the development of dementia. And again, I know what you're thinking. Well, he's shown it in MS, PD, dementia. Can this be differentiated? Absolutely. This again is AI-based, where we're able to now show actually sensitivities and specificities for MCI and dementia 0.93, and 0.96, MS 92 and 95%, PD was 100%. So with 100% sensitivity specificity, I can tell you whether a patient has neurodegeneration due to PD based on AI. So what started off as a crazy idea in Manchester kind of migrated to Australia because my colleague Nathan Efron, who introduced me to this, moved to Australia and continued his work there. And then it's kind of grown and grown and grown. And now there's a lot of centers doing this. So this is my last slide, future, what I'm going to coin neurooculomics. You're going to have people who are going to have maybe the ACT questionnaire to get us through the door. And of course, the ACT questionnaire has been validated in Arabic now as well. So it's available to people. They will then undergo, if they're positive, maybe, CCM. AI will tell us whether or not you're healthy. If you are, go away. If you're not, you have an abnormality. AI will then again help us to identify whether or not you have abnormalities from a particular disease. Is it diabetic neuropathy? Is it some other peripheral neuropathy? Is it dementia? Is it PD? Is it MS? I know what you're thinking. How much does this cost? How accessible is it? Well, I'm going to give you an example, actually. This is a picture you see of Chinese cars. Chinese cars you would never have thought would have made it in kind of the so-called first world. Well, we now have actually a Chinese camera, CCM, which is going to replace the current HRT3, which was actually a German machine. Muhammad Ali said, "He who is not courageous enough to take risks will accomplish nothing in life." Thank you. So I'm happy to take Q&A. Is somebody going to...
So I'll help you out. Thank you for the very nice lecture. So the first question is, what is the biggest dogma in peripheral neuropathy that you believe should be, abandoned for practice?
Monofilaments. They are not a test for early diabetic neuropathy. They are a test for picking up advanced disease. And if we're happy continuing to do that, then actually, no, I was going to say that's fine, but it's not fine. We are actually not doing our patients a service. I mean, we kind of talk the talk, oh, personalized medicine and, early detection, but we don't actually do it. So unless we change our mindsets, then we're going to continue to do what we've been doing for the last 50 years, and people are going to continue to develop foot ulcers and ulcers and amputations.
Okay, thank you so much. Interesting. Which investigation do you find most informative when the diagnosis is unclear?
Honestly, people, again, it comes back down to what are you trying to detect? Well, if it's pain, you want to detect some aspect of small fiber damage, right? So if somebody's got painful neuropathy, it is useless to be doing EMGs, right? Nerve conductions, because they are measuring large fibers, completely a different fiber subtype, right? So you need to think a little bit of what you're trying to diagnose. And again, early damage, small fibers are affected early. Then you're left with, well, which small fiber test might you do, and what's convenient, what's doable? Of course, in the clinic, even if you did just an assessment of thermal, kind of not thresholds, but just sensory testing, that gives you a starting point. Then, if that's just in the clinic, then of course beyond that, quantitative sensory testing, maybe, but again, that's quite variable. For me, I live in a nice world where I've got corneal confocal microscopy next door to my clinic, and I actually send my patients in there and I have an answer, like within literally minutes. Skin biopsy, of course, some people would say, but that's not really something I think is practical.
Thank you so much. Next question. Thank you for this interesting presentation. Really great topic. What is the role of heart variability, measuring via heart rate sensor device, in diagnosing diabetic peripheral neuropathy or autonomic neuropathy?
Well, we know if you measure heart rate variability using in the paradigm of cardiac autonomic function testing, that heart rate variability is reduced because of parasympathetic dysfunction in people with cardiac autonomic neuropathy. Now, can you then take that and say, okay, I've got this, watch or a sensor that I can put on that we know works out heart rate variability? Possibly, but I'm not sure the big studies have been done. I think that probably is a good way to start to kind of generate some data. And I'm sure it's already there. Maybe I just haven't seen it. But yeah, heart rate variability per se is a good measure of overall sympathetic parasympathetic dysfunction.
Thanks so much. What's the relationship between small fiber neuropathy and diabetic neuropathy? And should we treat them as the same or not?
It depends on whether you want to be a purist and you want to say, I'm a neurologist, small fiber neuropathy is characterized by small fiber symptoms, which is an essential part of it, and small fiber abnormalities based on skin biopsy. If you're gonna have that purist attitude, then no. But to me, when I look at diabetic neuropathy, I think of small fiber damage, which is clearly there and is actually there very, very early. So for me, that is really what we should be doing going forward. I want to see a world where hopefully there will be more corneal confocal microscopes everywhere, and you'll have it. Honestly, I see it as we went 20 years ago. Nobody used to talk about retinal screening, right? You all used to be, digital retinal, not digital retinal fundus photography, ophthalmoscopy, and people say, oh, we don't need to do, assess the retina and things. Now, we've got diabetic retinal screening programs. Why can't we have alongside that a CCM that's doing assessing the corneal nerves at the same time?
Next, how practical is it for a general physician, not a neurologist, to screen for peripheral neuropathy in a busy clinic, do you think? And this is, I think, an important and practical question for our audience today.
Well, that's actually where I've deliberately had the talk in two parts, which is the first bit, which is the simple questionnaire, the ACT questionnaire, which we've developed to answer, to help with that general physician who's busy in their clinic, because what will happen is that the questionnaire component, the patient themselves will already have filled it out. They will come into you and literally you will already have a score. If that score is abnormal, you then have to do a very quick sensory exam, right? Touch, pinprick, that's it. And if that's abnormal, you refer them. So it's easy. You don't have to, spend hours. Even actually, I think, I'm not sure even if you need to have the physician bit in there, you could have somebody in the clinic who's actually doing the sensory exam as well. So that, that is where I think if we change the pathway, we will then now be able to address this issue, because that's the big issue. I mean, when I have a patient, say, for example, me, diabetic patient, by the time I've dealt with their blood pressure, which I'm aware of because they've already had it done, their lipids, they've had their blood tests, and their HbA1c, I don't have time to ask about diabetic neuropathy.
Absolutely. So next is, I think we have so many questions, so I think we have time for one more. In addition to good diabetic control, what medication is best recommended to arrest nerve damage at subclinical disease to avoid overt clinical manifestations?
Okay, so good glycemic control, but I think it's really important for you to get this clear. It is good glycemic control using medication which does not cause weight gain and actually promotes weight loss. So we have got data very clearly showing that people, if you treat them with an SGLT2 inhibitor, regenerate nerves, GLP-1 and GLP-1 GIP therapy, whether it's semaglutide or whether it's tirzepatide, also regenerate nerves. So that's glycemic control. I have got data actually way back 20 years ago where we published with an ACE inhibitor showing that there's an improvement. And there is also data with fenofibrate and omega-3 showing that there is regeneration of nerves.
Fabulous. Thank you so much. Such a rich presentation. It's truly a pleasure for you to be with us. And I'm sure there are still many more questions. I think we can, forward them to the P&G team. Maybe they can forward them to you. Thank you so much, Professor Malik. It was really a pleasure to have you with us again.
My pleasure.
Thank you, everybody. Next, we're going to have the cardiovascular session. So I would invite you to go back to the main stage and join the cardiovascular session. Thank you so much again. Bye-bye.
Thank you. Bye.
Morning, everybody, and we're still on session 5, going great. I hope everybody is still excited and happy to shift into the cardiology and the cardiovascular session. And I would like to introduce our moderators for this session, Dr. Yasser Parvez, who's a consultant interventional cardiology and head of cardiology department at Emirates Hospital, Dubai. He holds a UK board certified interventional cardiology and has more than 20 years of global experience across the UK, US, Canada, and the UAE. We have also Dr. Fatima Nabavizadeh. She's a consultant cardiologist and head of cardiology at Dubai London Hospital. She has over 20 years of clinical cardiology experience in the UAE and a fellow of the European Society of Cardiology and active researcher with publications in leading medical journals. Please join me in welcoming both our moderators, and the floor is yours.
Thank you.
Thank you very much. Good morning, everyone, and welcome to session 5, continuation of session 5. So I would like to introduce the first speaker, Dr. Hilal Al-Safar, consultant cardiologist and fellow of the American College of Cardiology, founder of RCP Iraqi Network, and he will speak on ACS for general physicians. Dr. Hilal Al-Safar, please. If we can start the talk for Dr. Hilal.
Hello, everybody. I am Dr. Hilal Safar, consultant cardiologist, international advisor for the RCP. I am privileged today to present at this prestigious conference an important topic, which is acute coronary syndrome for general physician. I have nothing to declare. To start with, I am living in this lovely city, Baghdad, with a more than 1,000-year history, and I am working in this lovely university, Al-Kafil University. The learning outcome of this presentation will be first is that to recognize and rapidly evaluate patients with acute coronary syndrome. The second one is that how to interpret the ECG and high sensitive serum troponin to distinguish the type of the acute coronary syndrome, and then apply the rule in roll-out diagnostic pathways, and then to apply an evidence-based medicine approach to the management of a patient with acute coronary syndrome, including the type of the medication to be used and invasive versus conservative strategy, also identifying the pitfalls that's commonly encountered in patients during diagnosis or the management, and lastly, how to integrate secondary prevention strategy into our routine clinical practice following the acute coronary syndrome. To start with, the definition of the acute coronary syndrome is that a clinical spectrum results from rupture of atherosclerotic plaque with the superimposed thrombosis leading to occlusion of the coronary artery. The occlusion could be partial or complete, and depending on that degree of occlusion resulting the clinical condition. So either we will end with a STEMI, which is ST elevation myocardial infarction, where the occlusion will be complete and the ischemia will be full thickness of the ventricle. On the ECG, there will be an ST elevation and there is rise and fall in the troponin level. The second clinical category will be an STEMI, in which there is a partial occlusion and there is subendocardial ischemia with the changes will be ST depression and T-wave changes, and also there is a rise and fall in the troponin level. The third category will be an unstable angina, where we will have either transient complete occlusion or critical stenosis. Here we have no necrosis, so therefore the troponin level will be normal. And the ECG changes, again, similar to the anastomia. We will have ST depression and plus minus T-wave inversion. We commonly encountered, or can recognize patients with the classical presentation of ischemic chest pain, its site, radiation, severity, and duration. But we have to think about those patients presented with atypical presentation, and this is the very important one because they have no chest pain. They present with dyspnea, epigastric pain, nausea or fatigue, sometimes syncope or generalized weakness. And who are the category who are more liable to present with atypical presentation or atypical syndrome? They are the women, because frequently they present with dyspnea rather than chest pain. Elderly patient frequently presented with fatigue and sometimes syncope. Diabetic patient because of the high chance of silent ischemia, and those patients with the chronic kidney disease, more than 30% of them will pass into acute coronary syndrome. Also, I have an example. If you are a physician in charge and you encountered at 2 a.m. a patient about 58 years old with a classical presentation of ischemic chest pain for more than 45 minutes. He has many risk factors, diabetes, hypertension, smoking, and his vitals saying that there is mild hypertension, a bit tachycardia with a normal oxygen saturation. So what is your immediate concern? So definitely the answer will come. The immediate concern in this patient is that acute coronary syndrome have to be excluded because early recognition will save the myocardium. And the clock will start at the first medical contact. Therefore, within 10 minutes, we have to do the followings: assessment, ABC assessment of the patients, cardiac monitor, IV access, focus history, 12-lead ECG, and high-sensitive serum troponin should be sent within 10 minutes from the first patient contact. And the learning point is that this is a quick action because it will save the myocardium, because delay in doing these steps, it means myocardial damage more and more. We may use the mnemonic of ACS, similar to the acute coronary syndrome, where the A point to any abnormality in the ECG. Quickly look if there is any ST segment elevation, because any ST segment elevation or equivalent, it needs an acute urgent reperfusion. The C comes from the clinical context. What is the character and the radiation and the severity of the pain, plus the presence or absence of comorbidity. And the S comes from the stability of the patient, whether he is hemodynamically stable or not, there is cardiogenic shock or not. This is very important. These three letters is very important in the initial assessment of the patient with acute coronary syndrome. And as I said, within 10 minutes, we have to have all things set it up, like IV access, cardiac monitor, the defibrillator is ready, and we may give a loading dose of aspirin, 300 milligram, but please don't give oxygen if the oxygen saturation is not less than 90%. Now, this is the first ECG. After 10 minutes from arrival, you can see that the ECG is normal and the cardiac troponin of this patient is still within the normal. But 1 hour later, you can see this patient having significant ST elevation in the 2-3 AVF leads, as well as reciprocal changes in the lateral leads, and the serum troponin becomes double. So there is no doubt this patient sustained an acute inferior STEMI. And since we diagnose acute STEMI, that means immediate reperfusion is needed in this patient, because muscle means time means muscle. The longer the time, the more the muscle damage in this patient. Now, if we go back to the ECG, what the things not to be missed and to be looked for. Usually, any ST elevation in any lead more than 1 millimeter is significant, with the exception of V2 and V3, we need more than 1 millimeter. And the changes, it should be in more than or at least 2 contiguous leads. We have to keep in mind that the first ECG with the first contact may be normal, and therefore we have to take serial ECGs within 15 to 30 minutes interval. And always, if we have an old ECG, we have to compare the changes. This is very useful, reaching the clinical context. Then, what things not to be missed? Things not to be missed, which is called the STEMI equivalent, is that posterior MI, the changes will be in V1 to V3, but they will be an ST depression rather than ST elevation. If we have an hyperacute T wave, this might indicate impending acute STEMI. Also, if we have an ST elevation in AVR with a widespread changes in the other leads, it might indicate left main stem, which is a very serious diagnosis. There are 2 syndromes can be diagnosed from the ECG. I will come in the next slide talking about them, which is the De Winter syndrome and the Wallen syndrome. But if you have a left or right bundle, this may mask the ST segment elevation of the STEMI, and therefore you have to go to the Zgarboza criteria to know whether it is ischemic or not. The other thing is that you have to think of right ventricular infarction. If there is any suspicion, you have to take right-sided chest leads. Now, the first syndrome that we have not to miss in the ECG is that the De Winter syndrome. This resulted from a critical total occlusion of the proximal LAD. But instead of ST elevation, there will be ST depression in V1 to V4, with a rapid upslope of the ST segment accumulating in a hyperacute T wave. Those patients should be treated as if they are STEMI. Immediate reperfusion is needed in those patients. The other syndrome is that the Wallen syndrome. In those patients, there is a critical stenosis in the proximal LAD, and they will have either deep T inversion or biphasic T wave in lead V2 and V3. Those patients usually have these changes during the pain-free period in between the chest pain. So be careful. Those patients usually have negative troponin. Don't exercise them because it may lead to a total occlusion. So these two syndromes have to be looked and not missed from the ECG. If we go back to the troponin, the two pillar, troponin and the ECG. Now to the high sensitive troponin. We have to do the troponin on serials, 0 time on contact, and then after 1 hour, and then after 2 hours. And then we will have two options, either rule out, there is no acute coronary syndrome, or rule in. If the initial troponin is very low, and there is no increase in the serum troponin after 1 hour and 2 hours, then another diagnosis should be taken in this patient other than acute coronary syndrome. And this has a negative predictive value of more than 99%. But if the initial troponin is very high or the subsequent 1 and 2 hours are increasing troponin level, delta, there is delta increase and decrease, then this patient having an acute coronary syndrome and should be admitted and referred immediately to the cardiology unit. What are the common pitfalls from the interpretation of the troponin? First of all, there are other causes apart from ischemia causing elevating troponin, including sepsis, heart failure, and myocarditis. Also, it might increase with age and renal failure patient. Be careful, serum troponin might be negative less than 2 hours from the presentation, and it may come plateau after 12 hours. Therefore, these points have to be kept in mind when interpreting the high sensitive serum troponin. And this diagram will representing what I have just said. Contact time 0, you will have take serum troponin and then serial after 1 and 2 hours, either rule out if it is very low initially or not increase after 1-2 hours, or it is very high from the start or increasing after 1 and 2 hour sample, then you have to roll in. Sometimes a patient may fall in between. Those cases need observation, and we may do another sample at 3 hours. If after 3 hours the serum troponin remains low, that you can exclude acute coronary syndrome. Now we come to the risk stratification of the acute coronary syndrome patient. Usually we use the GRACE score, which is the global strategy of acute coronary event, which use 8 variables, including age, clip class, systolic blood pressure, heart rate, serum creatinine, cardiac arrest, ST deviation, and serum troponin. And then we categorize the patient into either a very high risk group patient, those patients who are hemodynamically unstable or having malignant arrhythmia, they should have intervention and reperfusion within less than 2 hours, or high score patient who calculated score more than 140, they need revascularization within 24 hours, or intermediate risk patient between 109 and 140, they need revascularization within 72 hours, or low-risk patient where the score below 109. Here we have to select another mode of diagnosis like the coronary CT angiography. So we can use this GRACE score into risk stratification of the patient as well as indicating to the time of reperfusion. Now, the initial management should include aspirin with a loading dose and the maintenance of about 75 to 100 milligram per day. A potent P2Y12 inhibitor like prasugrel and ticagrelor might be used, especially in those patients with the invasive strategy and when we know the coronary anatomy of those patients. Anticoagulation, parenteral, might be used in those patients with STEMI, including unfractionated heparin and bivaluridine, or in anesthemy we may use unfractionated heparin, enoxaparin, or fondaparinux. Statin, high-intensity statin, either atorvo 40 to 80 milligram or rosuvo 20 to 40 milligram to be used in order to reach a target LDL of less than 55 milligram per deciliter. Don't use nitrate for a diagnostic tool, and they are contraindicated in those patients with a systolic blood pressure less than 90, or they are suspected to have a right ventricular infarction. As I said previously, no oxygen should be given if the oxygen saturation is less than 90%, because it may cause vasoconstriction. And this will represent the type of therapy that we need. You need antiplatelet and anticoagulant in the acute management of acute coronary syndrome, because both of them have an important role in the pathophysiology of the coronary artery occlusion. Now, if we go to the invasive strategy and reperfusion in those patients, it differs from STEMI than non-STEMI. In the STEMI patient, definitely they will need immediate action, immediate revascularization. Our aim from first medical contact to the wire crossing the lesion, 90 minutes. Door in to door out in non-PCI center, less than 30 minutes. And if you are not able to refer the patient to have PCI within 120 minutes, then you have to give thrombolysis. The thrombolysis should be given within 10 minutes from the first medical contact. And if you have a rescue PCI, if there is failure of a thrombolysis within 60 to 90 minutes. The things is different for STEMI, where we use the GRACE classification, as I said, for high-risk patient, unstable, cardiogenic shock, arrhythmia, usually less than 2 hours reperfusion. Those patients score more than 140 within 24 hours. For those with intermediate score 109 to 140, less than 72 hours. And in those patients less than 109, you may use another mode of diagnosis like coronary CT angiography. The common pitfalls in the management of patients with acute coronary syndrome include nitrate, not to be used for as a diagnostic and contraindicated in the presence of hypotension. Single normal ECG doesn't exclude. 11% of patients with STEMI have initial normal ECG. Therefore, you have to do a serial ECGs within 15 to 30 minutes interval. Early troponin might be negative. Therefore, serial 1, 0, 1, and 2 hours up to 3 hours is indicated. Oxygen therapy not to be given if the oxygen saturation is less than 90%. Beta blocker should not be given to those patients with cardiogenic shock or acute heart failure. There are bad effect on these conditions. Also, you may use antiplatelet, high potent antiplatelet P2Y12 inhibitor if you are going to use the invasive strategy in those patients with acute coronary syndrome. There is frequently bias. Women and elderly receive less aggressive treatment despite there is a highest absolute risk. And then do not stop or down titrate statin when you reach LDL lower than 55, because this is very useful for the secondary prevention. Dual antiplatelet therapy, usually we use dual antiplatelet for 1 year. This is the standard strategy. The maintenance dose of aspirin should be 100 milligram and less, especially if it is combined with ticagrelor. Then we have to balance the patient whether he has a high ischemic risk or a high bleeding risk. For those patients with a high ischemic risk, we may continue a dual antiplatelet for more than 1 year. And for those patients with a high bleeding risk, we may go for dual antiplatelet for 1 month, and then we continue on a single antiplatelet therapy. Sometimes we do de-escalation from a potent P2Y12 inhibitor like prasugrel and ticagrelor to a less potent like clopidogrel after 1 month from those high or potent antiplatelet. Sometimes the patient with acute coronary syndrome may have other indication for oral anticoagulant, like those patients with acute coronary syndrome and atrial fibrillation. Here we have to use a combination of dual antiplatelet and oral anticoagulant for 1 week. And then we continue oral anticoagulant and antiplatelet for 1 year. And this is similar whether it is in European or in the American schools in the treatment. Sometimes the patient, if have a high ischemic risk, we may extend the first 1 week triple therapy to 1 month and then continue for 12 months. Sometimes the patient has a high bleeding risk, therefore we may continue for 1 week triple therapy, and then we shorten the oral antiplatelet and oral anticoagulant for 6 months instead of 1 month, depend on the bleeding or ischemic risk profile. For the secondary prevention, pharmacotherapy is very important, including the dual antiplatelet therapy. As I have just said, we have to give proton pump inhibitor for those patients with high bleeding risk. High intensity statin, if we are not able to reach the target within 55 milligram per deciliter, we may use either ezetimibe or PCSK9 in those patients. Beta blocker, ACE inhibitor, ARBs in those patients with ejection fraction less than 40 minutes. And don't forget influenza vaccine for elderly patients, very important. Cardiac rehabilitation is important whether at home or at a center because it may change the quality of life for your patient. You have to give advice to the patient regarding their sexual activity, going back to work or driving. This is very important. Lifestyle modification, including smoking cessation, Mediterranean diet, and keeping body weight, body mass index less than 25 is important. And we have to look for your patient whether they have any psychological stress or depression. You have to keep your patient as an active part in the management. This is called the teach back technique, where the patient is an active role in his own management. This is very important. Lastly, I will deliver the taking home messages. The first one is that within 10 minutes, you have to do a quick assessment, ACS assessment, do an ECG, IV line, cardiac monitor, and send for serum troponin. And the second thing, urgent revascularization in any STEMI patient or very high risk non-STEMI patient. The golden time for the primary PCI is less than 120 minutes. It's standardized high sensitivity protocol for the troponin, usually on 0 time, 1 hour, and 2 hour algorithm. If they are negative, it has a negative predictive value of 99%. This is very important. Optimizing the antithrombotic therapy, usually the standard or default for 1 month, for 12 months. And usually we have to balance the risk of bleeding against the risk of thrombosis. And then aggressive management of lipids, keeping the LDL less than 55. You have to initiate high-intensity statin at admission. And before all patients, you have to refer them to cardiac rehabilitation and screen for psychosocial health for those patients. And thank you.
Thank you very much, Dr. Hilal. I think that was an important reminder that the first decision in ACS is often made before the cardiologist sees the patient, and it's done by GPs. And it's important to know for GPs and primary care physicians to know that ECG is urgent, but it's not enough, and a normal or non-diagnostic ECG does not exclude ACS. And high sensitivity troponin should be interpreted in the context. I will ask Dr. Yasser to introduce the next speaker and the next talk. Please, Dr.
Thank you, Dr. Fatma. And we'll move on. And the next speaker is Dr. Khaled Sabeh. He's American board certified. After his initial training in Beirut, he moved to US. He's one of the top electrophysiologists here in Dubai. He's completed his initial training in US. Later on, he moved to Harvard Medical School. He did a postdoctoral fellowship there. He's one of the top electrophysiologists and rhythm specialists here in Emirates Hospital Group. He's going to talk to us about updates in dyslipidemia. Dr. Khaled, floor is yours. And he's presenting to us from Beirut, and he's very kind, and he will be flying after the presentation.
Thank you, Dr. Yasser, for your kind words. Good morning, everyone, and thank you to the RCP for this invitation to be part of the Global Update. My name is Dr. Khaled Sabeh. I'm a consultant cardiologist at Emirates Hospital, Jumeirah in Beirut. I have particular interest in preventative cardiology. In the next 20 minutes, I want to take you through what I consider to be the most clinically significant guideline update in preventative cardiology in nearly a decade or so. The 2026 ACC/AHA dyslipidemia guideline, and we will compare it to the European framework. I want to be clear on this. This is not another review of statin therapy. Most of us know statins. What I'm going to be focusing on is what has genuinely changed in how we risk stratify, in how we set treatment goals, in how we choose non-statin agents, and how we manage lipoprotein A. Lipoprotein A, a risk factor that until now we have been measuring, but we haven't been reacting on. By the end of our session, I want you to leave with 5 concrete clinical takeaways. First, you'll be able to describe exactly how the 2026 ACC/AHA guideline differs from the 2018 predecessor. The difference is substantial and it's very clinically important. Second, you'll understand Prevent Calculator. and why it replaced the PCE or the pooled cohort equations, and what it means for the patients and how you're going to treat them. Third, you'll have a working summary of the 2025 and the 2025 European Society of Cardiology focused update. This was added to the 2019 guidelines. We will talk about what was deliberately changed, what was deliberately unchanged. Fourth, and probably this is the most important part, practical part, we'll be comparing the American guidelines versus the European guidelines, what they have in common and how do they differ. And fifth, we'll be looking at the evidence behind modern non-statin therapies and what we should be looking out for. Before we go into the guidelines, I'm going to anchor this problem for us. So as we all know, atherosclerosis is the #1 cause of death globally, causes around 18 million deaths every single year. 1 in 4 adults in the United States and a comparable proportion across the Gulf and Europe have extremely elevated LDL. As we know, LDL is closely related to cardiovascular disease, strokes, and heart attacks. And yet, across every major registry and real-world data, it shows that only less than 50% of high-risk patients are meeting the guidelines for the recommended LDL goals. A landmark meta-analysis by the CTT showed that a drop of 1 millimole, so around 40 milligrams per deciliter, in your LDL can actually decrease 22% reduction in major cardiovascular events, such as strokes, heart attacks, etc. So at the end of the day, it's not that we don't have the pharmacological techniques and the agents to drop, to reduce the risk. It's just that we are lacking in the implementation. And this is where the guidelines and adhering to the guidelines become very important. I'm going to orient you a little bit to the landscape of the guidelines because there's 2 guidelines ecosystems, the European as well as the American. And it's important to understand the structure before we go into the content. On the European side, 2019 ESC guidelines remains the full comprehensive framework. So it's still the baseline that we are referring everything to. However, last October 2025, there was a focused update. And this, we need to be precise about it. This is an additive to the 2019 guidelines. So it does not replace it. It just adds to it. On the American side, the 2026 ACC-AHA guidelines was published in March of 2026, and it is a complete replacement. The 2018 guideline is now retired, completely gone. Everything in 2026 supersedes that of the 2018. Looking into the 2026 ACC guidelines, the first thing that you would notice is that the name of the document was actually changed. 2018 was Guidelines of Management of Blood Cholesterol, while the 2026, it's called Guidelines of Management of Dyslipidemia. And this is not just a cosmetic change. This is a real important change because it is targeting and saying that there are other things than cholesterol, such as LDL, triglycerides, and the lipoprotein A, which will become extremely important in this upcoming guideline. So I'll talk a little bit about the European guideline first. The cornerstone of the European practice is these 4-tier risk stratification. And it classifies patients into these 4 tiers, the very high-risk patients. These are patients who should have a target LDL less than 55 milligrams per deciliter. This applies to patients with established ASCVD, established diabetes with organ damage, CKD with an eGFR below 30, patients with familial hypercholesterolemia plus ASCVD, or a score 2 of 10% or more. These patients should have a LDL of less than 55, as well as a reduction of more than 50% from the baseline. We'll talk about that later. Second risk group is the high risk group, which has a just slightly lower risk. And the target is for LDL is to be less than 70. Again, This is patients who have markedly elevated single risk factors, a score 2 of 5 to 10%, and diabetes without organ damage. Third group is patients with moderate risk. These should have an LDL of less than 100, and these would have a score 2 of 1 to 5%. And finally, the low-risk group, which should have an LDL of below 116, and we advise lifestyle change. Now, as I told you earlier, there is a little bit of a nuance here that the American guidelines do not address, and you can notice it here, is that the European guidelines say that we need to achieve both goals at the same time, meaning we need to achieve a 50% reduction or greater than 50% reduction, and to reach the target goal, meaning less than 55 or less than 70, etc. Most of the time, these are achieved simultaneously. So achieving one means achieving the other, but this is not always the case. And so it is very important that you look at both at the same time, the absolute reduction as well as the value. 2019 treatment algorithm, it followed a very strict stepwise logic. Lifestyle was first. Then afterwards, there was high-intensity statins at maximally tolerated doses. Afterwards, there was addition of ezetimibe if the target was not reached on maximally tolerated doses. And finally, PCSK9 for very high risk or high risk at not at goal patients. The problem that was addressed that this algorithm. It was too patients coming in with ACS. These are the most fragile patients. These are the patients who need a reduction as much as possible. We don't have the luxury to wait for 3 months or 4 months or 4 weeks or whatever it is. And so why not start all we have and try to reduce the cholesterol as much as we can right now on the incident day? And because right now is the highest risk for them. And so this was actually addressed in the 2025 focused update. One of the most important things that was discussed was with regard to treatment of ACS. So they call it Fire to Target. And basically the update is explicitly recommending immediate in-hospital initiation of a combination pill. Or combination treatment, lipid-lowering therapy with statins as well as ezetimibe. And they even go even further to say that PCSK9 can actually be started on the index admission. So there is no need to wait for the outpatient follow-up. There is no need to test later on. Try to reduce it as much as possible, as early as possible. And this evidence was based on multiple different trials: Improve It, Pacman, AMI, AT Target, and Sweetheart. The second important addition within the 2025 European update was regarding the bempedoic acid. So this is genuinely a new class 1 recommendation. The CLEAR Outcomes trial, around 14,000 patients, as a matter of fact, 14,000 patients who were statin intolerant. And we'll talk about what statin intolerance means later on. Now these 14,000 patients, they showed that there is around 13% relative risk reduction when they were taking the bempedoic acid. It is not a statin. It works upstream of HMG-CoA reductase, and it is only in the liver, so myotoxicity is not a concern. Third addition in the 2025 focused update was the inclisiran, Leqvio. This is an siRNA, a small interfering RNA. It inhibits PCSK9 synthesis in the liver. It only needs 2 subcutaneous injections per year, and it achieves around 50% reduction of LDL. The cardiovascular outcome trials are still running right now. So there's 2 of them, the Orion 4 as well as the Victorian. Results should be out in the 2027. So it's important to keep an eye on that. And if the results are positive, then this might be a potential alternative to PCSK9 monoclonal antibodies, particularly in patients who have adherence issues. And fourth, and very important, lipoprotein A was formally incorporated as a continuous risk enhancing factor. You need to measure it once during a lifetime, ideally, and the European guidelines talk to that specifically, ideally within the first lipid profile. So the first time that the patient gets a lipid profile, they get the lipoprotein A with it. If the lipoprotein A exceeds 50 milligrams per deciliter or 125 nanomoles per liter, then you need to classify the patient's risk upwards. And then you just need to do it once in a lifetime. It doesn't really change, neither with lifestyle nor with diet, etc. So, you can do it just once in a lifetime. And then the patient, if he has these elevated numbers, they would be reclassified upwards. Now, going to the American side, crossing the Atlantic, we'll be talking about the 2018 guidelines and what they were really focusing on before switching to the 2026. So there's a significant departure between the 2018 and the 2026 guidelines. And the important thing is that in the 2018 guidelines, it was built on 4 statin benefit groups. So 4 groups of patients that would really benefit from statins. And the whole guidelines was built on that. The first patient was the patients with clinical ASCVD, high intensity statins, etc. Second patients are patients with an LDL of more than 190, and you've probably heard that number a lot. Third set of patients are patients with diabetes between the age of 40 and 75. And the fifth set of patients is patients for primary prevention with a 10-year risk of 7.5 onwards. But the problem is that the defining feature of the 2018 guidelines, and it was also the defining controversy, was that there was a deliberate absence of absolute LDL targets. So there was no targets of where these patients should get to. What should it be? LDL less than 50, less than 55, less than 100, etc. The philosophy at that time was that we need to treat the risk rather than the number, and we need to prescribe the right statin intensity for the right risk groups, and don't chase a specific LDL number, etc., etc. Now, in theory, this sounds very elegant and nice. In practice, it was a little bit problematic because clinicians took longer and longer to up-titrate therapy. They took longer and longer to add non-statin medications. So all of those kind of delayed care and probably had a worse outcome. The other issue is that the pooled cohort equations were known to overestimate the 10-year risk by around 75 to 150% in contemporary populations. So these two were the two most important Achilles heel, and the 2026 guidelines address these issues. Now, this is a table that is comparing really the 2018 to the 2026 American guidelines. And you can see that there is a significant paradigm shift. I talked about the title earlier. So the title was going from management of blood cholesterol to management of dyslipidemia. And again, it's signaling that the LDL is no longer the only atherogenic lipoprotein that we care about. Now we are looking at the triglycerides, and more importantly, we are looking at the lipoprotein A. The second thing is using a different risk tool, right? So initially we were using the pooled cohort equations, and now we're using the PREVENT. Now the PREVENT is a equation that used the data of around 3 million Americans, contemporary Americans, which is also very important. While the pooled cohort equation used basically around 25,000 patients, and these studies were from the 1960s. And at that time, even these studies were not racially integrative. So now it's a much closer to the patients that you are seeing right now. where it's in 2025, 2026, and it's a much larger study, and the race factor is kind of taken out of the equation. The other important thing about the PREVENT equation is that it includes kidney function, and as you know, kidney function over the past 20 years or so has been closely associated with increased cardiovascular disease. The other important thing in the paradigm change between 2018 and 2026 is that now we have LDL targets. So this is perhaps the single most important change. After 8 years without having a numeric target in the American guidelines, at least, now they are back. You need to have an LDL below 55 for very high risk, below 70 for high risk, below 100 for intermediate risk. Another important change was the lipoprotein A in the 2026 guidelines. So it wasn't even mentioned in the 2018 guidelines, and now it's basically you need to get it at least once in every adult's life. Another very important change is that the age range between the two guidelines was looked at. So in 2018, range for primary prevention was 40 to 79. In the 2026, it is now 30 to 79. So it's a decade earlier. You need to start checking a decade earlier. And that's because earlier treatment, earlier prevention is better. We'll talk about that later as well. And finally, previously in the 2018, the primary focus was the cholesterol, while now it is LDL, triglycerides, and the lipoprotein A. So we touched a little bit on the PREVENT, and here is a dedicated slide because I think it's very important to really understand the significance of this new equations. So the PREVENT ASCVD equation is one of the most substantive equations that has happened in cardiovascular preventions, and it's derived from around 3.3 million contemporary US adults, as opposed to the 2013 PCE pooled cohort equation of 25,000 adults. And even the PCE 25,000 adults, these patients, this data was even from the 1960s, so even earlier times. Again, an important difference between the PCE and the PREVENT. PCE can calculate from patients' range of 40 to 79, while PREVENT is 30 to 79. A very important difference between the two is that the PCE gives you a 10-year risk stratification. However, the PREVENT gives you a 10-year, and it also gives you a 30-year risk for patients under 60. So that's fantastic, because now your patients who is 30, right? Because we can start at 30 or 40, you can give them a 30-year prediction as opposed to a 10-year prediction. You know, a 10-year prediction for a 40-year-old may not be very significant for him, but a 30-year prediction would actually be important as a lifetime kind of burden of ASCVD. Difference between both in race, we had talked about that. And then a very important factor is that the risk estimate for PCE was actually, it is known to overestimate, while the PREVENT now with contemporary patients and a bigger cohort of patients, it is showing that the risk is actually 40 to 50% lower than the PCE for that same profile. Now, what's important is that although now we are saying that the risk for, or appropriately estimating the risk for ASCVD, the threshold of starting the statins or starting medications has also changed. So previously, for example, the threshold of starting statins in patients was to have a PCE of risk of around 7.5 or higher, while now it is 3% or higher. So as a matter of fact, you know, we're going to end up basically treating the same patients who needed treatment in the PCE would definitely still need treatment under PREVENT, but the risk estimation is just a little bit better. there's this thing that's called the CPR model, which is basically calculate the 10-year ASCVD risk using PREVENT and for any adult between the age of 30 and 79. Second is personalize that risk. So apply risk enhancers such as calcium score, high sensitivity, CRP, lipoprotein, premature ASCVD. And the last thing is to go ahead and recommend the treatment, which we are going to be talking about right now. LDL targets are back. There are 3 numbers that you need to know: 55, 70, and 100. For very high-risk patients, multiple ASCVD events, patients who have one event but with additional high-risk factors such as diabetes, hypertension, heart failure, or age above 65, or LDL or an LDL persistently above 100. The goal is to get a LDL of less than 55 milligrams per deciliter. They also go into the ApoB and the non-HDL. But these are less important. I think the most important thing is just to target the LDL of less than 100. For patients who are high risk, but they're not meeting the criteria of very high risk, target is below 70. And the patients who are intermediate risk, the target, which is basically a primary prevention risk of around 3 and onwards in the PREVENT trial, the LDL should be less than 100. So the idea is the whole goal is to have earlier, lower, and for longer. And this is actually written there in the new guidelines. Earlier, lower, for longer, because that's going to that's going to decrease the cumulative risk of cholesterol and atherogenic lipoproteins. Right. 2026 ACC guidelines also talked about non-statins and novel therapies. The first one is ezetimibe. Most of us are familiar with ezetimibe. It has a class 1 indication to be used. It's cheap, it's well tolerated, it causes around 20 to 25% reduction in LDL. IMPROVE-IT trials showed it decreases MACE by around 7%. And this is used on top of statins. This should never be used as a first-line treatment unless there's a very significant discussion that was done with the patient. But it should be used on top of statins. As we said earlier, in the European guidelines, it should be done in conjunction with statins in an ACS case. This should be used, ezetimibe should be used before we reach for PCSK9. PCSK9, which are basically class 1 indications for high-risk and very high-risk patients where we are unable to achieve targets. Basically 2 large trials, Fourier as well as Odyssey, showed a 15 to 20% reduction in MACE, 60% reduction in LDL, and these can be used on top of statin. So these reduction in MACE are on top of the statin therapy, so not instead of the statin therapy. So these are fantastic drugs. They're available, but they are extremely expensive. But if the patient needs them, you're getting a 20% risk reduction on top of the statins. The patient needs that, then this is something that needs to be addressed and fighting with the insurance for it. Another thing that non-statin therapy that has now been talked about significantly is bempedoic acid, and this is class 1 for a patient intolerant, statin intolerant patients. It's one time, it's oral. It causes around 18 to 20% reduction, even used as a monotherapy. And this can be added on to ezetimibe as well. So you'll have the bempedoic acid plus ezetimibe instead of the statin plus ezetimibe or statin alone. And the final thing is the inclisiran, the Leqvio, which is a twice daily subcutaneous injection, causes around 50% reduction of LDL. The outcomes data are still not out. So, the thought is that reducing LDL is going to cause significant protection from cardiovascular disease, and that's the framework that we are working on. But the outcome data is still not out yet, so we are keeping a close eye on that. I wanted to take a moment to talk about lipoprotein A, and this is probably one of the most clinically impactful changes across both sets of guidelines, European as well as American. So 1 in 5 people worldwide has an elevated LPA above 50 milligrams per deciliter. It is genetically determined in over 90% of people, in over 90% heritable, I'm sorry. Lifestyle has essentially no effect on it. Diet, exercise, etc. Statins even, not a significant effect on it. And yet it is an independent causal risk factor for myocardial infarction, stroke, aortic stenosis, etc. It causes around 3.5-fold increase in lipoprotein A has the effect of one allele of familial hypercholesterolemia, significantly affecting the cardiovascular disease, significantly increasing your cardiovascular risk. So both guidelines right now are saying screen everyone once in a lifetime. European says do it early on. You do it at the first lipid profile check. ACC really doesn't mention when to do it, but they do advise to screen children with family history of elevated lipoproteins A. What do we do when we have a patient with elevated results, elevated lipoprotein A? Currently, at this time, we don't have a approved medication for it. So all that we are doing, we are just increasing the risk of the patient, and then intensifying lipid lowering therapy. So intensifying the statins, intensifying ezetimibe, etc. That's the only strategy that we have right now. PCSK9, they do reduce the lipoprotein A by around 25 to 30%, but this is the secondary effect, and the primary driver is in fact the decrease in the LDL. However, there are multiple medications right now that are in the pipeline. Olpasiran and pelacarsen are in phase 3 trials. These reduce the lipoprotein A by around 80 to 95%. There's another one that's called lipodisiran and achieves a 95 reduction in LPA. So these are expected to be published. Outcomes trials are expected to be published in 2027. Again, big year. So I think that we'll be keeping an eye on that. I think we're around 18 to 24 months from having a medication for targeting lipoprotein A per se. All right, this is an important slide that I think that is important for you guys. It basically compares European versus American guidelines. First, I'll talk about what brings those guidelines together. As far as the LDL targets, now they are perfectly aligned below 55, 70, and 100, for high risk, very high risk, and intermediate risk. For the first time since the statins era became upon us, the Europeans and the Americans are in complete agreement with the targets, and both of them having numbers. So this is fantastic. Lipoprotein A, both guidelines recommend that we do that. Bempedoic acid, both guidelines say that this is a class 1 for statin intolerant patients. And unfortunately, there is a little bit of differences. I can hear my voice. All right. A little bit of differences. The first divergence is basically dual target criterion. So ESC requires the use of LDL as well as a 50% reduction from baseline for very high risk as well as high risk patients. ACC requires only the absolute target reduction. Again, in practice, most patients who achieve one will be achieving the others, but it's not always. So you need a close eye on that, to keep a close eye on that. The second thing is treatment for triglycerides. The American guidelines are considerably more detailed on the guidance for hypertriglyceridemia, including a 2A recommendation for ecosapentyl ethyl in established ASCVD or high-risk diabetes or patients with diabetes with triglycerides. The ESC guideline, the European guidelines, is a little bit less, granular about this. Third difference is ACS management. Again, Europeans say much more aggressive, start statin plus ezetimibe at the same time, and even consider PCSK9. ACC says just maximize statins before discharge, and then the escalation is done as an outpatient in the follow-up. And finally, with regards to statin intolerance, European says bempedoic acid directly as a class 1 alternative. The American guidelines is still focusing on ezetimibe first as a non-statin add-on, and then getting in, adding bempedoic acid. I suggest to use the 2026 American guidelines as a primary reference. It's more contemporary, it's more comprehensive, clinically more detailed, but then apply the stricter rules, the stricter percentages of the European guidelines for your patients. I think that way you'll be getting the best out of both worlds. I'm just going to touch briefly on a few patient populations. Yeah.
Fantastic presentation, and of course we are happy to listen to you whole day. Just because of some time constraints, if you don't mind, just give your final words as well. Yeah.
Yes. Let me. Okay, I think
whatever you think.
Two slides. So basically, special populations in 2026 guidelines, patients with familiar hypercholesterolemia, pediatric screening, very important. Second patient population is diabetes, patients with diabetes. So now, start thinking about GLP-1 agonist as well as GLT-2 agonist as well in the setting for modest LDL lowering as well. Patients with chronic kidney disease, these are often missed. Patients with chronic kidney disease, they typically would benefit from lipid-lowering therapy. Right now, the guidelines is not to stop statins, even for the elderly woman. Make sure that statins are contraindicated for pregnancy, and very important. HIV patients with HIV that they would actually benefit from lipid-lowering therapy as well. Triglyceridemia, again, read about it a little bit in the 2026 guidelines. But first, exclude if patients comes with hypertriglyceridemia. Just exclude a few things like hypothyroidism, diabetes, alcohol intake, chronic kidney disease, and even some steroids before starting, or consider those before starting therapy. I think this is basically it. First, this summarizes everything. Risk stratify, patients using the PREVENT. For all the patients, advise a lifestyle change, Mediterranean diet, physical activity, weight management, etc. And then start pharmacotherapy as risk-based. Patients who are borderline risk, 3 to 7.5%. We discuss starting statins. Intermediate, 7.5 to 20. We start statins and have these goals according to the risk stratifications. And one last thing. The statin intolerance, a lot of patients report to us statin intolerance. Samson trial, New England Journal of Medicine 2020 showed that we actually are overdiagnosing statin intolerance. When it was an open label, patients had around 9% statin intolerance. However, when it was a closed label, so patients didn't know what they were taking, it was significantly less than that. Which tells us that before saying that the patient is statin intolerant, try a few things first. Reduce the medication, give them a holiday, do it every other day, etc. And that's it. These are the takeaways. LDL targets, prevent lipoprotein, treat earlier and longer, bempedoic acids for statin intolerance, and watch out for the new therapies which are in the pipelines.
Thank you very much, Khalid. You've done such a wonderful job going through such a comprehensive document, and you've given us a summary. And as you said, it's all about earlier, lower, longer, and they should come and talk to you if they want to have more details. Thank you very much.
All right, have a good one. Thank you.
Thank you. So, Dr. Fatma, because of the time, if you don't mind, just go ahead and introduce the next speaker.
Sure, Doctor. Our third speaker is Dr. Hassanain Al-Shakarchi, Consultant Internal and Acute Medicine at Medical Clinic, Park View, and Adjunct Clinical Assistant Professor at Mohammed bin Rashid University. Dr. Hassanain will discuss updates in hypertension management. Please, Doctor.
Dr. Fatma, thank you very much for the introduction. Good afternoon, everyone. It's an honor to be here and to follow on such an informative and distinguished speakers in the second day of a global RCP update. In my presentation next, I would like to talk basically about management of hypertension, mainly non-cardiologist translations of the latest guidelines and making them more into a practical take-home messages. Within, obviously, the limited time we have in a big and important subject. We all know hypertension is a worldwide epidemic. It's one of the most prevalent cardiovascular diseases in the whole world. Over 1 billion adult patients would have hypertension. Majority they live in low income or middle income countries. High prevalence among males and female, and a modest increase in the blood pressure, like a 20 millimeter mercury in systolic or 10 millimeters mercury in diastolic, have a significant rise in the coronary artery disease or stroke. Not only is prevalence is prevalent, but as well as poorly controlled across the whole of the world. It's a silent killer. It's responsible for more than 10 million deaths every year. And just a reminder, May 14th is the World Hypertension Day. Locally as well in the United Arab Emirates, where I live, it's a prevalence around 40%. Over 1.8 million in adult age they have hypertension. Problems is they are majority they are not diagnosed, and even when they are not diagnosed, they are poorly controlled. Now, looking at a global research, which is a comprehensive observational study, looking at the world-leading risk factors for disability-adjusted life year, which is the DALYs, hypertension came second risk factors behind the pollution. As I mentioned, it's highly prevalent. Problems is there is a gap between the diagnosis, the awareness, and the control. And as you can see here, there is less than 1 in 7 patients with hypertension worldwide have it under control. So there is a big proportion of patients that are undiagnosed and not aware of the diagnosis. The one who are aware, not all of them are treated, and the one who are treated, not all of them were achieving the targets. We know that hypertension is associated with multiple hypertension-mediated organ damage, and these all need to be screened during diagnosis of any hypertension involving from the eye, from the cardiac side, from the kidneys, circulations, brain. You name it, you'll have an impact from the uncontrolled hypertension. We know as well any patients who get treated with hypertension, we reduce their cardiovascular mortality and morbidity significantly, over 50% reductions, for example, in their heart failure or cardiovascular deaths, and as well cardiovascular events. Not only achieving the targets, but any reductions matter. So little reductions in the blood pressures actually resulted in a reasonable reductions in their heart disease or in their risk of cardiovascular diseases. Hence, it's very important not to look at small reductions as not significant, but any reduction to achieve the targets make a big impact on the reductions of their cardiovascular diseases. And now, reminder for all, first encounter of patients during clinic consultations, for example, there are certain tics that need to be done before assuming that this reading of high blood pressure is accurate or not accurate. These are simple things like, for example, avoiding exercise, caffeines, relax, right cuff sides, and others. And now, if we go into the guidelines, and I'll put comparison between basically the two major guidelines, which is the European Society Cardiology, the 2024, or the ACC AHA 2025. First and most important, both and all of the guidelines suggest if we see any patients with an office-based or clinic-based elevated blood pressure or borderline elevated blood pressure or hypertension, in order to confirm, preferably they would have either an out-of-house blood pressure measurements, which include basically the home or ambulatory measurements. So the guidelines are in alignment. Both would recommend using home out-of-office blood pressure measurements to confirm the diagnosis. As per the 2025 AHA and ACC guidelines, they categorize blood pressures reading into normal, elevated, or hypertension, and the hypertension stage 1 and stage 2. So any patient with a blood pressure above 130 to 139 with the diastolic or diastolic between 80 to 89, this is stage 1. Stage 2 is more than 140 or more than 90 diastolic, while the new groups of elevated blood pressure is counted as 120 to 129 with the diastolic less than 80, and the normal blood pressure classified as per 2025 AHA ACC guidelines below 120 or below 180 diastolic. It's similar, so that's basically the recommendations. They should be categorized into either normal, elevated, or stage 1 and stage 2. And we will come to the why it's make a difference in a second. The European Society of Cardiology, sort of similar, let's say, classifications, but different naming or different labels. So the European avoided using the term of normal blood pressure. They've used a non-elevated blood pressure, and that's for the patients with an office blood pressure with less than 120 over 70. While they have the elevated blood pressure, that's they categorize it between 120 to 139 or between 70 to 89 diastolic. That can be and or basically for the systolic or the diastolic, while the hypertension is classified as more than 140, more than or equal than 140 or more than 90. So they've avoided using the terms normal. They've used it non-elevated, elevated, and hypertension. The ISH, which is the International Society of Hypertension, or the ESH, which is the European, sort of similar as well. They labeled the high normal 130 to 139. So it's very important to try and identify the patients where he lies in the group. Why is that? Because basically, if you see from this graph, this is around 7,000 patients from Framingham Heart Study, which showed the impact of high normal on the cardiovascular events. So there is a 10-year risk of stepwise, an increase in cardiovascular event even for a high normal patients. So for example, in this group of patients between 35 to 65 years old, they have basically around 8% risk of 10-year cardiovascular event. So it's very important not only to diagnose the hypertension, but as well to diagnose the high normal patients or the elevated blood pressure groups, unlike before where you used to just measure mainly the hypertension. As Dr. Khalid highlighted for the dyslipidemia group, it's a very strong emphasis in all of the guidelines to risk stratify the patients. So it's a very important steps if you had identified especially the let's say the elevated blood pressure group to risk stratify these patients using either the 2025 they recommend using the prevent cardiovascular group. The ESCs recommend using score 2. So it's a very important to risk stratify any patients who comes to you making the diagnosis of hypertension, or more importantly to the group of the elevated blood pressure group. Now the treatment-wise, this can be guided by either blood pressure level only, or a risk-based approach. So any patients with average blood pressure more than 140 or over 90s, they need to be initiated with medical or antihypertensive medications, alongside obviously the first step, which is the lifestyle changes. But the medications or the antihypertensive medications is essential. While if their blood pressure lies below 140 over 90, and that's for example, stage 1 hypertension, or in the American guidelines, or elevated blood pressure in the European, then we risk classify whether they have a cardiovascular disease or whether they have a high risk and the prevent score. Then these as well, they require medications. They require medications. So any patients with a blood pressure more than 30 over 90, but they have a high prevent score or high cardiovascular risk factors, they require medications. For the patients who are low risk, but their blood pressure is more than 130 over 80, less than obviously 140 over 90, then American guidelines suggest basically 3 months of, or 3 to 6 months of lifestyle interventions. And if they fail to achieve the targets, to initiate the medical management. Now, this is slightly different for certain group for the ESC guidelines. As you can see here, the group, for example, that have high blood pressure or hypertension with blood pressure of over 140 over 90, they require medications. Lifestyle across the whole of the groups, irrespective of the blood pressure, lifestyle changes or lifestyle measures is recommended for all the groups. Medications recommended highly for any patients to be started immediately for the patients with the blood pressures on 140 over 90, while the groups, they have between 130 to 139 with cardiovascular risk or high risk score, lifestyle changes and pharmacological treatment is recommended. For the groups of lower than that, then mainly lifestyle changes. They don't recommend to start antihypertensive medications for low-risk patients with the blood pressures 130 over 139 if their cardiovascular risk is low. While the American, they suggest 3 to 6 months of lifestyle changes and implementing medications or starting medications if blood pressure's target not achieved. All in agreements, all the guidelines, the target blood pressures should be less than basically 130 systolic, which is between 120 to 129 and 70 to 79 millimeter mercury. Lifestyle changes, all in agreements, 5 core step, which is basically diets, salts intake, reducing weight, exercise, and reducing basically alcohol. Again, all the guidelines in agreement. It's very important to highlight to the patients the significance of lifestyle changes, and always recommend that this is done through a prescriptive way where you explain exactly to the patients what they need to achieve, what's the amount of reductions of the salt, for example, what type of diets which is being recommended, for example, is a DASH diets, and highlighting the importance on the significance of any of these lifestyle changes. For example, if the patient is overweight, any 1 kilo reductions in their weight is associated with roughly 1 millimeter reductions in their blood pressure. If they reduce their salt intakes, associated with the reductions of around 4 to 8 millimeter mercury blood pressure reductions. And the same if they apply the DASH diet, which is dietary approach to stop hypertension, is associated between 8 to 14 millimeter mercury reductions in their blood pressure. Exercise the same, and recommends that you prescribe them, let's say the exercise exactly to the patient to know exactly what they need when they need to do from the physical activities, and this is well associated between 4 to 9 reductions in their blood pressure. What about the drug therapy? So we talked about the groups that need the drug therapy, and that's any patient with blood pressure of more than 140 over 90 or more than 130 with the risk factors. So if we take into the more details, the recommendation suggests all of them to be started on a low dose double combinations, which is between ACE or ARB with the calcium channel blocker and diuretics. The only groups that you might consider, for example, using monotherapy is if their blood pressure categories less than 140, or in elderly patients, moderate to severe frailty, or symptomatic orthostatic hypertension, so as I mentioned, age more than 85. Otherwise, the recommendations and any initiation of any antihypertensive medication, you start with the low-dose double combinations, which include either ACE, ARB with calcium channel blocker or diuretics. If blood pressure is not controlled after 1 to 3 months, then basically you either switch to low-dose triple combinations as per ESC guidelines, or you increase the double dose or double combinations therapy. And again, you follow up for 1 to 3 months to see if there is under control. If they are controlled, then you go with the one yearly follow-up minimum hypertension without any complications. If they achieve maximum tolerated triple combinations, which is basically ACE/ARB with the calcium channel blocker or diuretics, and despite that, the blood pressure is under control after 1 to 3 months, then this looks like it's more of a classified as a resistant hypertension. And this have, let's say, a big another presentations require more time to explain it, but basically then you'll add medication like spironolactone on some group of new medications has been let's say. So this is the summary of the SPC preferred, let's say, medication strategies, which is, as mentioned, initially start with dual combinations, either with ACE/ARB with calcium channel blocker or diuretics. Second steps would be the triple, increasing the doses. If that all fails, then basically this will be classified as a resistant hypertension, and it can include things like spironolactones, alpha blockers, or beta blockers. Now, one or two more slides just to reach to the more important take-home messages. This is just giving you one of the landmarks blood pressure studies, which is a meta-analysis looked at over 350 trials, which combining classes showed an additive effect comparison to monotherapy. And in fact, it showed that doubling monotherapies is associated with very slight decrease in the blood pressure of around 2 to 3 millimeter, while adding a second agent, second group is associated with 8 to 15 millimeter reductions in the blood pressure. So for sure, combining beats the escalation. So it's better to give 2 groups of medications instead of 1, with increasing the dose to maximum tolerated. Where we used to have in the guidelines, we initially used 1 medication, then we go up. Now, very clear from 2024, 2025 guidelines, you initiate low dose combinations better than monotherapy. This is associated with the blood pressure, better blood pressure control, and as well reductions in their stroke risk and ischemic let's say, events. Now, what about using SPC or free equivalent combinations? Like, for example, this is using either 1 tablet with the combinations or same equivalent, free equivalent combinations. Again, the study, the SPC is available. It's basically better. It's this is let's say systemic review. 44 studies showed the SPC higher adherence, higher persistence, better reduction in the systolic blood pressure, better reduction in diastolic blood pressure, and as well patient achieving blood pressure target. So basically, patients adhere more, stay on the medications longer, targets achieved better in using SPC medications in comparison to free equivalent combination. So combinations, VS immunotherapy combinations wins. It's a better adherence, better cardiovascular, let's say, outcome, lesser side effect, and synergistic actions of the different classes. One slide before I go to the last basically take-home messages. There is on the horizon new classes of hypertensions. These mainly the aldosterone synthase inhibitor. We know the mechanisms of resistant hypertension mostly is the aldosterone axis, and it's recommended that we do screening for hyperaldosteronism, and these new classes of medications works on inhibit the production of aldosterone.
2 minutes. Sorry, 2 minutes. We are a little bit hard.
The most important take-home messages: screen and confirm hypertension. So confirm hypertension with home-based or ambulatory monitoring. Classify the blood pressure, elevated, non-elevated, and hypertensions, and then thorough cardiovascular risk assessment using, for example, the score or prevent risk calculator, faster control in the blood pressure that's needed to be considered. Lifestyle changes is very, very important. Using them SPC and combinations medications as your first line medications. And I think that's the end of my presentation.
Thank you very much, Dr. Hassanein, for the concise and timely presentation on hypertension. I think we are tight in time, and we will move to panel. We have only 2 minutes for any question. Dr. Yasser, please.
Yeah, thank you very much. As you said, Dr. Fatma, that we have a lot of questions in the chat box, but of course, because of the time constraint, we can't do it. So I'll just quickly give 1 minute summary that we all know that the main problem is cardiovascular illness. So what we have realized in acute coronary syndrome or hypertension or dyslipidemia, that it's all about earlier diagnosis, earlier treatment, and asking for an expert. So my request to audience will be that they can move to our next cardiovascular therapeutic session, and we will give you the contact details for all the presenters. You can individually send them email and ask the individual questions. There are a lot of controversies in our chat box. Unfortunately, me and Dr. Fatma, we cannot answer in the next 5 minutes. So I think we'll just move on to the next session. And please send the text or email or LinkedIn to individual presenters, and they will answer your queries. Anything else, Dr. Fatma?
Thank you very much. I think this is the end of this session. And thank you for all the speakers.
Thank you very much. Thank you.
This is a wonderful seminar, and we are lucky that we got this opportunity to join online. This is second Royal College of Physicians Global Update in Medicine 2026. Started yesterday and will continue till tomorrow. And today's day 2. Already we finished day 1 and we are in day 2. From the morning, we have finished 2-3 sessions. Just now, finished the cardiovascular part. Earlier, there was a part for the neurology and neuropathy. That was excellent. So now it's time for cardiovascular therapeutics. So we will join here. Cardiovascular therapeutics. The audience platform, so we need to modify and we'll try to make it change. This is day 2, day 1, sorry. This is day 2. So this is cardiovascular therapeutics.
And now we are starting the symposium, the cardiovascular therapeutic sponsored symposiums. We will start with Professor Peter Jan Landsberg. Professor Peter is a consultant in lipids cardiovascular risk management at Academic Medical Center, University of Amsterdam, Netherlands. I was just in Netherlands like a month ago, amazing place. Professor Peter is an internationally recognized expert in lipid cardiovascular prevention and metabolic medicine. He's the founder
of the Dutch National Screening Program for Familial Hypercholesteremia and Dutch Lipid Clinic Network. With decades of academic and clinical experience, Professor Landsberg has held several international advisory and leadership positions with major cardiovascular and lipids organizations, including the International Atherosclerosis Society. He has authored numerous scientific publications and delivered extensive international lectures focused on cardiovascular risk reduction, dyslipidemia, and preventive cardiology. Today, he will talk about statins in primary prevention, what's new in dyslipidemia guidelines and clinical practice. It's a symposium sponsored by Viatris. Professor Peter, the floor is yours.
Thank you very much. I hope everybody can hear me and can see my slides. It's a great honor to join you here in this meeting organized by the Royal College of Physicians. My aim today is to share with you some experience and information regarding the relevance of early intervention, so primary prevention, and perhaps even in primordial prevention, because I think that's going to be really essential if we want to address the huge issue of rising cardiovascular disease. These were my disclosures. This is some good news. It shows very comprehensively how acute cardiovascular disease has been really successful in reducing the death rate from patients that make it to the hospital for acute coronary event. And you can see that in the past, that survival rate was less than 50%. And today, that survival rate is 90 to 95%. So cardiologists and cardiology was very successful in addressing the acute cardiovascular complications and making sure that patients came out alive when they reached the hospital. What is, however, a challenge is the huge surge in non-communicable diseases that is going on now, and that's expected to go even further in the future. And this is a WHO slide, so showing you an overview of what can be expected in terms of healthcare resources that are needed. Tremendous growth in cost addressing all those non-communicable diseases. And intriguingly, 40% of these are actually avoidable with lifestyle policy changes. But what's even more worrisome is that the low and middle income countries will face the biggest burden. 80% of cardiovascular deaths will be in those countries, and unfortunately, they only have 20% of the resources. So what is the reason for having such a success in acute care and a failure in preventing cardiovascular disease? We can argue and say it's the worst environment in terms of personal environment, like diet, nutrition, lifestyle, exercise, and also environment in a broader context, pollution, air, noise, light. All these factors play, of course, a very important role. There is always a tendency to think, okay, we're going to address it by having new therapies, by having the so-called silver bullet to reduce our cardiovascular disease burden. But I think that's going to be very, very difficult, if not impossible. What I think is more practical and actually provides us with a better resource to change the problems that we're facing is better implementation of guidelines. Everybody knows the guidelines, but if you evaluate how well they are followed, it seems that it's not as good as you would hope for. And last, but certainly not least, we're starting prevention much too late. So this is a short introduction. I'll go on by explaining what primary and primordial prevention is, why we should start treatment, who should be treated, how to treat them, when to start, and some conclusions. Primary prevention is, as it's defined, preventing the first occurrence of a disease or clinical event in people who already have risk factors but not have developed disease. And most guidelines or risk calculators are based on this. It's actually trying to avoid events by controlling the presence of certain risk factors. And usually that is triggered at the moment where risk is sufficiently high, to apply these risk factor changes. I would argue that we should actually try and go a little bit more broader to what I call primordial prevention, where we not only try to reduce the risk factors to reduce the cardiovascular risk on a short-term basis, but preventing the emergence of risk factors themselves or controlling the emergence of risk factors in a healthy situation. So not when the risk is already very high, but perhaps when the risk is actually not elevated yet. Then why should we treat? I'll share with you a brief series of a very simple case, and I think it's very illustrative, showing us how we fail. So this is Bob, a 25-year-old US male, and he's very health conscious. So he thought my cholesterol is a little bit high, maybe that should be addressed. So he visits his GP and asks what he should do. So the GP plugs in all the numbers, and these are his numbers. He doesn't smoke, he drinks occasionally, and his lipids are slightly abnormal. Blood pressure is in a normal range, BMI is normal, and no positive family history. So this is one of the tools to calculate risk. This is the Q risk calculator, and at his age, his risk is considered to be 0, his 10-year cardiovascular risk based on these risk factors. So Bob goes home and thinks he's very reassured. But at age 35, he thinks maybe it's time to have another checkup. So he goes back to his GP, plugs in the numbers, and this is what the GP does. He has a pretty good diet. He hasn't changed too much of his risk factors. So the GP, after calculating his risk again, don't worry, Bob, you're fine. Your 10-year heart risk is about 1%. So Bob goes home, happy, reassured, and continue his life for the next 20 years. So at age 60, he returns to his GP and he sort of treats himself to a test for his risk factors. And what happened? Everything seems to have changed, because now, after plugging in the risk factors, and these haven't changed very much, suddenly the GP starts to get very worried. That is confusing, because all the time when he went to his GP and his cholesterol has been always the same, the GP was never worried and said, don't worry, just continue what you're doing. So he asked, what has changed? And then the GP answers, well, at your age, having a cholesterol that is that high associates you with a risk of 10% for having a heart attack. So that means we have to start to do something. Bob is perplexed because he said, my cholesterol hasn't changed that much. So why we have to do and change something now? Maybe we could have done that much earlier. GP is a little bit confused, and he says, yeah, it's, this is the guidelines. I follow the expert guidelines, and this is how we should do things according to these guidelines. Unfortunately, Bob returns not to the GP, but in hospital at age 65, because his cholesterol has been high for more than 60 years, and that has consequences. And I think this is a very crucial way to illustrate why prevention should be broadening its scope and go beyond what we think is considered to be high risk, and maybe start not in the patients at risk, but patients that are healthy. A high risk score or a high calcium score is definitely an action that is required, but a low or normal score is no guarantee for having no cardiovascular risk factors or complications. As we see many, many times that patients come into the hospital after they have been screened without having any acute indications for addressing that risk. To illustrate, this is called the PISA study, where they included only patients who had no risk factors. So they had normal cholesterol, normal blood pressure, normal body weight. Everything was absolutely normal. They were at an average age between 30 and 40. And you can see here, based on the color, if 1, 2, 3, 4 more vascular beds were infected with atherosclerosis. They used non-invasive imaging for the carotids, for the femorals, and for the coronaries. And to their shocking conclusion, almost all patients, despite having no risk factors, had actually atherosclerosis. The only group that seemed to be completely free were the ones who had LDL below 60. And that is an interesting number for LDL values. So I can assure you, we not all die from cardiovascular disease, but we will all die with atherosclerosis. Another illustration, this is an old slide. This is from the 1950s, looking at autopsies of young American soldiers, mean age 22.1 year. The cause of death was, of course, obvious, but it was a rule that after death there had to be an autopsy. And you can see that even in those very young, and you would expect quite healthy men, there was extensive atherosclerosis. Now you might think, okay, this is something that happened because smoking was so prevalent in those days. But this is looking at some different data from young individuals who died from different causes at an age of 29, 23, and 19, an age where you don't expect to be seeing atherosclerosis, and they had extensive atherosclerosis in the coronary arteries, illustrating that this disease starts much earlier than the 40s or 50s, where we're now starting to think about treating patients. This is a study, fairly recent, 2017, from New Zealand, where they found that 1 in 4 major ischemic heart disease events are fatal, and 60% are pre-hospital death. And I'm just highlighting this because that means that secondary prevention is, of course, a little challenging. So more focus on early prevention and early intervention. 1 in 4 ischemic heart events is a fatal event. Then another way to look at it is what is the number of patients that were unknown with cardiovascular disease or had no awareness that there was something wrong. And in this study from Australia, they also came to the conclusion that 40% of fatal cardiac events are in patients, or people, I should say, where this was the first sign of having atherosclerotic cardiovascular disease, 40%. Another indication that primary prevention should be really more in front on our radar. And finally, this is a recent study from 2025, where patients who were admitted for an MI, first MI, 1 in 5 had no previously identified standard modifiable risk factors, SMRF, and the majority of those who visit the physician before the MI and were identified with SMRFs were actually not receiving preventive therapy. So this illustrates that we do have a big problem if we want to change the outcome of cardiovascular disease by simply focusing on the very high-risk individuals. Now, who should we treat? I thought I'll keep it simply because of time. These are the new updated guidelines from the European Heart Association and also from the American Heart Association. And the 5 important differences, because they are in a way based on the same guidelines, based on the same evidence, I want to highlight for you. So in the European guidelines, there are 5 risk tiers: low, moderate, high, and very high. And we use the score 2 or the score 2 for all the patients. For the American guidelines, there are 4: borderline, intermediate, high, and very high. And the risk 2 is prevent. Then the clinical categories that are associated with cardiovascular disease. In European Society of Cardiology, there is a broader inclusion for high risk or for very high risk, which includes primary prevention. In the American guidelines, there's explicitly based on secondary prevention. And there is a sort of nuance possible there based on the type of events and the number of events. Another interesting difference is the calcium score In the European guidelines, calcium score is a risk modifier. In the American guidelines, calcium score is a direct determinant of action for lower targets of LDL. Stepwise escalation in Europe, statin followed by ezetimibe, PCSK9, although in ACS it's underlined we should initiate statin and ezetimibe, while there's a more flexible approach where you can combine high-dose, high-intensity statin with PCSK9 or with a ezetimibe or bempedoic acid. Targets are very similar. Perhaps there is one extra target of extreme risk where we aim for 40 milligrams or less. Realize that guidelines are there to help us. They're like handrails guiding us, and we can hold on to them if we really need a proper direction, but they're not like railroad tracks. You know, we have to be able to use our own clinical judgment and also the personalized approach, simply also because the trials that provided the evidence for the guidelines included special sets of patients, and in the real world, these patients not always fit in those special sets. So that means you have to sort of be a little bit more flexible in interpreting the guidelines, although I do think that the guidelines more or less point out at least the minimum what should be done in terms of risk prevention and management. So how do we lower risk? Well, we have, fortunately, we have a huge armamentarium of new and standard lipid-lowering drugs. And I'll just point a few out. This is the statins inhibiting HMG-CoA. We have bempedoic acid.
Doctor, you have 2 minutes. 2 minutes.
Okay. Inhibiting at a higher level. And we have all these new drugs which are becoming available, but not yet in the market. Then finally, I think statins are unique because they are effective, safe, cost. There's evidence, experience. Don't forget, statins have pleiotropic effects that are very, very important, especially in the acute and secondary prevention situations. Based on the evidence, this is an old paper, 2017, showing you the immense evidence we have for statins and also about the safety and efficacy. And simply, these are the trials. I just want to highlight that, especially for atorvastatin, the evidence for 80 milligrams or more is very overwhelming. When to start? Well, this is from the European guidelines indicating treatment targets depending on the number of risk factors. I just want to highlight one thing. If we prevent atherosclerotic events, then I think the tools are very, very helpful, but preventing atherosclerosis is a different strategy. And to illustrate, this is data from the European FH cohort, where children from the age of 8 were treated, and showing you how at that young age, there was a huge impact on the reduction of mortality and morbidity if compared with their parents who suffered serious complications at the same age that these children are now. So to conclude, I would like to share with you a very ancient slide. This is one of the oldest medical textbook that has ever been discovered. It's 4,500 years out, 2,500 years before Christ. And it states that inferior doctors treat the full-blown disease, mediocre doctors treat the disease before it becomes evident, and superior doctors prevent the disease. Final thoughts: improving cardiovascular disease remains a high priority. We have to prioritize atherosclerosis, not only ASCVD risk, if we want to curb the epidemic of cardiovascular disease. Risk scores show us who is at risk, not who is free of risk. And that's an important message to remember. Maybe we should not find people that need statins, but maybe we should reverse it and say, maybe there are some patients that do not need statins. And finally, following treatment guidelines is basic medical practice, but use it as handrail, not as train tracks, and that allows us to be more flexible and more personal in approaching managing risk. And that was my last slide. Oh, yes, high-dose, high-intensity statin is a standard approach to reduce cardiovascular risk as well as atherosclerosis, and I think not only in secondary prevention, but even in high-risk primary prevention. Last last slide, and I'm open for questions if we have time, but I think the time is already gone. So thank you very much for...
Professor, I'll ask you just one question. So what is the role of calcium score today before starting statins? Is it necessary?
And I think calcium score is a very helpful tool to determine who is at very high risk and that might intensify treatment. It's not as useful. It's not as useful if a calcium score is negative, especially at the younger age. If we look at South Asian or Southeast Asian populations, we can see the age at which they present at the hospital, and they is much younger, and they are free of calcific deposit, but have extensive atherosclerosis. So a positive score helps us to determine very high risk. Negative score, especially in younger patients, doesn't exclude that.
Thank you, Professor Peter. Thank you so much for your kind help. Now we'll move to the next speaker. Next speaker is Professor Ian Winkeston. He is the Professor of Therapeutic and Consultant in Clinical Pharmacology and Hypertension at the University of Cambridge and Edinburgh Hospital, Cambridge. Professor Ian is a world-renowned clinical pharmacologist, Professor of Therapeutic at the University of Cambridge, honorary consultant physician at Edinburgh Hospital, Cambridge University Hospital. He currently serves as the president of the British and Irish Hypertension Society and director of both Cambridge Clinical Trials Unit and the Office of Translational Research. With over 25 years of clinical and research experience, Professor Wilkinson has had several high-profile national cardiovascular clinical trials. His expertise focuses on hypertension, atrial stiffness, cardiovascular pharmacology, and the development of future cardiovascular therapy. Today, Professor Ian will tell us about the long-term effects of blood pressure and blood pressure variability on cardiovascular and renal endpoints, implication for clinical practice. It's a symposium supported and sponsored by Viatris. Professor Ian, the floor is yours.
Thank you very much indeed. It's a pleasure to be with you all this morning. And I'm going to talk about something which may be quite new to some of you, which is about blood pressure variability. So just while we go through disclosures, our blood pressure varies all the time, minute by minute, day by day, visit by visit, and that's normal. But in a landmark paper in the Lancet in 2010, Peter Rothwell and Peter Sever showed very clearly that if you measure that variability, then it relates to the risk of here a stroke, but also heart disease and total cardiovascular disease. So people with a more variable blood pressure have a higher risk of cardiovascular disease. And others have shown by a variety of measurements that both short-term variability in blood pressure and long-term variability in blood pressure can predict a number of events, including stroke, dementia, and heart disease. So these different measures of variability are giving us clinically useful information. Now, many people have regarded this as just noise, and therefore they've not been interested in it, and it's not made it into clinical guidelines. But I think we now have a wealth of evidence showing us that we should be looking at variability in blood pressure. And I'm going to take you through just some of the evidence about that now. So let's talk about the Ascot study. This was a landmark study done by Peter Sever, which basically showed that beta blockers were less good, and that changed practice across the world. It randomized about 20,000 patients to either atenolol or amlodipine, and you can see the add-on drugs here. And the blood pressure lowering effect of those two different regimes was pretty similar. About 1.5 millimeters of blood pressure between them by the end of the trial. But when we look at outcomes, what was clear is that if you were given amlodipine, you had a significantly reduced risk of developing heart disease and stroke, and the overall primary endpoint, once adjusted, was significantly lower by about 20% in those people given amlodipine. Now, what was really interesting is if you look at the blood pressure on treatment and relate that to outcomes, then there was no real relationship between how low your blood pressure went on treatment and event rate, apart from perhaps in stroke at people with the highest on treatment blood pressure. But certainly that wasn't apparent for coronary disease, which is slightly surprising to many people. However, if you looked at variability of blood pressure on treatment, there was a clear and consistent relationship between on treatment variability and risk of both stroke and heart disease. And that's shown here for two different measurements of variability, standard deviation and something called variation independent of the mean, which simply tries to adjust standard deviation for average blood pressure. Now, what was really interesting in that trial was that when they adjusted for the blood pressure difference between the arms, it did not account for the superiority of amlodipine. But what was apparent was that the two drugs produced completely different effects on blood pressure variability. As you can see here, for standard deviation, amlodipine reduced blood pressure variability, and it kept blood pressure variability reduced for the whole 6 years of the trial, whereas people on atenolol had a significantly higher blood pressure variability throughout the trial. And actually, once they adjusted for this variability in blood pressure, the difference between amlodipine and atenolol in terms of heart disease and stroke disappeared, suggesting strongly that the superiority of amlodipine in the trial was probably due to its beneficial effect in reducing blood pressure variability. And that has been confirmed in a number of large trials, such as ALL-AT, NHANES, and the Medical Research Council trial in older subjects, as you can see. These have all shown a relationship of on-treatment blood pressure variability to cardiovascular outcomes, confirming what Peter Sever and Peter Rothwell showed in the ASCOT trial. Now, that's a trial of 6 years. What about the longevity of that effect? And we now fortunately have data from 20-year follow-up of ASCOT. So this is 20 years after ASCOT. And remember, ASCOT only ran for 6 years. And these are data from people who were included in ASCOT from the UK, with an average follow-up of about 17 years, maximum follow-up of 20 years. And you can see of the original 20,000 people in ASCOT, 8,500 were in the UK, and roughly just over 4,000 were randomly assigned to amlodipine or atenolol, and data were available for cardiovascular events, coronary events, and stroke from UK data services. Now, the first thing to note is that effect of being less likely to have an event if you're on the amlodipine arm compared to atenolol arm stood the test of time, and 20 years later, it was still clear that you were better off being on the amlodipine arm than you were on the atenolol arm, particularly for stroke. Now, if we look at on-trial blood pressure in relationship to subsequent events, what you can see here is there is a relationship between trial blood pressure and events up to 20 years later. So getting the blood pressure controlled in the trial had a very long-term benefit in terms of reducing events. But coming back to blood pressure variability, what was very interesting was that if you look at the predictive value of blood pressure variability in the trial, and these are data that have been adjusted for average or in trial blood pressure, you can see a stronger relationship between blood pressure variability and all these measures of cardiovascular outcomes. So again, the more variable your blood pressure was in the trial, up to 20 years later, you were more likely to have heart attack and stroke. And we can look at this in a slightly different way. What I plotted here are tertiles of average systolic blood pressure and tertiles of variability, in this case standard deviation of blood pressure. And what you will notice is that if we go up the standard deviation of average blood pressure, which is going this way, then what you can see is there is an increase, but that increase is relatively modest. Whereas if we go up the standard deviations of blood pressure variability, we get big differences in risk. And if we look at the people in the red circle here, these are people in whom we've achieved target blood pressure. So target at that time was less than 140. So these people all have a systolic blood pressure less than 140. But if you are in the more variable blood pressures, which is what's shown in this circle, that accounted for 50% of all events. So these are people that we think we've achieved target, and most of us would do no more. We'd say the patient's at target, but half of all events in this trial were observed in those people who had achieved target but had highly variable blood pressure. And that re-emphasizes the importance of controlling blood pressure. And this just shows a similar plot for other measures: stroke, heart disease, heart failure, and indeed atrial fibrillation, suggesting that blood pressure variability is an important driver of all these different outcomes. And if you look at this just shows you this in a different way. This is just looking at a number of subjects who have an event in that follow-up period by categorizing them as having low or high variability and low and high blood pressure. And if you just look at the two groups in red, what you'll notice is that achieving low blood pressure but high variability, more people have events than if you have low variability but high average blood pressure. And we now are fortunate that we have renal events from the Ascot legacy. And what you can see here is even for renal events, it's being driven by both average blood pressure, but also being driven by blood pressure variability. And that's shown more clearly here, where you can see again a significant number of people who've achieved target blood pressure based on that average blood pressure are having renal events driven by blood pressure variability. So in conclusion, I hope I've shown you that blood pressure variability is an important predictor of stroke, coronary, and renal events, and that is independent of average or office blood pressure. On treatment blood pressure in trials, poorly predicted outcomes, but variability in blood pressure was a much stronger predictor of outcomes. And in the Ascot long-term follow-up study, if you're randomized to amlodipine, the benefit of being on amlodipine was seen out to 20 years for total cardiovascular events, and particularly for stroke. So what does all of this mean for us? Well, it basically means that we need to think about controlling blood pressure variability as well as controlling average blood pressure. And as I've shown you from Ascot, calcium channel blockers, and particularly those with long half-lives like amlodipine, are particularly effective at controlling blood pressure variability. And I haven't had time to show you the data comparing drug classes, but the two drug classes that stand out as controlling blood pressure variability well are long-acting calcium blockers like amlodipine and thiazide-like diuretics like chlorthalidone. And I think what we're going to see over the next 5 years is these data incorporated into guidelines telling us to control blood pressure variability as well as controlling average blood pressure. Thank you very much for your attention. And I'm happy to take any questions if there are any.
Thank you so much. We have a few questions. What is the biggest challenge in achieving stable blood pressure control? Are we focusing too much on the office blood pressure readings?
Yeah, I think that's a really interesting question. Yes, I think we need to put more emphasis in our office readings, and that could be home or ambulatory. My patients tend to prefer home readings rather than ambulatory. And I think we need to think about using drugs that have long half-lives because they produce much smoother blood pressure over a 24-hour period. But also, many patients forget to take a tablet occasionally. And if you're on a long-acting drug, that doesn't really affect your blood pressure if you miss 1 or 2 doses. If in a short-acting drug, it has a big effect on your blood pressure.
Should treatment strategies differ for patients with high blood pressure variability? What role does ambulatory monitoring play today?
Yeah, so if people are reporting highly variable blood pressure, perhaps when they're in the office or when they've done some home readings, then I think doing an ambulatory blood pressure measurement and looking at the blood pressure variability over 24 hours is very helpful. And that can help guide treatment. Might be you want to intensify treatment. Equally, if people are falling over and they've got really low blood pressure, it may be that you want to reduce treatment. But again, I'd avoid short-acting drugs and I'd avoid vasodilators like doxazosin, which can produce significant postural effects.
Thank you. Thank you so much, Professor Ian, for your kind help and support and for this amazing lecture. Thank you so much. Now we will go with the next speaker, Dr. Suhail Ashraf. Dr. Suhail Ashraf is a consultant gastroenterologist at Cleveland Clinic, Abu Dhabi. He is a highly skilled consultant endocrinologist. Dr. Suhail Ashraf is a highly skilled consultant endocrinologist with extensive clinical experience spanning over 12 years across UK and UAE. He holds a dual certification of completion from the UK General Medical Council with both general medicine and diabetes and endocrinology, alongside with a PhD and a master's degree in diabetes from Queen Margaret University, in collaboration with the University of Edinburgh. Dr. Ashraf is a fellow Royal College of Physicians and specializes in advanced metabolic health, type 1, type 2 diabetes management, thyroid disorders, and complex hormonal conditions. Dr. Suhail Ashraf will talk today about optimizing macrovascular and microvascular diabetes care. It's a symposium by Abbott. Dr. Suhail, the floor is yours.
Yeah, thank you, Dr. Silvani, for the kind introduction. Thank you for the organizers for inviting me. I take it you can hear me right now. Is that right?
Can hear you.
Yeah, please. So I'm just going to share my screen. I'm hoping that you'll be able to see the slides as well, right?
Yeah, we can see it. We can see it.
Okay, super. Thank you very much. So thank you, everybody, for joining. What appears to be a very, very informative sessions. I've been hearing to some, eminent speakers coming through. Thank you very much. Guys, my introductory talk in a moment, please.
Dr. Suhail, Dr. Suhail, your voice is a little bit. Dr. Suhail, your voice is a little bit sometimes not working well. Can you make sure of your connection, please?
Yes, the connection seems to be pretty good. Are you coming through very clearly to me? Am I audible now? Is this better?
Yeah, this is better now. You can continue. Thank you.
Okay. Yeah, great. Thank you very much. Good. So I'll be talking about the CVD burden, something that we are all fairly familiar with, and then a little bit about atherogenic dyslipidemia. We'll then talk about residual CV risk and the importance of non-HDL cholesterol. Along with that, a little bit about triglycerides as well. And then I'll be talking about prescriptions of omega-3 and the role of fenofibrate in CV risk reduction, in which I will be talking about 3 studies, landmark trials, following which I'll discuss a little bit about the role of fenofibrate in diabetic retinopathy and share the LENS trial with you. And finally, I'll very quickly summarize. Right, so let's get started. This is data coming out from the World Health Organization global health estimates, and not something which we are not very familiar with. We all are fairly aware about this, that the cardiovascular disease is the biggest killer. It has remained the biggest killer, unfortunately, despite all the advances that we've had over the period of last couple of decades. About 16% or up to 18% of patients, unfortunately, still continue to die with cardiovascular diseases. What about locally? Locally, the numbers seem to be fairly similar, but slightly on the lower side. I think the numbers are underrepresented, if you ask me. In GCC, anything in the range of 5.5 to 10.2 is what the CVD diseases are. You've had the risk factors, namely hypertension. About almost 1 in 4 person living in Middle East has hypertension. Dyslipidemia, almost 50% of the population has dyslipidemia, unfortunately. And diabetes, the rate is almost about 15 to 16%. And this is the continuum, the residual vascular risk continuum. We are aware about this, dyslipidemia, which essentially results in endothelial dysfunction. And then you've got the atherothrombotic state. Throw in hyperglycemia, throw in hypertension, and you've got a pretty heady, potent, unfortunately risky mix, wherein you have microvascular complications, macrovascular complications coming in. Just to start off with some more evidence, essentially, this is the cholesterol treatment trials, one of the biggest meta-analysis that we've known in medical evidence base. 21 RCTs, sample size of over 170,000 patients. What they showed is, despite people being on statins, a substantial residual risk still remains. And almost about 78% of the risk still continues to be lingering around, despite very good LDL reductions with statins. So that brings me to non-HDL cholesterol, something that we occasionally forget to address, essentially, because we're concentrating too much on the LDL cholesterol. Now, patients, this is data coming out from Netherlands. It's slightly old, 2012. But nevertheless, it does send a message. It is again a meta-analysis of RCT related to patients who have been on statins. Sample size was pretty decent, 62,000 plus population. What they looked at is they looked at association of CVD with HDL cholesterol, with LDL-C, ApoB, as well as the non-HDL cholesterol as well. And what they figured out is that even if the LDL-C levels are reasonably well controlled, if your non-HDL levels are slightly on the higher side, there is a 32% significant higher cardiovascular risk of having further events. And what about triglycerides as an independent risk factor? This is data coming out from Harvard, published some time ago. And what they showed is essentially the clinical correlation of triglycerides is almost similar to LDL in the form of risks to myocardial infarction and CCVD risk. So the associations is fairly strong, so to say. Two big studies, which I'd like to quote, the FIELD trial coming out in 2005 from Australia, and ECHO trial from John Buse in 2009. Basically, extensively quoted trials, very well established. 9,000 plus patients in the FIELD trial. And what they showed is that if the patient has a TG of greater than 2.30, the risk is on the higher side. And if you could bring it down using fenofibrate, there's a role of fenofibrate, then the CV 3-point MACE seems to be much better. And the numbers needed to treat roughly is about 23. Likewise, about 5 years later, a CORD trial came out, which looked at holistically decreasing cardiovascular risk in diabetic patients, and they showed almost a similar outcome where the numbers needed to treat was roughly about 20%. 20 numbers in numbers. The triglyceride is independently and significantly associated with coronary artery disease. This is data coming out from the US, fairly similar to the previous trials that we've seen, where the premature familial cardiovascular disease risk is high when you have elevated triglyceride levels of more than 200 milligram per deciliter. So essentially, we've established that Along with the LDL, the non-HDL and TGs are also of important concerns and something that we sometimes forget to address in our day-to-day clinical practice. And it's worthwhile addressing them, and there's data around that. How about the role of omega-3? Let's have a look at some of the slides. So this is the 8th guidelines coming out in 2023. And they were fairly clear that there's a role of omega-3 here. So if the triglycerides are greater than 200 or 500 or 1,000, certainly what we'd like to do is go into lifestyle changes, which we're very good at dealing with, rule out hyperglycemia, failures in the form of liver failure or kidney failure and hypothyroidism, and then addresses the matter. Look into statins, and icosapent ethyl is also useful. But if that doesn't work out, we move on to fibrates and omega-3. And there's decent evidence around that. And occasionally, we tend to give in niacin if the triglycerides levels are above 1,000. How about locally? These are guidelines formulated locally. There is some evidence of omega-3, especially in patients who have high plasma triglyceride levels, and doses of up to 4 grams a day can be given. This is data coming out from South Korea. What they really showed is that if you are on rosuvastatin versus rosuvastatin along with omega-3, what is the difference? It was a small study with kind of just about 400 sample size, but nevertheless, it did show a message which is essentially showing that if you give a combination treatment, the decrease in triglycerides, non-HDL, and even ApoB is quite significant. And they also showed that the effects seem to be proportionately higher in patients with diabetes compared to a non-diabetic population. This slide is repeated. We then move on to the Gulf Coals trial that was published recently. This was done over 5 countries and over 8 centers. Some of the big names in the Middle East were on it. And what they really showed is that even if the LDL reduction has been fairly optimal, for some reason, we haven't done well on non-HDL and ApoB reduction. So if you can see the bar chart there, the LDL reduction is up to 32% of patients having less than 150 reductions. But unfortunately, almost half of the patients seem to be still having a raised non-HDL and ApoB levels, despite all the advances and all the treatment options that we have been offering. So this study, the sample size was about 2,000 patients. Inclusion criteria was patients greater than 45 years of age, LDL-C levels were less than 1.8, and anybody who had triglycerides of more than 400 or LDL-C greater than 1.8 was excluded. So fairly well-controlled trials. And let's see what they came up with. So they came up with some numbers, and essentially what they showed was despite LDL-C targets being met, 22% of the patients did not achieve the non-HDL target, and most of the patients were on the younger side. They were predominantly male. They had higher pre-index CVD prevalence and a higher CVD event risk moving forward. The prevalence of hypertension and CKD was also on the higher side in this population. And if you were to offer the LDL-C, non-HDL-C target, and if you were to reduce it, you would confer a 25% risk reduction in CVD events moving forward. So the bottom line is what we've discussed is that the LDL-C reduction, I think we are concentrating and doing reasonably well on that, but the non-HDL-C reduction, we're probably not concentrating much on that. So that's regarding the lipids. Let me just move away and talk a little bit about diabetic retinopathy towards the final end of the talk and the role of fenofibrates. This is the Emirates Society of Ophthalmology consensus, on diabetic macular edema. And they have mentioned that there's a good role of fenofibrate and statin therapy moving forward. We are all fairly familiar with the prevalence and the incidence of diabetic retinopathy. Classically, in type 1 diabetes, it tends to occur around 5 to 6 years. But in type 2s, some of the patients are already having some element of diabetic retinopathy at the time of diagnosis, secondary to the chronicity of the disease itself. And how do fenofibrates work in diabetic retinopathy, fairly well established with lots of evidence coming through. ApoB levels, ApoA1 levels are increased as an independent risk factor for DR, which fenofibrates tend to help with. You've got the retinal endothelial cells, apoptosis, which fenofibrates tend to help with, and fenofibrates decrease the anti-inflammatory or increase anti-inflammatory activity in the eye. Two trials which I've quoted previously, the FIELD trial, the fenofibrate intervention and event lowering trial, and the ACCORD trial, which was again a call to decreasing cardiovascular risk in diabetes, have certainly showed that there's a role of fenofibrate in managing diabetic retinopathy, 31% risk reduction in laser treatment in those receiving fenofibrates in the FIELD trial, and about 36% risk reduction in progression to diabetic retinopathy with fenofibrate. So the LENS trial was done across in Scotland mainly, but it was multi-centric across the world. The sample size was roughly about 1,151, randomized to fenofibrate, 45 milligrams, and then placebo. The treatment was over 4 years, and the inclusion-exclusion criteria is mentioned quite clearly there. This is the primary endpoint. The aim was to find out the first occurrence of the composite of developing referable diabetic retinopathy or maculopathy, or treatment for diabetic retinopathy or maculopathy. The secondary outcome was time to progression of diabetic retinopathy or maculopathy, development of referral maculopathy alone or macular edema, and change in visual function or visual acuity. So let's look at the evidence base around this, or the results. The absolute risk reduction was pretty remarkable, 6.5%. The relative risk reduction was 27%, a p-value which was fairly significant. And if you could see, the lines started separating fairly early on in the trial. So in conclusion, essentially, there's decent evidence to say that fenofibrate is something that we should be using in diabetic retinopathy in patients that are coming through the door. How about the forest plot? All the bar charts, all the blocks that we are seeing are towards the left-hand side. The hazard ratios are fairly impressive. If you look at the composite endpoint, 27% risk reduction. And if you look at the breakdown of the secondary endpoints, any progression of diabetic retinopathy or maculopathy was about 26%. Exudates or blot hemorrhages reduction was about 34%, and macular edema itself was about 50%. So fairly robust numbers. That's my last slide. So in summary, we've established that cardiovascular burden is ever increasing, and fortunately, despite all the advances, the atherogenic dyslipidemia continues to remain on the rise. There is certainly a residual CV risk reduction, and despite all the advances that we've been making in controlling LDL levels, the non-HDL cholesterol is not something that we have been winning in reducing against. Triglycerides is an absolute independent risk factor for CVD. We've established that, and there's a definite role of fenofibrates in diabetic retinopathy management. Thank you very much for listening. I'll be happy to take any questions.
Thank you so much, Dr. Suhail. We'll take two questions. Question number one, do you think the treatment targets are too complex?
Yeah, Dr. Sujani, thank you for that question. Now, I think as time has moved on, all the guidelines are now beginning to get tighter with their targets. If you remember the ESC guideline that came out in 2018-19, with very high risk, we had a target of 1.4. But now they've moved on to say that the target of LDL-C is now 1. I think the reason being is we have evidence around it. The lower the LDL levels, the better the lower the risk of having cardiovascular events. But at the same time, we now have the tools to be able to drive the LDL-C levels rock bottom, and that is the reason why I think we are seeing much more harder targets.
Thank you, Doctor. Last question. Are we detecting microvascular complications early enough? And what's your advice on screening for microvascular complications of diabetes?
We are, I think we're getting better in terms of the finding out which patients are having microvascular risks. However, having said that, I think diabetic neuropathy is one of the ones which you're not very good at picking up. At the same time, urine albumin creatinine ratio is something that always doesn't happen. So though time has moved on, we have tons and tons of evidence around the risk of microvascular complications, and we have treatment options. We probably are not doing a great job in terms of identifying the risk early on.
Thank you so much, Dr. Suhail Ashraf. Thank you so much for your kind information.
Thank you very much for having me. Thank you.
Thank you. Our next speaker is Dr. Omar Kamil Hallak, who is a consultant interventional cardiologist, clinical professor at Mohammed bin Rashid University in BRU, Dubai, president of Gulf chapter of ISEVS. Dr. Omar Hallak is a highly distinguished consultant of interventional cardiologist with over 25 years of global clinical experience. He currently serves as a clinical professor at MBRU in Dubai and holds the position of president of ISEVS Gulf chapter. Dr. Hallak is uniquely American board certified in six distinct medical specialties, including interventional cardiology, vascular medicine. Prior to practicing in UAE, he successfully served as the head of cardiology in St. Francis Hospital, USA, performing thousands of complex of cardiac procedure. Dr. Omar today will talk about From Control to Prevention, Cardiovascular Protection Symposium by SINFA. Dr. Omar, the floor is yours.
Well, thank you so much for this kind introduction, and thank you for including me in this particular session. We have been talking about risk factor control, and aiming is to preventing cardiovascular events. And hopefully, well, apparently there is still a lot of room for improvement in controlling those risk factors. And I'm going to continue on the controlling the blood pressure. You already listened to previous talk about the blood pressure. I'm going to continue on the blood pressure control and from control to prevention. So I'm not able to move the slides. Here. Well, as you know, hypertension is one of the most modifiable risk factor for heart disease. About 1.2 billion people around the world diagnosed with hypertension, or not diagnosed, have hypertension. And it is one of the major causes of premature death. For some reason, is a control from your end or from my end here?
Can you control Dr. Omar, or is there any problem?
I'm not able to control the slide. I'm not able to go forward. Oh, here we go. Well, hypertension, I said, is the most common modifiable risk factor worldwide. And on average, about a third of adult population diagnosed with hypertension. For example, in your United Arab Emirates, about 30% of adult population diagnosed with hypertension. And as you can see, some other countries have even much higher number. And but in average, about a third of population have hypertension. Well, what hypertension? And that is basically, there's a lot of debate what is considered normal or when to treat. And that is kind of up to the bottom line here. The normal hypertension is between 80 to 120. That is the normal blood pressure. And up to 129 kind of become a borderline hypertension. And then after 130 and above, it becomes diagnosed as hypertension. And of course, as you can see, can go to the very severe hypertension or hypertension emergency. And of course, the other end, if the blood pressure drops too much, also another problem. So we need to stay in the green area between, 120 over 80. That is our target for our patient. Up to 130 is acceptable, and we don't need to give medication. But of course, there is kind of more personalized treatment for the patient. Some patient may need to have a little bit higher blood pressure, especially elderly, and some patient would like to aim for lower blood pressure, especially patient with heart failure or kidney failure and so on. But this is overall our target, less than 130 over 80. How to diagnose hypertension has been discussed earlier. We have to look for multiple way of to measure the blood pressure in the clinic, attended blood pressure, and then there's unattended blood pressure in the office also, and there is home reading and ambulatory blood pressure reading. Actually, you have to take all of those readings in consideration to make decision, does the patient have hypertension or not. Of course, ambulatory blood pressure have more weight of making the diagnosis, but all of those ways are helping to make decision, does the patient have hypertension or not. There's a lot of types and form of hypertension. White coat syndrome is common problem, and usually we have to do ambulatory blood pressure to diagnosis. There's mask hypertension, which is reverse to white coat. The blood pressure in the clinic is normal, at home is higher. There's nocturnal hypertension. Of course, keep in mind sleep apnea. Malignant hypertension, when the blood pressure is causing trouble, especially like in the affecting the alertness or affecting the eye or kidney or whatever. Essential hypertension, which is the most common type of hypertension, which you don't know the reason of it, most likely genetic. Secondary hypertension is not uncommon, see it once in a while, and this is most likely due to renal failure or renal problems or renal artery stenosis or endocrine. Resistant hypertension, by definition, more than 3 antihypertensive medication, one of them diuretics, and the blood pressure still not controlled. Isolated systolic, you see it most likely in elderly patient where they have stiff arteries. Diastolic blood pressure, you see it more in the young patient. Of course, you can have mix of the above. Well, the bad news of hypertension is a silent killer. Hypertension, unfortunately, is asymptomatic most of the time, and we have to clear the myth that if the patient doesn't have high blood pressure, headache, they don't have hypertension. And always have to tell and educate ourselves that hypertension is really silent, and that's the reason people don't take their medication properly. If it's causing symptoms, usually they have more compliance. But it is silent disease, unless it's very severe, more than 180 or so, but most of the time it's silent. And that way we have to be more careful of measuring it and follow up with the patient to be sure it's controlled. Hypertension, why is a bad problem to have? Because it can cause a lot of problems. Talking about the heart in particular, of course, it damages the endothelium. It can promote the atherosclerosis by doing that, and of course LVH end up with coronary artery disease, myocardial ischemia, myocardial infarction. Of course, that end up with remodeling of the heart and heart failure, and of course increase the death. In this way, also by doing remodeling and so on, increase the arrhythmia, increase the atrial fibrillation, damaging the heart valve and so on. So it's really very bad for the heart, because the heart facing the blood pressure 24/7. And if it is high, it has more work and more strain and more barotrauma on the heart. The main, of course, thing we kind of need to be aware of, the major side effect of the hypertension, of course, it causes problem from top to toes, from the brain with a stroke, from carotid arteries, including carotid artery, aorta, peripheral arterial disease. Heart, as we all know, as I mentioned earlier, includes a heart attack, heart failure, valvular heart disease, arrhythmia, atrial fibrillation in particular, and kidney. Of course, it damages the kidney and damages the artery of the kidney. So it's really, if you ignore the hypertension, the whole body will be damaged, and that the reason increased mortality. It is probably #1 cause of mortality worldwide. And if you compare patient with normotensive versus hypertensive patient, they have more survival. The patient who have normal blood pressure, they have more survival, and they have really short period of their life. They have cardiovascular disease. The one with hypertension, they have less survival, and the cardiovascular disease started early in their life, almost 7 years earlier. What is the aim of our blood pressure management? Actually, is, of course, we have to look at the number, be sure that the number we are achieving less than 130/80. But our really ultimate aim is to decrease the end organ damage. And I mentioned earlier that hypertension can cause damage from top to toe, and we need to protect all those organs from top to toe. And that is the aim of treating hypertension. Well, the disappointing news that 40% at least of patients who have hypertension not being treated, and 40% of being treated not being treated properly. And actually, there is a significant part of those in between not treated because of either not diagnosed, underdiagnosed, and the one being diagnosed, almost 40% not being treated. Actually, end up with 80% of patients with hypertension, they are not treated properly. And that is a catastrophe. We have all the means to control the blood pressures, all the medication and ways, but the blood pressure, 80% still not controlled. And that's the reason we're still seeing a lot of heart attack and stroke and kidney damage and so on. Only 20% of patients with hypertension has been controlled. There's quite a few reasons for that, of why we are not reaching the good number of patients to be controlled. In compliance with the patient, inertia of the doctors, not able to afford medication, not getting the proper medication, and so on. Well, that was the bad news. What is the good news? The good news that if you do action and bring the blood pressure down, only 10 millimeter of blood pressure reduction, you can have a 20% decreased major cardiovascular event, and 10 to 15% cardiac all-cause mortalities, 35% stroke. Look at that. It's very impressive. And decreasing coronary event 20%, and also decreasing heart failure 40%. Of course, makes sense, because if the blood pressure have too much strain on it because of high blood pressure, it will fail. So lowering the blood pressure properly, that will prevent having heart failure. Next slide. What did the guidelines say? The guidelines said you can, of course, you treat the blood pressure. You can start probably with the RAS blockers, ACE or ARBs, and start with combination therapy. And the guidelines recommend start off with combination therapy. So the European Society of Cardiology 2024, the target blood pressure 120 to 129. And they recommend to start with combination therapy up front. You can start with a low dose 2 medication and up titrated if needed, or add third medication. And single pill combination, it is strongly recommended, and probably the start with the RAS blockers plus calcium channel blockers, and it's class 1 indication. Here's a guidelines. They said is you can start with RAS, ACE or ARBs with combination with calcium channel blockers. You can start with low dose, both of them. If it didn't work, you may increase you can have a combination of their third medication, and then if it didn't work, you up titrated the medication. And if it didn't work after 3 medication, probably you have to refer to somebody who deals with the blood pressure regularly to be sure there is no secondary hypertension, and why the patient not responding. There may be some other issues going on, probably lack of compliance and so on. And so if it didn't work after 3 medication, probably the patient need further evaluation. The synergy of ARBs and calcium channel blocker as recommended as a first-line therapy with the guidelines, because ARBs or ACE that have a significant positive effect on the arteries, not only on the blood pressure reading. So it's blocking angiotensin 1 receptor that reduce angiotensin 2 mediated vasoconstriction. It decreased nitric oxide. It preserves nitric oxide, which is a vasodilator, and that is a important health factor for endothelium. Decrease the inflammation and decrease the executive stress. Calcium channel blocker, you heard a beautiful lecture earlier. It is vasodilator, reduce the afterload, decrease atherosclerosis, and also cause the venodilatation. So the combination of both good, of course, you have synergistic effect of the best. The one slide on the fixed combination therapy, which is strongly recommended by the guidelines, because fixed combination with single tablet improve compliance, because there is a number of pills alone is one of the variable for lack of compliance. If you decrease the number of the pills, the patient will more likely to take it. It becomes less expensive. It becomes more convenient for sure. And of course, by doing that, it's become reduced all-cause mortality, because patient is more likely to take the medicine and more likely to take all the medicine prescribed. And in this case, you have better outcome, better control for the blood pressure, and better clinical outcome. We talk in particular about one of the ARBs, olmesartan, if anything unique on this particular medicine. The olmesartan have one of the highest AT1 receptor binding affinity. Of course, that make it stronger than many of the other ARBs, and also have very slow receptor dissociation, and that make it more prolonged effect blockage. So by doing that, more stronger affinity and slow dissociation make it effective and have a 24-hour coverage or more prolonged effect. Comparing to other ARBs, there is olmesartan have much more stronger lowering of the blood pressure comparing to some other ARBs. Now, if you combine the olmesartan with amlodipine, as I said, it's recommended in the guidelines for ARBs and calcium channel blockers, of course, you have a significant drop of both systolic blood pressure and diastolic blood pressure if you comparing with a combination therapy versus monotherapy. And same thing if you combine it with a hydrochlorothiazide. Of course, some of the patients, you may need to use hydrochlorothiazide instead of amlodipine. Patient probably with heart failure, fluid overload, probably combination with hydrochlorothiazide may be more appropriate for the patient. And that combination with hydrochlorothiazide, olmesartan and hydrochlorothiazide, of course, will be much more effective than monotherapy, obviously. And comparing to other ARBs with combination to hydrochlorothiazide, as you can see, the other ARBs, probably this is one of the strongest combination for lowering the blood pressure, both systolic and diastolic.
Doctor, 2 minutes.
Unique benefit of olmesartan is just beyond the cough. That means is not only the lowering the number of the blood pressure. Next slide. There is data, as a study showed that it has significant lowering of the central aortic pressure, and that is very important, as you heard from the previous talk comparing to parenteral amlodipine. Next one. And also roadmap trial, which is a famous trial with 4,000 patients. It showed that olmesartan significantly decreased the proteinuria, and that means that is protecting the kidney, decreasing the damaging kidney. And olmesartan improve endothelial function by reduce vascular superoxide and improve the endothelial nitric oxide. It decreases the pro-inflammation and antifibrotic, and it decreases the data to suggest to decrease the intimal medial thickness of the carotid. Next slide. Endothelial dysfunction, of course, the mechanism of ARPS, it decreases the cell proliferation, small cell proliferation, and that decreases restenosis and decrease, of course, calcium channel blocker decrease the vasospasm, improve the microvascular flow, and improve the endothelial function and endothelial protection. Holding the plaque, this is very interesting. Olivos trial, does this. Olmesartan decrease the progression of atherosclerosis by doing all those mentioned endothelial function. And in this trial, they did IVUS, and they have olmesartan comparing to other standard of treatment was achieving similar blood pressure, and they found out after 14 months that olmesartan kind of freeze the plaque progression. The volume did not change much comparing to the standard of care, which naturally the plaque will increase after 14 months. So that what we talk about the biology, we can see it by decreasing the plaque burden. Next. Almost finished. Same slide was showing that the standard of care therapy versus the olmesartan. The olmesartan, as I said earlier, decrease the inflammation, cooling the blood vessels, so decrease the high sensitivity CRP, increase the adiponectin, which is stabilize the plaque, and decrease is the inflammation for vascular microenvironment. And then, of course, that will decrease the vulnerable plaque. Final takeaway, hypertension is the most common modifiable risk factor globally. Only small percentage of patients have their blood pressure controlled, 20% or so. Target blood pressure 130/80 or less. RAS blockade should be foundation of modern therapy with combination with calcium channel blockers. ARBs are effective, protective, and better tolerated. Starting combination therapy for the blood pressure more than 120 above normal. And olmesartan in particular have beyond blood pressure control, decrease the proteinuria, decrease the atherosclerosis progression, decrease the risk of stroke, and possibly prevention of type 2 diabetes. Olmesartan is a good medicine, effective, convenient, and beyond just lowering the number of the blood pressure. Thank you very much.
Thank you, Professor Omar. I have two questions for you. Question number one, shall we increase the single dose of medicine, or shall we start with combination therapy if the blood pressure is not controlled?
I would recommend the combination therapy. Yeah, I would recommend to start combination therapy.
Okay.
And yeah, go ahead.
Yeah, and the other question, what is the most common mistake in controlling blood pressure that most physicians usually do?
Depending on only office reading or blood or depending on so sometimes you are overestimate or underestimate the problem of the blood of the patient. And number two, the common problem is not having enough time to examine the patient thoroughly. So we kind of take wrong decision of the degree of hypertension. And other one is to evaluate the any other abnormality the patient have, because the patient have to be evaluated thoroughly for hypertension. There is a lot of comorbidity very common with hypertension. Have to be sure that the patient is completely evaluated before start the medication, because tailoring the medicine depends on the other factors. So if the patient have diabetes, for sure they have to be an ACE or ARB. If the patient have sympathetic overflow, probably beta blocker can be on board. So the most common mistake, not enough time to evaluate the patient properly.
Thank you, Dr. Omar. Thank you so much for your kind knowledge. Now we will proceed with the next speaker, Dr. Vinay Somashekar Eligar. Dr. Vinay is a consultant diabetes and endocrinology at Imperial College London Diabetes Center in Abu Dhabi. He's a UK-trained consultant in diabetes endocrinology and obesity medicine. He holds a RCP from London MRCP and CCT UK in diabetes and endocrinology with extensive international clinical and academic experience. Dr. Adhikary specialized in diabetes management, obesity medicine, thyroid disorders, adrenal and pituitary diseases, and cardiometabolic care. He serves as the chairman of Clinical Audit Committee and a clinical lead for diabetes at Imperial College London Diabetes Center and actively involved in education and research. Dr. Vinay today will talk about redefining the standard, embracing the combination treatment and dyslipidemia management, a symposium by Servier. Dr. Vinay, the floor is yours.
Thank you. Thank you. Is my voice audible?
Yes, we can hear you.
Thank you very much. And I would like to thank all the previous speakers for fantastic foundation. Last but not least, how we can utilize combination single pill therapies for managing the dyslipidemia is the central focus of my talk. And I would like to thank Servier for the opportunity to present here. So within our MENA region, we see that the burden of obesity, dyslipidemia, and diabetes is very, very high. And this is ubiquitous. And as their burden increases, the risk for MACE events like myocardial infarction or stroke exponentially goes up. With every addition of a risk, the end result of ASCVD is much higher. So we often think, how do we actually classify our patients quickly, whether they are at what risk they are, very high, high, moderate risk, or low? So for within the MENA region, we know we have had a few studies, including the PACMIA study, which very well demonstrated that most of the times what we see is very high-risk patients or high-risk patients. Of course, extremely high-risk patient is another group which we often see in complex clinics as well. So anybody with diabetes, 1 or 2 organ damage, another risk factor like hypertension or hyperlipidemia, automatically will be placed as high or very high risk, depending upon the duration of the diabetes. So it is very important that we consider most of our patients, which we see in the clinics as internal medicine specialists, as primary care physicians and endocrinologists, that we are dealing with high-risk population. So how does it all start? It starts with a lot of modifiable and non-modifiable risk factors, but the risk enhancers are predominantly family history of early onset atherosclerotic cardiovascular disease. In these patients, we had to look for, is there an evidence or anything like FH, like heterozygous FH is very common. 1 in 250 is the prevalence. Continually elevated LDL above 160 milligrams or 4.1 millimoles is a risk factor. We know that the longer the LDL is higher, the higher the risk for ASCVD. And of late, we have been testing more of the lipoprotein A, which is an independent lipid molecule, which is very atherogenic. If we compare one molecule of LPA to a LDL, LPA is 6 times more atherogenic. So it is independent risk factor, and I think therapeutics are developing in that area. CKD, metabolic syndrome, preeclampsia, premature menopause, having risk enhancers. I think recently we've seen even in the lay press that psoriasis increases the ASCVD risk by 48%. South Asian ancestry, because the genetic abnormalities contributing to hyperlipidemia is very, very high. And my colleague, Dr. Sohail, very much touched upon the hypertriglyceridemia. So it's important, where possible, we have to enhance, to look for the enhanced risk factors and address these patients as primary hyper risk patients. What we call as nowadays, we are having a new terminology like high-risk primary prevention therapies. This is where we are heading towards. And the longer we leave the unattended LDL, the more likelihood that it accumulates into an atherosclerotic plaque, making the fibrin cap thinner and eventually rupturing to cause those end organ damages that we want to prevent. So this slide is a very important one to show that how quickly you will develop an ASCVD depends upon how high the LDL has been and how quickly it has started in the lifetime. If somebody had an FH and they have very high LDL levels before they hit the second decade, the likelihood that in the next or third or fourth decade they develop an MI or a stroke is much higher if untreated. So the idea is we keep the LDL as low as possible and for as long as possible to have the cumulative LDL levels low or to below the threshold of developing ASCVD and organ damages. And the European Society of Cardiology has published the articles in 2019 on lipid management, and that has been updated in 2025 recently. And this is a chart which most of us, I think, have it in our clinics on the wall to have a quick glance and to assess our patients at what risk they fall. If I just focus upon the high and very high risk patients, you can see that in diabetes clinics, we are going towards a score system called score 2 or score 2 OP, which is for the older persons. And using that score would be very useful. And having FH, which is familial hypercholesterolemia, immediately puts somebody into a very high risk. And if the score 2 is more than 20, they're falling under very high risk. End organ damage and 3 other major risk factors put them into very high risk. So in essence, most of the times we have patients in the high and very high risk group. And this is a very important chart that at a glance can give you what is the risk and what would be our target levels of the LDL reduction needed. So the take-home message from most of the guidelines is we have to treat them earlier, treat them with better combination medications and for better outcomes. So the early we hit hard, the LDL to keep it as low as possible is what we should do. So the end effect of LDL on the risk of ASCVD is determined by both the magnitude and the cumulative duration of the exposure to LDL. And often we come across the question is how low is good and is too low bad? The answer is no, as you can keep the LDL as low as possible. And there have been several studies which have shown no negative effects on the person. What really happens in reality is that we have a population who are either high risk or very high risk, and their target has to be below the 1.4 millimoles per liter, but in a large majority of the patients, we do not reach them. The reason for that most of the times is we have a step-up approach in dealing with the LDL. We start with the lowest dose because whether it is clinician inertia or is it patient inertia, somehow the lipids don't get the same level of intensive management that it deserves. And you can see from this slide very clearly that though these patients need to be on a single pill combination or combination therapies and enhancement of their treatments to further options like PCSK9 inhibitors, majority of the patients remain in the monotherapy area with just statin therapy and doubling of the statin doses, which may take a much longer duration to get the LDL under control. And LDL control is one of the most easiest if we get to the high dose, high intensity statin with combination earlier, and within the first 3 months, we should be at target levels of their LDL. And this slide will demonstrate which of those statins are high intensity statins and compare it with the low intensity statin. As you can see, rosuvastatin at 20 milligrams is much higher. It's a high intensity statin, giving almost 50% reduction in the LDL from the baseline, comparing it with something like atorvastatin 80 milligrams. Simvastatin and pravastatin are considered as low intensity statins. And I'm sure in majority of practices, we are using either rosuvastatin or atorvastatin as the initial starting doses. And now if we just look at how we can alter the management in a quicker way to get the LDL lowered, combining a statin, say rosuvastatin with an ezetimibe in one step as a single pill combination gives the achievement of lowering the LDL by more than 50% within the first 3 months, rather than having a step-up approach, which can take prolonged duration, maybe up to 9 months sometimes, if the patient is unable to get their appointments with their doctors. So hitting it hard early gives us the best outcomes. As we know, every millimole of the LDL you reduce, the risk for the ASCVD is reduced by 22%. And this is achievable with the single pill, simple combination medications earlier into the course. And if we put all the available therapeutic agents that we can use for lowering LDL cholesterol, you can see that generally we say at least 50% reduction from their baseline should be achieved. And the second thing is, what is the target for this person? If that 50% is not able to reach their target LDL levels, then we have to implement an escalation therapy within the next 4 to 6 weeks of starting the therapy. But generally, we say that appointments might be about 3 months. So the next available opportunity for this person would be in the 3 months after the initiation. So if they're not reaching their targets, if need be, we have to escalate it to combination therapies if they're not on it already. And the next steps would be using PCSK9 inhibitors or bempedoic acid. And one of the earlier studies was with simvastatin and combining it with ezetimibe. What it showed was, in a large trial of 18,000 patients, combination of simvastatin and ezetimibe gave an extra 24% reduction in the LDL versus just the simvastatin alone at the end of 1 year. What translated is how much CV reduction would you achieve by keeping that LDL very low. 6.4% relative risk reduction in the major CV events versus simvastatin alone at the end of 7 years. So this is like, it has given us a foundation to say that combination therapies with statins is probably the way to go. And we have now large cohorts of studies. You have got on the slides 3 lines. One of them is red, which is randomized controlled trials of a median duration of 5 years. On the top line, you have the blue line, which is actually the Mendelian randomization study, which have the longest duration of follow-up of up to 52 years. What all these studies is, they sing from the same page, saying that every millimole you reduce, you're reducing the ASCVD by 22% at 5 years. The first year by about 10%. If you look at if you keep it longer, lower at the target LDL for that particular person, you are reducing the risk significantly. And this is a very good return on, you can say return on investment for longevity of their life is significant. And if we come to the crux of the issue about using a combination with rosuvastatin and ezetimibe, and a few slides will be about why we should use combination. So this was a study where they used titrating the statin from 10 to 20 milligrams versus combining the same 10 milligrams with ezetimibe 10 milligrams. And what they looked was, there was a further 4 times reduction in the LDL cholesterol when we combined rosuvastatin with ezetimibe. And that was translated to an extra 24% reduction in LDL compared to just augmenting the dose to doubling the dose. And as we know, some people may not tolerate the statins at a higher dose and they require a lower dose. But even with low dose combinations, it works significantly better in terms of the lowering of LDL cholesterol. And if we compare all the different combinations of rosuvastatin and ezetimibe with rosuvastatin on its own, I will just highlight the commonly prescribed combination would be 20-10 combination in most of our high-risk patients as an initial dose. You should usually see, if the compliance is maintained very well, a high efficacy of 63% reduction in the LDL cholesterol from the baseline. And this is what is expected within the first 6 to 8 weeks. And if need be, we can further augment it based upon the latest ESC guidelines. This was a very interesting study from South Korea, the racing trial, where they divided the patients into 2 groups. Almost 3,780 patients were enrolled. Half of them went on to using rosuvastatin with ezetimibe 10 milligrams, and the other half stayed on 20 milligrams once daily, and they were followed up for 3 years. The primary endpoint was to look at composite CV death, major CV events, non-fatal strokes at 3 years. And the key secondary point was how many of these patients were able to keep their LDL below 70 milligrams per deciliter. And what did the study outcome show was that the pink line, what you see is 10 milligrams of rosuvastatin with ezetimibe was non-inferior to a high-intensity statin in the composite outcomes for the MACE events. That means even with a lower dose, but combining it with ezetimibe gave a similar outcome as opposed to when compared to something like a high-intensity statin. And how many of them—
2 minutes, doctor. 2 minutes.
Yes. How many of them were able to keep their LDL below 70 milligrams? A large majority of the patients who were on combination of rosuvastatin 10 and ezetimibe 10 kept it below 70, and the side effects were significantly lower in the combination therapy because the most common one to cause side effect is a statin, which was at a lower dose. The reason to combine these two medications together is to make utilization of their complementary mechanism of action, where ezetimibe reduces the absorption of the cholesterol, the key ingredient to put into the liver to make LDL, and at the same time, you're also having an impact on the HMG-CoA with the statin, so the LDL production is lower. So that is a complementary mechanism that helps. So rosuvastatin, which is widely used in combination with ezetimibe, if used in the right combination, we are going to expect a 63% reduction in their LDL within the first 4 to 8 weeks of the treatment, and 4 times more LDL reduction compared to just statin up titration. We have enough evidence for confirmed CV protection with the foundation of IMPROVE-IT study, and now using a better statin and combination. And the adherence is also very much useful because there's less pill burden for the patient. So for your high-risk patients and very high-risk patients, which are most commonly seen in the diabetes clinics, it is essential that we utilize a combination therapy with rosuvastatin and ezetimibe for early reduction in those LDL levels. But large majority of them are remarkably undertreated still because of various reasons, inertia be from the clinician or from the patient. And sometimes we may not be able to risk stratify them very well, and utilizing simple methodologies and looking at who would be high risk if they have diabetes, hypertension, hyperlipidemia, obesity, metabolic syndrome, NASH, they are all high risk patients. We should immediately, you don't even have to go into a scoring system if it's not available. We can overcome this by using the right combinations, simple approach, single pill combinations, and all the guidelines are now mentioning that upfront therapeutic approach in very high-risk patients post-ACS to reduce the CV events. And instead of just using high-intensity statin as monotherapy, go with single pill combinations for good safety and better adherence. I think I have used enough of my time there, and combination of rosuvastatin will fulfill all these 3 aspects: early introduction, stronger reduction, and sustained long-term LDL goals. Thank you very much.
Thank you so much, Dr. Vinay. I'll have 2 questions to ask you. We have a lot of questions actually, but we don't have time. How do you handle a patient who had not a nice experience with the statin side effect, and now he's resistant to take any lipid-lowering medication? Okay,
it's a very valid question and a very important one. We have many of them as well, and the result of statin-induced myalgia is sometimes overstated, and we have to balance between the risk and the benefits what we can get. And if they are not able to tolerate one particular statin, try a different brand, try different combinations. We should show at least 2 to 3 different brands to be utilized or combinations to be utilized before we can actually say they're statin intolerant. And if that is the case, then you may have to use a low-intensity statin and combine them with other lipid-lowering agents like PCSK9 or small incision RNA therapy and bempedoic acid if it's available.
Dr. Vinay, when a patient is already on a statin, but their LDL is on the borderline, not bad, just borderline, do you decide to intensify or you just wait and see?
So if they're not on target, I would definitely intensify, because the benefit what we derive by intensification and getting them to their, everybody has to have personalized medicine nowadays. If we can get them to their target, we have to, and intensify, don't wait, because this prolonged high LDL is what is going to kill them, and having a lower target-driven LDL is the better approach.
Thank you, Dr. Vinay. Thanks a lot for your kind information and amazing talk. Thank you so much. Now we will have our dear friend and brother, the chairperson of the conference, Dr. Yanal Salam. Dr. Yanal Salam is the head of department and consultant internal medicine at Emirates Hospital, Jumeirah and Dubai. He's a member and fellow of the Royal College of Physician and also hold multiple postgraduate diplomas from the UK. Is deeply involved in medical education and professional development. Dr. Salam has delivered hundreds of lectures and educational activities across the region, serves as the tutor in postgraduate programs, and had a particular interest in obesity medicine, cardiometabolic health, and evidence-based clinical practice. As we said, he's a consultant and head of Department of Internal Medicine at Emirates Hospital, Jumeirah. Today, he will talk about achieving LDL-C target in high cardiovascular risk patients. It's a symposium by Amgen. Dr. Yanal, the floor is yours.
Thank you so much, Dr. Adil. Thank you. So technically, this lecture will build off what Dr. Vinoy has talked about in his previous lecture. So now we will go into it straight away. This is my disclaimer. So again, more of statistics. As we all know, cardiovascular death and cardiovascular disease is the leading cause of death globally. So if we look at the WHO health estimates in 2019, it accounted for more than 17.9 million worldwide deaths. 8.9 of them were due to ischemic heart disease and 6 million were due to stroke. Again, there is considerable rehospitalization, mortality, and economic burden for patients after MI. If you take a look here, you can see that nearly 1 in 5 patients with MI are rehospitalized from any cause within 30 days, and their average length of stay is around 5.4 days with MI. 18.1%, almost a quarter, are readmitted with a cardiovascular event, and 30% of these have a higher relative risk for all-cause death and cardiovascular outcomes, like recurrent MI, cardiovascular death, and this is after MI. Of course, along with all that, you have increased costs like medical, inpatient, emergency room, office visits, and 1 year, the average healthcare cost was $52,000 after year. So what are the gaps in clinical practice? First of all, we have a residual cardiovascular risk of around 43% of patients who had a prior cardiovascular event. Now they will have at least one cardiovascular event within 2 years. They have a failure of LDL target achievements, and these are 75, 3/4 of the patients. So imagine, and these are due to many factors, including patient inertia, physician inertia. We have a lot of troubles convincing the patient to increase their target. We at least sometimes take it a bit easy in terms of increasing the doses of medication for our patient. So again, we have suboptimal LDL testing. 73%, again, 3/4 of the patients, imagine, hospitalized for the first MI did not have a lipid test within 90 days following discharge. So patients who had a cardiovascular event are at increased risk of another event. Almost 1 in 3 will have an increased risk of another event. Hospital readmission, as you can see, we talked about this. It's very common. Mortality, this is a cumulative incidence, and this is the cardiovascular rehospitalizations. And as you can see, mortality rises steeply through the years following an acute MI, and then the rehospitalizations, they increase steeply, and then they pretty much plateau over the next years. So in the first year following an index MI, 10.2% experienced more than one rehospitalization, and of those, 15.8 had even more than 2. If we look at the Gulf, 75%, 3/4 of our patients are not receiving the recommended LDL goals, and that calls again for action. If we look at the 2025 guidelines, earlier treatment is better. So we should not wait and give a patient a trial of therapy and wait. No, in this case, it is actually recommended by the ESC guideline in very high risk patients and even extreme risk patients being treated with a maximally tolerated dose of statin. Do combine with ezetimibe, as my colleague said in the previous lecture, but if still is not at the goal, do add a PCSK9. And nowadays, even in the latest guidelines, you can start it from day one. You can start triple therapy with statin, ezetimibe, and PCSK9 all on day one post-MI to achieve the best LDL control for your patient. So if we take a closer look at Repatha evolocumab, it's our famous molecule actually that works wonders on our patients. So let's take a look a bit about the indications and study. So the indications, it's indicated for hypercholesterolemia and mixed dyslipidemia, homozygous familial hypercholesterolemia, and in patients with established atherosclerotic cardiovascular disease. So technically you can use it in primary and secondary prevention. It is contraindicated only in patients with a history of serious hypersensitivity to Repatha or any of the exits. So it's one injection. There's no titration. It's very easy to use. It's every 2 weeks. It's a single dose pre-filled auto-injector. The dose is 140 milligrams per ml. It's a subcutaneous injection. Nowadays, patients, after the rise of GLP-1s, are very familiar with these injections, so it shouldn't be an issue for our patients. Again, it can help patients with established cardiovascular disease lower their LDL and reduce their risk of MI, stroke, and coronary revascularization. It is a PCSK9 monoclonal antibody. It's recommended as a non-statin therapy with proven cardiovascular benefit when added with other therapies when LDL goals are not achieved with the maximum tolerated statin, ezetimibe, PCSK9, bempedoic acid alone, or in combination. The majority of my patients actually are outside these patients. The majority of my patients as a primary care physician and an internal medicine consultant are patients who are intolerant to statin for whatever reason. We have a lot of patients, especially Arabic patients, have a lot of resistance to statin in terms of taking it, in terms of a lot of myalgias that happen. You switch their therapy multiple times in terms of statin, and still they do not achieve their target. So I would say the majority of my patients are patients who are intolerant to statin for primary prevention. Nowadays, we're doing a lot of lipoprotein A and ApoB tests. I have a lot of Middle Eastern patients who have high lipoprotein A. Again, these patients are at high risk, and I would definitely use an LDL target of under 70, or even considering under 55 in these patients if they have a high family history, in order to keep their cardiovascular risk low. And of course, I'm talking about primary prevention and not secondary. If we talk about the 4-year trial, 84% of patients are on Repatha plus statin did achieve an LDL of under 55. It demonstrated a favorable safety profile over a median of 5 years. Again, it demonstrated intensive LDL reduction. We have the Laplace 2 study, which is a phase 3 randomized double-blinded placebo and ezetimibe control trial evaluating the efficacy and safety of Repatha in subjects with hypercholesterolemia on background statin. And here, 85% of patients showed up to 75% additional intensive LDL reduction on top of statin. This is the persistent rate of Repatha. 91% of patients actually persist with their treatment. And we see this is reflected in clinical practice. Successful self-administration rate, 95%. I never had a patient who had a problem self-administering Repatha. If we take a closer look at the 4-year trial, It was a double-blinded, randomized, placebo-controlled trial in more than 27,000 adults. The primary endpoint was a composite of time of first occurrence of cardiovascular death, MI, stroke, and secondary was the composite of time to occurrence of cardiovascular death, MI, or stroke, and the median duration was around 2.2 years. Here are the baseline characteristics, you can say. Mean was 62.5. The LDL was, the median was around 92. 81% had experienced more than one MI, and they were treated with other cardiovascular medications. Again, it reduced LDL levels. In 84% of patients achieved an LDL level of under 55 with Repatha plus statin, and 63% Repatha plus statin lowered LDL by an average of 63% in 12 weeks. For patients with established cardiovascular disease, Repatha added to a statin reduced the risk of cardiovascular events by 20% in a median of 2.2 years. And here you can see on the left, the graph shows it very nicely. There was a 20% relative risk reduction in these patients. If we look at the secondary composite endpoint, you can see a 27% relative risk reduction in MI, 22% relative risk reduction in revascularization, and 21% in stroke. So lowest is the best. And as you know, as science improves, we're getting lower and lower LDL target. So lowest is the best. There's evidence for greater cardiovascular risk reduction with Repatha, and there is no floor to benefit. Reducing cardiovascular risk by lowering LDL target levels urgently is what you need for your high-risk patients. So we'll just skip a few slides for the sake of time. Again, safety of Repatha is excellent. Usually, even in clinical practice, I have not seen patients who actually complain about any side effects of Repatha. But as you can see here, when you use statin plus Repatha in the 4-year versus statin versus placebo, they are comparable in all senses. But the difference here, as you can see, the median achieved LDL was 26 in patients with Repatha versus 89 in patients with only statin plus placebo. Adverse events led to discontinuation in 4.4 of patients assigned to Repatha and 4.2 assigned to placebo, which is pretty much similar in the same. So the conclusions is that Repatha 140 once every 2 weeks were consistently the most efficacious non-statin agent regimen, potentially allowing more patients to achieve an LDL consistent with the current guideline regimen. So don't wait for tomorrow. It's very important as primary healthcare physicians and using conferences such as these to improve our quality of treatment for these patients. So I would really advise you, if you do not prescribe Repatha, but we need to be very familiar with the indications. If you feel comfortable, prescribe it. If you don't, please refer to a cardiologist or a senior consultant as soon as you feel the patient is not achieving his correct LDL target. Sometimes we underestimate LDL targets, but please do not underestimate it. Repatha demonstrated intensive, rapid, sustained LDL reduction, 75% additional LDL reduction on top of the statins. Rapid, the LDL reduction starts after 1 week from the first dose, and sustained. So over 8.4 years over the 4-year OLE trial, there was high 91% persistent rate in these patients. Repatha has proven cardiovascular outcomes. It significantly reduces the risk of cardiovascular events and reduces the cardiovascular events risk by 20% in patients with atherosclerotic cardiovascular disease and 25% in recent MI patients. Finally, Repatha is self-administered with high persistent rates. It has 95% as the successful rate of self-administration and 91% as persistent rate in the Zerbini trial, the RW. So thank you so much. And I think I will be open to questions now. I will read some of the questions. I think we have time for just a couple of questions. So, the patient refuses a separated tablet combination. The hospital where I work is currently unable to procure the combined tablet formulation. How can I proceed further? So this is actually a very specific question, let's say. I would advise you to try to convince the patient. If I feel if we educate our patients enough, sometimes it's very interesting that the trials we show physicians like today, when you show it to a patient, you'll be surprised by how much easier it is to convince him when he actually sees real world data in front of him. So that is an option. Okay. The second option is trying high dose statin, but it all depends on your target. Is it primary, secondary prevention? Is he a candidate for PCSK9 from the start? So there's a lot of things that impact your question. But again, education is the key in all instances. Which patients should be treated most aggressively? So I would say patients that are for secondary prevention, number one, if you have a recent MI, do treat them aggressively, even if you will start them on triple therapy, meaning statin, ezetimibe, and PCSK9 from the start. That actually is an option now. Second of all, patients who are high risk, and these are more common maybe in our clinics as internists, family medicine, GPs, patients who are diabetic with at least one target organ function. So if you have a patient with diabetes, microalbuminuria is high, so do consider at least putting the LDL target under 70, and do not delay. We actually delay at all. We delay a lot in this, what we call physician inertia. So we should take care of this and educate our patients from day one. Is combining statin with fenofibrate contraindicated? No, it is not contraindicated. We have many patients who take both, but we should keep an eye on, of course, the liver function and if we have any myalgias. Okay, let's take one more question. Have a lot of questions, I think. The rest we can take. Feel free to connect with me on LinkedIn. Okay, what patients are most likely to be undertreated? So most likely, as per the statistics that we have, primary prevention patients, because we give them too much time for lifestyle measures. So you go to a patient, patients resist a lot, especially in primary, because they don't feel anything. So they go, they do, like I have patients actually who have been doing their lipid panel every 3 months for the past 5 years, and they refuse medication. And for the past 5 years, their lipid is high. And when I ask them, why are you doing the test? There's no point of doing the test if nothing is changing and you don't want to take medication. But this is how it is in some patients. And again, you know, one of these patients, when I did the lipoprotein A for her, she was doing the test for a long time. But you know what changed? I did lipoprotein A, and I had educated her beforehand that if this is high, then you have to take action. And it came back high for her. And she started actually on a statin straight afterwards. So again, education is the key. Primary prevention, we talk a lot about secondary prevention for cardiologists, for patients generally, but primary prevention is the key. Now in the new guideline, we should target patients at age 30 and above, even not 40 and is above. And cardiovascular risk calculators are calculating from 30 and above nowadays, not only 40. So thank you so much. I think we might have exceeded time. Thank you so much. I think now we have a short lunch break followed by the RCP session. which I would advise you to join right after the lunch break is finished. Thank you so much, and I hope to see you in the upcoming.